Can you hear me? Right, if you wouldn't mind just taking your seats. I'm very sorry if I'm squinting here. It looks staring straight into the sun with these lights, but anyway. Welcome, everybody. My name's John Appleby. I'm the Director of Research and Chief Economist at the Nuffield Trust. And welcome to I think it's the 12th year of the Nuffield Trust Summit. And we meet with health high on the agenda, not least globally. Coronavirus means that health is the number one news story worldwide at the moment. And domestically, health was also very high on the news agenda during the recent general election, second only, I think, to the B word, Brexit, with the main parties vying to promise more hospitals, more GPs and more nurses. I guess a welcome change from the 2017 election when the plans of all parties would have seen health spending actually shrink as a proportion of GDP. But now health spending is set to grow as a proportion of GDP, and the new government is making higher NHS spending a visible and concrete signal that we're coming out of a decade of austerity. And the Prime Minister has promised to, quote, fix social care once and for all. It almost sounds like a threat, that, but let's hope we don't have to hold our breath for too much longer on that one. So I think all this means that there's hopefully going to be a bit more space and appetite for new policy thinking on health. So welcome again. I'm sure we're going to have some great discussions today and tomorrow. I've just got a few things to say before I introduce the first session. First on housekeeping. Has everybody now clocked into the Wi-Fi? If not, it's Nuffield Trust 20 with a password of Summit 2020. And first of all, thanks to all our speakers for their contributions. Also especially our two supporters, Optum and MSD, and our media partner, the BMJ. Sessions will be live streamed and live tweeted. Please use the hashtag NTSummit if you're going to be tweeting, and I really encourage you to do so. Evaluation forms, don't have to say much more about that, do I? But we find them really valuable at the end of conferences like this to see what we can do better next time. All phones on silent, please. We'll also be using something called Slido. I'm sure you're aware of this, for Q&A sessions during sessions 3, 6 and 9. The details have been sent out to you. What I've got to say here, but as a reminder, and the details are on the screen, are they? Yes, there they are. So as an app you can download. We've also got roving mics who'd like to ask questions using their mouth rather than their fingers, as it were. And please say who you are, your organisation, national insurance number, the usual stuff. That'd be great. So that's just the house. Oh, fire drills. There's no planned fire drill. So if you do smell smoke or hear something go off, then leave the building, essentially. And just say something about the programme. We spend nearly a year going through this sort of programme, developing it and so on. And I think it's a really interesting programme this year, as ever. Lots of opportunities for interactions, discussion, no doubt some heckling as well, which would be great. It's a pleasure to have the Secretary of State for Health with us today, a bit later on today, to discuss the government's priorities for health and care. Also Simon Stevens later today in conversation with our very own Jeremy Paxman, Mark Diane, which should be very interesting. And a pleasure to welcome Professor Chris Whitty in his new role as the CMO, who's going to explore future trends in health. And we have sessions on the digital NHS, the future of US healthcare reform, new models of care, the needs of vulnerable groups, and a debate about how much inequity are we willing to tolerate in healthcare. Looking forward to that one. And finally, we also have an interactive horizon scanning session asking what issues are about to take us by surprise. It's a bit like the known unknowns and the unknown unknowns. I'm looking forward to that one as well. But before we look into the future, what about the past? What can we learn from history, and in particular the last 40 years of health policy? And as we dig down through the archaeological layers, what health policy fossils might we find? Let me introduce Nigel Edwards and Nick Timmins at this point. Sorry, I couldn't resist that one. Big welcome to Nigel Edwards and Nick Timmins. They need no introduction. And they're going to kick off our first session today. Thanks, Nigel.
Thank you. Thanks, John. Yes. Good. Thanks, John, I think. So I'm prevailed upon by my team to explore some of this. We're increasingly interested in history at Nuffield. We think, in contrast to other countries, the NHS has not got a good historical memory. And we might remember, some of you might remember Clive Smee, who was a regular attender at this event, who wrote this very interesting book on speaking truth to power. It's a shame he's not here. He'd have made a great contribution to this. But thinking back on him, I thought it was a good time to look at what have we learnt and how might we codify it. But it's quite interesting that we often talk about failure, so I thought we ought to start with some successes. And I asked my Twitter followers what they thought had been successful. They're in the same bubble as me, so they obviously came up with a list that I deeply approve of. There are quite a few more. There's also some nominations of sort of more local, what you might call street level policy, stroke centralisation, for example. Daily ward rounding even was nominated. It's notable that most of these are relatively focused. They'd all got a pretty good evidence base behind them, and where they didn't, they at least had a good theory to underpin them. And while the implementation of them was often sometimes quite complex, none of them were particularly complex pieces of policy. By contrast, the policy, actually the other notable thing is most of them are not in the last 10 years, you might notice, which we might draw some conclusions from. And quite a few of the public health lobby had probably most of them, interestingly. So the successes, the biggest public policy disaster, bar one of the last 20 years probably, was Andrew Lansley's reforms. I'm meeting a delegation from the Bosnian Ministry of Health who are coming to meet him to learn how to do healthcare reform. I'm hoping to meet them before, so that... The other noticeable thing about this is that quite a few of these have got acronyms associated with them. I don't quite know what you might conclude from this, but many of them are also the enthusiasms of what you might call policy entrepreneurs, people with a plan. They're also notably really complex. The other thing I discovered is that the closer you are to an issue, the more likely you are to think it's the biggest disaster. So dentists thought the dental contract was very bad. Junior doctors weren't keen on modernising medical careers. You probably got your own version of those. The most disappointing actually were the things that we had left undone rather than the things that we had done. So our failure to plan the workforce, the serial failure to reform social care, and the mysterious but frequently cited failure to deal with culture. So let's try and develop some analysis about what underpins what's going on here. And let's start with the design of policy itself. So we've had a theory of policy making which is a sort of like a rational choice model, but pretty much discredited now and not really much held to. We now acknowledge the bounded rationality in which you don't consider all of the options, and we acknowledge our limited sort of cognitive space to make decisions. We won't optimize as much as satisfies. The problem with overly theoretical models, like Andrew Lansley's one, which was drawn, if you remember, from the privatisation of the utility industry, is that the model may not be a very good map of the territory. In fact, in his particular case, it was a deeply misleading model for how to think about things. So I like the phrase, all models are flawed, but some are useful. And the most flawed ones, I think, are those where you're relying on theory and evidence, which has been oversimplified, distorted, or in Andrew Lansley's case, just wrong, or perhaps more fairly, transplanted from a different context in which it didn't really work. And you may remember that having designed his sort of almost axiomatic set of policies in 2006, he then sort of stepped back and went, my work is done. And despite the near collapse of world capitalism, he didn't, and the introduction of austerity, he made no attempt to adapt his model to the new circumstances. So context, that gives us a clue that in this territory, context really matters. I was struck that Simon Stevens used a similar quote to this. It's from Karl Marx. I think he knew he was quoting Marx. It's an interesting, it was an interesting reference. So context, and in particular path dependency, the way that previous choices that we've made constrain the choices that we can now make, do have a really important influence. And having due regard for that, and not trying to break away too much from that, probably, for example, explains the success of Dutch healthcare reform over the last 20 years, where despite massive changes in government and political swings, there has been a broad consensus on the underlying theory of change, the overall direction of what's of where we're going, and a good understanding of where we've come from. And the neglect of this, thinking about context and history, often leads to ideas being resuscitated or borrowed from ideas that are just not very helpful. It's also, by the way, very useful when you do go and borrow an idea to check that it is actually working in the way that its proponents tell you. I'm sure you've all been to visit sites of good practice examples from the HSJ, only to arrive and to find they're not actually doing what they said they were doing, or they've stopped doing it because it didn't work. If you simplify and ignore things, you can then, however, it does become much easier to write policy, and we end up with a sort of cookie cutter policy which works on average and therefore nowhere. We design by simplifying and departing from an understanding of context and where we've been. So. A third issue relates to sort of poor conceptualization of the problem. Often common examples here would include sort of faulty logic. We've all seen logic models where the arrows from the boxes of causation don't seem to quite work when they connect to the outputs that are being expected. Sometimes we've had a tendency to conceptualize problems as being about failures of incentives and structures and rules, when actually they're probably more about culture, behaviour, and relationships, and therefore actually somewhat out of reach of most policy instruments, except to the extent that they can do harm. A third problem here is assuming that the signals that you're sending, whether that's through prices, incentives, or policy instructions, are actually going to be interpreted and responded to in the way that you intended. You may well be dealing with rational people at the end of your policy process, but they may be optimizing, there may be other goals than the ones you think you're pursuing, or they may have to trade off goals in ways that frustrate your policy. So the voltage drop from sending out your policy to it being received can be very, very significant. A tempting response to the problems of context and complexity and heterogeneity, as I said earlier, is to simplify the issue. And a particular way of doing this that's quite hazardous is to use your personal experience as a policymaker to inform policy, which is why I think so much primary care policy over the last 15 years appears to have been designed to meet the needs of middle-aged people who commute to SW1, and as therefore tended to over-stress access and late night opening over continuity of care, for example. Another problem is to sort of design for a subset, or your idea of a subset of the group. So I think the consultant contract in 2004 appeared to be based on the premise that those consultants that weren't playing golf were doing private practice, and we therefore got a very sort of mechanistic, Taylorist type of set of policies for the consultant contract, which I think could go on our list of not great policy successes there, because of course the majority didn't fit into that category at all. The other problem is a sort of framing of the issue in a way that is sort of contested. In a way that suits the policymakers, but the problem being that they're often contested. So, for example, we need to rationalise small hospitals because of issues of safety and critical mass. And when you then go and actually look at the evidence, as people who've been to a previous summit will know from work that my colleague Llewellyn Vaughan and others have done, that the evidence is often contested. The other stakeholders have different ways of framing that problem. They may actually value other criteria over the ones that you're using. For example, they may travel times more highly than you do as a policymaker, and actually more commonly they just don't believe you. And one of the things we might look at later is the growing mistrust of experts and the way that they frame the policy questions that they're looking at. Problems with objective setting next. The list here is the objectives of the original payment by results system, and the sharp-eyed of you might notice that there are two objectives on this list that are directly contradictory to each other. One is that this policy instrument will increase admission to hospital, and the other for elective, and the other is it will decrease admission to hospital for emergency, and it's the same instrument. The other noticeable thing about this, if we were put this next to the objectives of DRG type payment systems in other European countries, they would generally have probably two objectives. Not this long list. And this list grew over time through a sort of mission creep, but also by a process in which sort of policy entrepreneurs see a successful policy and then try and attach their policy to that one. So you try and get QOF points, or you try and get into the planning guidance, or you try and get a sequin, and that becomes the objective. And when you report your impact as a lobbyist, for example, for a disease group, it's measured by how far you've managed to hang policies like a Christmas tree ornaments over other people's policies, which ends up with this problem of contradiction and indeed too many objectives, which of course massively gets in the way of implementation. This sort of competing objective problem might also explain why we can't really settle on the right size for commissioning organisations. I mean, not just because we're very unclear on what commissioning actually is and haven't really worked it out over the last 20 years, I think, but also if it's too small, it can't deal with hospitals. If it's too big, it can't talk to primary care. We can't seem to cope with a degree of plurality in that area, which is always puzzled me slightly. Let's talk about the poor design process. In 2002, Alan Milburn made a speech in which he said there are going to be radical plans to allow the private sector, charities and universities to take over management of England's failing hospitals. And the idea was called franchising. And I remember vividly Neil Mackay, the then deputy CEO of the NHS, coming to a meeting of chief executives and said, we just made this speech about something called franchising. Have any of you any idea what it might be about? We said, well, you're the deputy chief executive of the NHS, isn't that your job? So his job indeed was to retrofit a policy idea that had already been announced, but unfortunately Milburn had announced it in enough detail to actually close off some of the more sensible ways that you could have realised it. It's also another interesting example of Mary Dixon would use the phrase cargo cult quality improvement. There's also cargo cult policy in which you replicate the external appearance of something but without truly understanding the essence that actually underpins it. So there is actually something called franchising. It has got something real to it, but you've kind of hollowed it out and you've got the outward appearance of it, but you haven't got the reality. It's also a good example of a solution looking for a problem. Research by Carol Proper and others, and quite a lot of research in football of all places, suggests that poor performance is not necessarily due to poor management. And that changing the management may not have very much impact on your performance. It wasn't also clear that many of the hospitals who were failing because of poor management. It was often the system that they were embedded in. I shouldn't be too cruel to Andrew Lansley, but listening was not his strong point. So that is another hazard. We've got selective use of the evidence and ignoring findings that don't support the direction. I think we've seen in quite a lot of countries a growth in interest in policy-based evidence as opposed to evidence-based policy. So a tendency to latch on to ideas and then go and look for the evidence to support them. David Cameron and the 5,000 health visitors was an interesting example of both ignoring the evidence but also selectively using it. Ivor Crewe, in his book The Blunders of Our Government, argues a lot of this is due to the fact that scrutiny has become much less rigorous in the past. And slightly humorously, but probably quite plausibly, they cite the problem of scrutiny by PowerPoint. I don't know if those lovely slides with blue boxes on them allow you to jump over arguments that are important and ignore important things that should be talked about. So I rather like this slide. Power corrupts. PowerPoint corrupts, absolutely. And it is actually also blamed for the Challenger disaster, by the way, PowerPoint, along with the rubber rings, for obscuring what should have been talked about. The most obvious problem is short-termism around policy design is short-termism and the clamour for immediate results, and that's partly the electoral cycle. But actually, we get this even between electoral cycles because secretaries of state often change within governments and want to move things quickly, and it's quite hard to make the argument about that you need elapsed time to do all of these things. So. There's probably more things, and in the discussion we'll add to those. But there's also once you've designed your policy, you do have to then implement it. And so quite a lot of good policies do get through the hazards I've listed, but the further problems then start to come when you try and implement it. The lack of a narrative about what you're trying to do and why you're trying to do it that really is compelling and gets people behind it, it's been a feature, that absence has been a bit of a feature of quite a lot of policy. I'm going to pick on poor old Andrew Lansley again, because I just have to share this quote with you. So he was had to rush up to the Royal College of Nursing conference because one of his junior ministers had been slow hand-clapped or barracked or had a very hard time. So he met a select group of nurses to talk about his reforms, and he said this: "I'm sorry if what I'm setting out to do has not communicated itself." Right? It does strike me that if you're relying on a multi-layered policy to explain itself without any assistance, you've already lost. And so the failure to communicate the benefits, the case for change, and what needs to be done is surprisingly common. And you could argue that to some extent the 5-year forward view and the long-term plan more recently have got they're way ahead of Lansley's reforms in many ways, but the lists of things to do, they're quite conceptual, they're quite abstracted from the clinical front line, and they don't really actually seem to have a particular theory of change. And that's quite common in quite a lot of places, actually, so shouldn't pick on anyone. What are we trying to do? Are we trying to use markets? Are we trying to use hierarchies, management control? Are we relying on professionalism, or will telepathy see us through? Telepathy, not a hugely successful method, I think you'll find. Okay, there's a lot of big things. There's a long list from the business literature, of course, which many of you will be familiar with. We'll just perhaps pick a few. What's the role of the payer and the provider in this? And not being clear about that has often been a problem, and bits of the system have tended to fall over each other and compete for space. The time scale and optimism bias, the tendency, optimism bias is that thing where if you've ever written a revision timetable, and by lunchtime you'll have done geography and French, and by lunchtime you've put the washing on, had a little lie down, and started a bit of French. Right? That's optimism bias. It applies also to building hospitals. It's a common problem. I think one of the things that just the sheer logistics of doing some of these changes are not appreciated by the people who are designing the policies. I was talking to my colleague Rebecca Rosen about the process of just getting a pharmacist embedded in a primary care network, and just the mechanics of getting the people that you need in the room together means that you're starting to suffer from the same revision timetable problem really quite quickly. And particularly if those logistics also include people who've not really worked together, learning to work together and forming those relationships. Hard to compress that, and I really don't think that's fully understood. And you therefore get this sort of problem where you get a confusion in the mind of policymakers between having said they've got a policy and then it being implemented. I once overheard a conversation between the then Prime Minister's advisor and Secretary of State's advisor. The Prime Minister's advisor said, we got Foundation Trust, we've got payment by results, we've got GP commissioning, we just need to let it rip. To which the Secretary of State's advisor said, no, Julian, we've just said we've got those things, that's not the same. They're not in place. Have I given away who that was? It was some time ago. The list goes on. Inadequate resources, particularly workforce, as we know, often gets missed out. But actually, the double running, the organisational development, and the other elements of change management often get missed. We continually miss the implications in terms of workforce capital and the like. Misalignment of payment and regulation. Well, we're very familiar with the way that some of our incentives have really pointed people in the wrong direction. the problem of layers of policy, one on top of the other, that bump into each other without clearing away the mess, often gets in the way of implementation. Perhaps the most common problem, and again, we're not unique in this, although we probably, it is the case that other countries do look on in wonder at the policy laboratory that we've got going on, about the number of pilots and things that we do. They also, by the way, are absolutely staggered that we don't seem to evaluate them, or we don't run them for long enough. But that's a separate problem. But the problem of how you take a pilot to scale, and there's a big literature from implementation science on that, which we haven't time to go into now. But again, we haven't really incorporated the lessons from that, and we're still talking the language of scaling up models which are context dependent and just rolling them out. We were commissioned to look for a standard model that you could implement in acute medicine for small hospitals. And we came to the conclusion that it was a bad idea to do it, but even if you could do it, it would take 50 years of selective retirement and recruitment to be able to be implemented. So there is a sort of lack of realism here in some of this. You can't just scale up one thing into a bigger system. And then I think perhaps another problem, a lot of rhetoric of the need for culture change, but many of the policies we use to do it are sort of superficial and fail to land. One element that we all sort of know about, but perhaps doesn't receive quite as much attention as it should, is that there is something special in healthcare about having a large and powerful workforce that may have a set of values and views which are not necessarily aligned with those of the policymakers. So Henry Mintzberg talks about the concrete floor that separates the clinical front line from management, in which the clinical floor know very little about what goes on above that concrete floor. And Peter Degeling, long retired now, but social anthropologist, found that if you looked at the attitudes and approaches of doctors, managers and nurses, they were very similar between different continents, with the exception of China, if I remember rightly. And here, I'll explain this graph because it's not immediately intuitively obvious to look at. So what he would say is there are differences in views about attitudes to accountability, to the extent to which it's personal versus personal and opaque versus external and transparent, and about autonomy and about how far you ascribe to models of work which are systematized and process-driven, as opposed to more individualistic models of practice. They differ in attitudes to team, on the distribution of power, and the extent to which a clinical decision is a financial decision, and that should be thought about. And what the graph basically shows is that managers, nurses, and what he calls medical clinicians are on very different places on this graph, with unsurprisingly certain agnosticism towards the financial implications of clinical decisions amongst clinicians, and more individualistic conceptions of work, less interested in systems and processes. Managers in a slightly different place, nurses quite keen on systems and processes, much more hostile to the financial implications of. So these are really quite significant differences in where people are. Medical managers are caught often in a rather difficult no man's land between the different groups. The good news is actually over time, he found this was work that was done in the early 2000s. He repeated it again 10 years or so later, and discovered that there's been convergence, and actually there is a little bit more. There's some good news in all of that. The other problem I think we've got is the extent to which scale and complexity really causes a problem. I've always liked this diagram. This makes distinctions between, we have on this bottom axis, the extent to which we are certain that if I do A, I get B. So we have certainty about causality, and the further we come down the x-axis, the less certain we are. And on the y-axis, we have the extent to which we have agreement on values and objectives. So if we have an area where we've got no agreement and uncertainty, no agreement on objectives and uncertainty about causality, then you end up with, are you fighting a war on drugs or are you trying to decriminalise it? If you've got high agreement and high certainty, then you have a clinical guideline and you can just follow it. We might agree that hyperacute stroke unit is a good idea, but we might definitely agree that it should be my hospital, not somebody else's. So we have, and then we have high agreement and low certainty. We're all agreed that you shouldn't wait very long in an ED department, but we're not quite sure how to actually make that happen. So It turns out, unfortunately, that an awful lot of our decisions are in this sort of zone of complexity in the middle. We're uncertain about about the causation that makes things happen, and we're not necessarily agreed always on what we're actually trying to do. So there's very high levels of complexity, and the real risk here is actually using the tools from the simple rational bit at the bottom. So, and then trying to apply those to more complex things. I think one of the wrong lessons we've taken from the healthcare-acquired infection reduction that we've done is that was a quite simple list of things that didn't affect the rest of the operation of the hospital and could just be put in place. So you need a different repertoire of muddling through, of experimentation, of short cycle change, and there's an area where you do political decision making, and this is all exacerbated by scale. And the NHS is unusual in the extent to which it's an international system which is run at the scale of 55 million people. It's just not something you tend to find in other places. And scale will increase complexity. It obscures local information. It flattens heterogeneity. It ignores local context. And that's why other European systems that seem to work do seem to be better at 1 to 5 million rather than 55. So very quickly, because I'm nearly out of time, but some bits of solutions. Well, first of all, some better questions and better diagnosis might be important. More rigor in testing the questions that we're posing, and in particular fighting the emergence of groupthink. More critical thinking about the solutions as well, and in doing that, probably we would be better off to have a more diversity of disciplines and views. There's more to do to bring ideas from social anthropology, sociology, political science, organisational psychology, and even geography, which the NHS is notably very bad at. It has the approach to geography of the British Empire in the Middle East around 1920, which is drawing lines on maps that don't seem to work terribly well. Some of these people will need help translating what they write for the audiences in policy and management, however, because some of them do seem to be very keen on obscurity. I think, and we're very interested in this, and we'll talk about it a bit later, much more use of history and comparative analysis, and getting much better at learning from the past, which we've been notably poor at doing, as I said before. Better policy evaluation might be a good idea. More experimentation, appropriate devolution and clearer decision rights, designing better support for implementation, and really tricky, understanding context. And the problem here is that a lot of the literature on context isn't terribly helpful. You get frameworks like Pettigrew and Whip's one, which are all perfectly good lists, although the arrows may be as important as the boxes in many of the conversations we have. So better understandings of this. And Mary Dixon Woods argues that to do this, we actually probably need better types of knowledge. So she rather impressively wheels out some ancient Greek. So she says we have episteme, standard book learning knowledge, techne, the technical ability to do it. But she then says, well, actually what you also need is practical wisdom and conjectural knowledge and cunning. And we probably need more of that. Short, digestible synthesis of the evidence. Even your mum is not going to read your 700-page report. She might skip the methods. So bringing all of these approaches together should increase the chance that policy will work better. And I think there's a big role for those of us who are sort of engaged in this process to try and bring better evidence, combat groupthink, make sure that people are using the evidence, test that the solution fits the problems, use some of this practical wisdom, particularly drawn from people from the front line. And so I guess if we did some of that, we might not, to quote David Nicholson, be able to see the results from space, but we might get some better results closer to home. Thank you very much.
Nigel, that's great. Thanks very much indeed. Just about to open it out, but I very carefully did not know what Nigel was going to say. And I was sitting there last night thinking, so what would I list as successes rather than going through all the failures? And I sort of came up with, well, day surgery, interventional radiology, vaccination programs, old and new, And these are almost all clinical changes that have happened because medicine has changed rather than because somebody's devised a policy, except when you get to a vaccination program, there has to be a decision there's going to be a national vaccination program, so the policymakers do get involved. But it's changing medicine that has a lot of the successes rather than attempts to alter policy and structure. So we've got lots of time to talk about this. Let's,
Our panel.
well, we are distributing microphones.
Where's our panel?
Thank you very much, Claire Gerardo, GP. Fabulous talk,
This is in your brief.
as ever. But there's two things you didn't mention for the disastrous, which now have seen it so many times, which is to implement a policy, which might be a good policy, and then at some point just pull it out and try and see whether it's working, and then try and stuff it back in again. In other words, not even allowing the policy to get on. And the other one is the habit of having a fabulous service or a fabulous system and then smashing it up to pieces or putting it out for tender, which is the equivalent of smashing it up to pieces, which we again do incredibly well in the NHS, and destroy good services that have been running.
Right. So we're not up here, do I?
Yes, you need your panel, Nick.
Very
We've
nice.
lost our panel.
We have a panel. I didn't
Where have they
know what
gone?
told me we had a panel. So can we have David Oliver at your state and Sally Warren, please?
That's a great point.
I was going to say,
yeah.
maybe better briefing would help as a policy. So, why not in order? Speak.
Okay, great.
Around that way.
So, brilliant. Good morning, everybody. I'm Sally Warren, Director of Policy at the King's Fund. I suppose I have three reflections on what Nigel talked through. The first is to say, Nigel talked about 40 years of health policy. I'm 41. I was quite a precocious one-year-old, but I wasn't paying that much attention to health policy as a one-year-old. But I do have 20 years of experience, mainly in the health and care sector, but actually, quite importantly, a couple of times where I've stepped out of health and care, working in the Cabinet Office, and more recently in DEFRA. So one of my reflections will be about what we can learn from outside the health sector. So I suppose my first reflection would be it's really easy to focus on the failures. It's where you can get the giggles. It's where we can kind of feel that that's a unifying feature, is the frustration with that. But I would reflect on some of the successes. I think some of those successes are complex, but I think the fact that they have been successful has kind of meant that we've forgotten the complexity of what it took to come up with the policy and implement them. And in particular, I'd highlight some of the population health successes, which have been some of the main things that have really shifted in the last 20 years, which have been complex, but they've required quite a different type of delivery. So they've not been complex because we're changing NHS structures or payment systems, but we're trying to change people's behaviours. So teenage pregnancies, the reductions in health inequalities in the 2000s, all of that took a really complex set of change, but slightly different to really complex NHS system change. I think my other reflection is, as I was listening to Nigel, I was thinking, how much of this is just relevant to any public policy and how much is quite specific and unique to the NHS and health generally? And the vast majority is pretty general to any public policy. You'd see rooms full of lots of other, be them BEIS civil servants, environmental civil servants, all grappling with the same issues around poor implementation, optimism bias, groupthink, etc. So I was thinking, what is it that might be particularly unique about the health sector when we think about policy and how we can improve policy and improve implementation? And from my point of view, it is actually the shadow of the NHS. So the NHS is a fantastic institution, it's brilliant, and quite rightly our politicians and our public are extremely proud of it. But it does therefore cast quite a big shadow over how we approach policy. And I think of those shadows in slightly different ways. The first is it's too easy for us to default to talking about healthcare systems rather than health. So we tend to lurch towards what's comfortable, but in doing that rather than what might be more challenging, thinking about health. The second is it can be really hard for us to talk honestly with ourselves, with our political leaders and with the public about some of the weaknesses in the NHS, because it's such a revered institution. Even suggesting it might not be perfect can be seen to be kind of fundamentally undermining, and you no longer believe in the NHS. So how can we talk honestly about its weaknesses? And then the third area is I think that we can think that the NHS is unique, and therefore we don't necessarily look outside to other sectors and what we can learn. And as Nigel was going through some of the examples, I thought what was quite striking is that where we did seek examples from outside the sector, not all of them successful, obviously, it's tended to be the politicians that have looked outside, not the public service leaders and the civil servants. So is there more we can do to have the system look outside to other sectors, to other kind of horizons and contexts to be able to learn from that as well? That's my reflection.
Sally, thanks very much indeed. David Oliver.
Okay, hi. I couldn't help noting that Matt Hancock yesterday came up with a nice template for what to do about bad policy when he was talking about coronavirus, which was contain, delay, research and mitigate until the next pandemic of bad policy comes down the line. And I've had an interesting ringside seat to a lot of this because I've been 31 years an NHS doctor, 22 as a consultant, but during that time of being shop floor clinician, I worked in the old Department of Health, actually in Sally's department, at the tail end of the Labour government and the start of the coalition government. So I've seen policy making and influencing from the inside. I've tried to influence it from the outside as BGS president and vice president of Royal College of Physicians. And then more latterly, I've commented on it as a medical writer and working for the King's Fund. But throughout that, I've had the lived reality on the shop floor of what the impact of policy on what happens to patients. And I think one important thing is there is a huge disconnect between the policy wonk community and the shop floor clinicians. I could ask the nurses I work with the name of the chief nurse for England, or the doctors I work with the name of even the NHS chief exec, let alone the medical director, and they wouldn't know who they were really. And they certainly wouldn't have heard all the buzz phrases about cost improvement programs and control totals and asset-based approaches. So I think there's a real need for the people who are policy making to engage with frontline practitioners. And if you see what's happened with, for instance, the GP contract, it seems to have been an afterthought that the BMA might not be very happy with what it contained, and they might need to do some engagement at that point. So I think Nigel's point about retrofitting policies is very important. And certainly when I was working in the government, ministers would announce things, and then all the officials would be scrambling to try and put some flesh on the bones. In our briefing, we were asked 3 questions, so I'll touch on them quickly. One is, policies that I've been involved with directly or indirectly that worked well. The national programme around improving the care for people with hip fractures, clinically led, linked to national clinical audit, a community of improvement and best practice tariffs has delivered. Much the same has happened for stroke, which I'm not directly responsible for, but clinically led with standards that are credible to the front line and big data sets and sustainability. The British Geriatric Society has done a lot of work getting care home medicine on the map, the healthcare needs of care home residents. And Nigel and I, about 2013, were trying to influence the NHS 5-year view and the care home new models, because there was a set of well-referenced resources about what good looked like, that has gone into the system architecture. And another one is the focus on acute frailty. There is now a big focus on zero-day admissions, front door assessment of frail older people, an acute frailty network, a load of guidance tools. I would say to an extent, the focus on patient flow and internal delays, and to an extent some aspects of the National Dementia Strategy. There's certainly been a big focus on improving inpatient dementia care. Bad stuff, the single assessment process for older people in the National Service Framework. I'm not criticising my predecessor as the NCD, but it was very confused, and the NSF for older people, unlike the ones for stroke, heart disease, cancer, didn't really come with any resources. I spent about 3 years trying to stop Andrew Lansley's policy of not paying hospitals for readmission. It reminded me of Max Bialystock in The Producers, where he said, I invented theatre in the square, nobody had a good seat. Everybody in the health and social care community thought this was a bad idea, but he announced it, and then we had to retrofit it. And the other one that Sally may remember is that when Andrew Lansley said we wanted outcomes and not politically motivated process targets, then the officials in the DH were tasked with producing an outcomes framework for public health, social care and healthcare within about 3 months. And all they could do was cut and paste the existing outcomes. And it's not been any use to drive change at all. The failure to implement either DILNOT or the Royal Commission on Long-Term Care, I think there's one important thing here, which is sins of omission, isn't there? It's what we failed to do. And the 2 signal things we failed to do in my career are proper workforce planning. It's hardly a bloody surprise, is it? A lot of the workforce would want to go less than full-time, for instance. It's hardly a surprise that immigration policy might influence the workforce. We failed to plan, and we've complacently relied on overseas staff. And the other one is the serial failure over 25 years to come up with meaningful solutions for social care. The Care Act, which Shelley was leading the writing of, was a good piece of legislation. The Dilnot Review is good, but we haven't backed it with concrete investment. The final thing we were asked to comment on was any quick advice for anybody about policy in the future. Heed the lessons of recent history about what hasn't worked. Again and again, we keep promising admission prevention, and anybody who knows anything about the evidence base will tell you you're not going to attenuate the flow of admissions into hospital, and it's not going to save money, but we keep promising it. So, learn the lessons of history and base what you do on robust evidence. But most of all change will be subverted by the frontline professionals who are working in health and social care. And if you don't engage them right from the outset, then it won't work. And the reason things like hip fracture and stroke have worked is because the professionals are on board right from the outset and defining the standards. So I think that's the signal error, is to get that disconnect between policy and frontline clinicians and operational managers. But right, thanks.
Great, thanks. Thea.
Right, so the joy of going third is, of course, I can say I agree with absolutely everything everybody else has said. And would have said those very wise things myself, obviously. But I'd like to add just a couple of thoughts to it. One is about detail. I think policymakers either forget incredibly important detail, which is about sometimes their inability to have actually walked in the shoes of being a jobbing chief exec, such as myself, or they obsess about detail and get lost in it. And so, for example, I'd like to use two recent examples. I think in the creation of one of my genuinely policy that I love at the moment, which is primary care networks, and equally hate at the moment because of its complexity and what I'm trying to do, there seems to be no conversation about the fact that primary care are outside the NHS and they do not employ staff on NHS terms and conditions. Just a little detail, tiny, weeny detail. That means that in Leeds, where I work, where I have 19 PCNs I'm working with and supporting that will be recruiting over the next couple of years, 190 to 200 really skilled and important community clinicians could all not be on agenda for change conditions and will not be going into agencies where they're on continuity of service. Tiny, weeny detail. Second, you can obsess about detail. We can go down a rabbit hole of detail. So again, just from my current world, the aging well policy. Love it. 2-hour response. Well, I don't really love the idea of why 2 hours. Where's that come from? Haven't we learnt from 4 hours and all the excitement that brought us? But 2-hour community response, not the right community response in the right place at the right time for the right level of care. And there is already a conversation which is making me want to weep, which is when does the clock start for the 2 hours? If you're not involved in that conversation, I can only wish that you remain outside it, but it is making me want to weep. So you can obsess with detail or you can forget detail. The second thing I want to say is we think that organizations and people in organizations create transformation and embed policy. And I couldn't be more with my colleagues who've talked about workforce and bringing clinicians and workforce with you. However, we also have to bring communities with you, and you have to bring the public with you, you have to bring the citizen, the patient, and real transformation, real change about how we care, for example, for our older, frail population will come from the way in which we bring our populations with us and understand the way that change is embedded rather than anything else. So I will stop there.
Good.
Yeah, thank you very much indeed. Do you want to respond to any of that before I open it out?
Let's ask the audience.
Yeah,
They were great points. I agree with all
Okay,
of
I
them.
just reinforce Sally's point that a lot of this stuff is not unique to the NHS. It's a public policy problem more generally. Hands up. Sorry, the lights are not great.
It's
I think
Nick
that's
Black.
Nick Black.
Yeah.
Thanks. Nick Black, London School of Hygiene. I think that there are lots of examples where centrally led policies have had a great influence over the last 40 years, and some of you have mentioned some of them, so did Nigel. But looking at the title of the session, what are the lessons to be learnt? The one lesson I take away, looking back over 40 years, with all the ups and downs, successes and failures, is despite the best attempts by people in this room and our predecessors to try and devise policies at the centre, despite that, on a Monday morning, every primary care centre, every hospital opens its doors, and patients and in social care clients get managed on the whole, mostly in a pretty good way. That's not to underestimate the challenges the NHS and social care faces, which we're all familiar with. So the lesson is, despite the best attempts of policymakers, thank God the service is more resilient for the sorts of reasons that David, you were talking about, that clinicians actually get on with it despite the best attempts from the centre.
That's great.
Yeah. Although, as Claire was saying, that there are still hazards to that. The policy can reach in and cause problems. Yeah.
Yep. Andy Cowper.
Andy Cowper, HSJ and Health Policy Insight. What are the panel's reflections on the tipping point of trying to start to get a bad idea to either be understood as a bad idea or to die? I'm thinking particularly about some work which David and John Appleby and some other colleagues did on the HSJ's Commission on the Hospital Care for Frail Older People. I think we were among the first people to suggest that the policy of trying to reduce acute admissions and therefore the bed base was unlikely to bring success. And when we published that finding in 2014, it was seen as being slightly controversial. I think now it's probably not. What do the panel think is the way to achieve those sorts of tipping point moments?
Anyone have a view on that?
Well, that specific example, people who actually know stuff have been saying for years we can't continue to reduce the bed base. They've been saying for years that snapshot bed audits that tell you that people don't need to be in the beds are meaningless if you don't have the capacity in community services. The National Beds Inquiry in 2000 described the fact that unless we invested seriously in community alternatives, we couldn't keep losing beds. The College of Emergency Medicine have said it. The Nuffield Trust said it. That we needed the equivalent of 20 new DGHs by now, really. So it's not news, is it? I think the tipping point for the professionals is often the minute they hear the bloody announcement. And I think, but I'm really glad that Thea mentioned logistics, because logistics and risk registers and actually the flesh on the bones of how you implement these things in the workforce are often where they die, aren't they? But we could save ourselves a lot of bother if everything wasn't driven by ministerial vanity and the electoral cycle, because what we know realistically about the pace of change is it's going to take longer than 2 or 3 years to produce something like even an attenuation in demand for hospital beds. So,
This is an interesting example, because there's a strange process in which it appears that consensus emerges without you necessarily, a bit like the way that jokes appear simultaneously, or that Leibniz and Newton invented calculus separately. It's almost like there are things in the air, and that I'm not sure about morphic resonance. That sounds slightly woo, but it does explain what happens. It is strange, and it makes it quite hard. You know, you plug away. There is Alistair Campbell used to say that you need to, the point at which you're so bored with what you're saying, that it's just the point where people are starting to listen. And it may well be that Chris Ham's 10-year "It's All About Integration" campaign very, very successful, but I did wonder sometimes whether he wasn't starting to feel, God, I'm still saying this. And I think it's a kind of non-linear process, this emergence of a consensus and getting to a tipping point. It makes it quite hard to systematise and explain, but it probably, like Alistair Campbell said, just, the point at which you're boring yourself and you're physically sick with saying it again is just the point at which you're starting to be listened to.
I think there's an important point with tipping point, 2 points there, it's because of groupthink. So in effect, how can you make sure during the policy and implementation process you're staying open to hearing lots of different voices at different points in the spectrum and not assuming motivation for what that spectrum is? Because I think we can too often have well, of course the doctors are saying that because we're about to negotiate a new contract with them, or of course and we kind of ascribe motivation without really understanding the reason they're saying that is because their frontline clinical experience would suggest it's not that straightforward. We've we've synthesised the evidence in the wrong way and it's leading us in the wrong direction. So how we can create conversations where disagreements are not just aired but properly understood requires a different way for us to have conversations and dialogue and engagement. But that's the only way to really start to understand that divergence and kind of cut through it.
Great.
There's Nick Mays and
One over there.
Andy, is it? Andy Bell?
Hi, Andy Bell from Centre for Mental Health. Gosh, this is a big room. One of the things about working in mental health is we have an overlap of our own policies and also those of the wider NHS and health policy, and so it feels a bit federal. Perhaps we feel a bit like Britain in Europe before this year. And so we've got kind of two things often which don't align with one another and sometimes go in completely opposite directions. When we had a look at the last 20 years of mental health policies, we couldn't find one that had been independently evaluated. And I guess my interest is, what would good evaluation of policy look like? Because I think because it tends to be so political, it tends to be so politicized, we evaluate all sorts of things apart from those which really direct things. So what do the panel think good would look like? And how can we perhaps have greater alignment? Because I'm sure lots of other sectors have similar experiences.
Do we want to deal with that at the moment, or take?
Give us a minute to think about that one. Find us an
Let's
easier question, for goodness sake. We'll come back to that, yeah. And there's Nick Mays, yeah.
Yep.
Nick Mace, London School of Hygiene. This is really a comment, so you might want to turn it into a question, and it relates to one aspect which is probably endemic across public policy, which is churn and turnover among civil servants. Going back to you showed a picture of Clive Smee at the beginning of the session, and of course Clive was 17 years in the Department of Health, and he represented in a sense the antithesis of that, which is continuity. It seems to me that given that we have short electoral cycles and we have ministerial churn, there's absolutely no point chiding ministers for wanting to make announcements. But it does seem to me one of the skills of civil service and developing continuity is to always be able to have a repertoire of policy solutions in search of a minister who wants to make an announcement. In other words, a serious point, which is that if rather than being shocked and put on the back foot or having to do damage limitation when a crazy idea comes in through the SPAD sort of system, you actually, I mean, one of the tricks will be, I think, to be able to have some things that you've really wanted to do, which you can understand, and you've got some evidence base or some clinical engagement, and you can make it available. And that was something that Clive did from time to time. Particularly found a junior minister who needed to do something to bolster their career. So turning essentially what could be a problem into a partial solution. But it doesn't require continuity and expertise inside the system.
Yeah. Great point. Should just respond to Andy's point, because there is actually a whole load of method and approaches for doing policy evaluation. The problem is not knowing how to do it. The problem is wanting to commission it and then wanting to publish the results. And I remember a story of one special advisor sitting on Sally Davis's desk, shouting at her about the temerity to actually evaluate a policy that his minister had put in place, and trying to stop her from publishing it. You can probably, those of you who know Sally will probably be able to work out how that encounter ended. But I don't think method is our problem. Actually, it's a problem of will.
Do you agree with that?
Yes, but I think I'd also expand it to say I think too often with evaluation we consider that scheme to be unique, and we're cleverer, brighter, we're not going to fall in the same trap. So there's a bit about how we are all capable of engaging with the messages from evaluation and being quite honest about ourselves and how we're leading in that space. So I think it's not just how you evaluate, but how you learn from the evaluation.
That's good.
I also just wonder, as the kind of person who's been a civil servant for 18 years on the panel, whether I should just kind of comment on Nick's point. So a few kind of different reflections. One to say is that churn isn't always a bad thing. So healthcare-acquired infections is considered one of the successes of the last 20 years. I got moved onto that policy and delivery area at 24 hours notice, having had nothing to do with it at all in my career and know nothing about it. It didn't stop it being a success. I think I helped it rather than hindered it from a churn point of view. But there is a lot overall of churn, and I think the key bit becomes organisational memory, and can you learn from it? So a lot of civil servants, we will have that list of these are the policies. So if we take social care for an example, it's a long failure. There's only so many ways you can solve social care funding reform. It's not that every new team starts from scratch. Every new team is kind of learning from what's happened before, and I spend quite a lot of my time trying to explain from my perspective what's happened over the last 10 years with social care reform, what's worked, what hasn't, and I do quite a lot of that privately to help people not create the same mistakes again. So I think there is more of a willingness to learn. But some churn is good. It creates new ideas. Too much churn is bad because you don't have enough expertise and enough memory.
Can I come in? I think there's also, we're obviously talking, and this is a very eminent room where we're talking about things on a national level. As somebody who's worked at a national level, but also a lot at regional and local level, I think you shouldn't underestimate the power to shape policy from the bottom up or from that local level. And I would agree with the idea of having ideas, having schemes that are ready. Working now at a local or regional level, we'll always have schemes ready to influence those who are around us, around the way in which it's commissioned or the way in which a policy is implemented. And that's the way in which a policy and the actual implementation on the ground gets shaped by the way in which you also use evidence. I think one of my frustrations often is the lack of discussion of evidence within the chief exec leadership community. This is absolutely not saying that it isn't there or trying to be different from, but I don't think that there is enough conversation about our ability as a group to use evidence to both lobby and frame the way in which assessment and evaluation of policy on the ground is done, the scale in which it's done, the time frame in which it's done on, or indeed the intellectual framing of what it is that we're doing. And I don't think it's encouraged, but I think that there's some space that we as a community should be seizing to do that better.
And just before I come to you, just partly pick up on that. If you look at some of the successful policies, I think everyone would class NICE as a successful policy. And that was actually an odd mix of bottom-up and top-down. So, before NICE, there were the regional DECs, the evaluation committees that the regions started inventing because people needed to know what to buy in this new market and whether it was worth it. And then you had Clive Smee, who sort of took 6 weeks off and went around America, New Zealand, and Australia, and came back and said, we're off the pace in evaluating cost-effectiveness of pharmaceuticals. So you've got some stuff that's coming up from the bottom, because there's a clinical commissioning need for it, and stuff that's coming down from international evidence. And it all sort of begins to come together, and you get something that works. David?
Well, one quick resource to mention, I don't know if Chris Whitty's here, but I commend to you all a paper he wrote in 2015, I think it was, called What Would Make a Scientific Paper Useful to Policymakers, which explained really nicely why often the academic cycle is too slow for the policymakers. But I think the answer is, of course, there is a well-established methodology for policy evaluation, and the three main health think tanks do it, and academic departments of health service research do it. My question is whether anybody in government or national bodies really cares about what the findings are. And I think there's ample evidence that people repeatedly fail to learn it. And there's just one example I didn't mention that I think illustrates the problems, which is the fixation over the past decade with telehealth and telecare and digital healthcare solutions. Lansley announced that 3 million lives, no idea where he got this figure from, would be affected by telehealth and telecare. Then senior officials in the Department of Health were saying, now we know that it works. There's no excuse not to roll it out. And then when the government commissioned evaluation, Whole Systems Demonstrator, was published, the results were completely null. There is a nice framework for evaluating new technology, but again, in the creation of NHSX, there doesn't seem any particular interest in objective, empirical, peer-reviewed evidence. What's been described as digital exceptionalism, really, that the normal rules don't apply to digital. And that's why you get a company like Babylon Health getting more and more market share with government backing, or people making massive assumptions about automation and robotics transforming the healthcare and requiring less workforce. You don't see the workings, you don't see the numbers, there's no peer-reviewed evaluation, but the policy's still pushed. So I think my question is, using that as an example, is anybody that bothered about the objective independent evaluation? I suspect not.
You just have to believe, David.
It's a cult.
You've just got to believe.
It's a cult, yeah.
There was a hand up, two hands up there. Can we take those two together, one after the other?
Thank you. Crystal Oldman, and I'm Chief Executive of the Queen's Nursing Institute. My question's about nursing and nurses' involvement in policy. It's really interesting that there's been a kind of theme of it's really important to engage with the front line. The front line will inform policy. Now, nurses make up 40% of the workforce. 50% of them don't work in the NHS, so they're really good at informing around health, social care, the charitable sector, education, etc. So my question is about how do we systematically involve nurses in policy and policy development? One of the things that we do at the Q&I is to engage with those two things in terms of policy development in engagement is to ask those who are developing the policy to come and spend time working on the shadowing on the front line. That has been really impactful, including Prime Minister's special advisor. Feedback, that was the most impactful day I have ever had when he spent the day with a district nurse. So that kind of frontline informing policy, it's great, we can do it on an ad hoc basis, but how do we get systematic informing policy in a systematic way from those who make up 40% of the workforce and spend the most time with the citizens that we're supporting?
Right. Would you like to do those two together?
Thanks. Anne-Marie Rafferty, President of the Royal College of Nursing. My question was also similar to Crystal, so I'll think of a different one, which is that I guess on the question of churn in policy and the circulation of civil servants, I think they often carry ideas from one department to another, and I think that policy transfer and translational process is partly itself responsible for churn, but many of the, I think all of the panel members and speakers have referred to workforce as being one of the things that gets left behind. And I just wondered if there was a view from the panel that essentially, rather than being a last minute thought, that we should start from workforce and reverse engineer policy design and all of the implementation and evaluation processes that should underpin it.
Would anyone like to pick up those points?
Shall I kick off? So in terms of systematic involvement of the front line, I think there's lots of different ways to do this, aren't there? So actually when Jeremy Hunt was Secretary of State at the department, he instituted all senior civil servants had to spend 5 days on the front line. And I think, to be fair, that was initially greeted with a bit of scepticism as me being a polite former civil servant. But actually it did help create connection and an understanding of reality on the front line in a way that some of us as patients might get, but it was slightly different when you're there kind of almost with your job badge on. There's also been lots of examples of organisations where they've kind of deliberately put in place processes or systems to do it. So I can see Andrea on the front table. So when we're at CQC, kind of having every month a co-production approach where we would have a room full of people who are either using services or delivering services to help challenge and shape our work. So there are lots of different ways to do it. Some of the issue is about pace. So ministers wanting to kind of move really quickly can be a real issue about how do you have it be genuine co-production engagement and not a token. Then just reflection on churn and should we start with workforce? I mean, I guess maybe slightly a challenge back. Shouldn't we start with patients and the public and what they want and need from their health system? And then you work back from that. But I think too often patients and the public definitely aren't at the heart of what's driving decisions, and certainly workforce isn't. So I think there is something about how do you turn things on its head. But I would put patients and the public up there rather than the workforce.
Okay. Well, there's a lot of very eminent nurses at that table, and I think you've probably got the solutions yourself, especially some workforce experts there. So far be it from me to say how nurses particularly should be engaged. But I think, I've hosted a lot of senior officials and SPADs and think tank people actually, and some ministers spending a day with me in the service, and they do all come away having that grounded sense of how some of the policy impacts. I don't know how much good it does in the long run, but I think it is a useful thing to do. I think the question about should we start with the workforce, I think what we need to do is think about what is the core purpose of a national publicly funded, publicly provided, free at point health service. What function should it be playing? and what should specifically be provided by a health service as opposed to wider societal policy. And having defined that, what are hospitals for, what's primary care for, then you need to design the workforce around that. And then you need to look at the role of teams, about role flexibility, role substitution. Should people be working at the top of their pay grade where they're adding the most value, or should whichever member of the team has the right skills? And I don't think any of that's been done in a systematic way. But we're talking about just incompetence here, aren't we? Policies being announced where nobody has thought about the workforce implications at all. And even if you look at primary care networks, which I think are a good idea in principle, those occupational therapists and paramedic practitioners and physiotherapists, nurse practitioners have to come from somewhere. And we've already got epic workforce gaps. And if they're taken into the PCNs, then they're going to deplete local community health services. And that policy has been favoured over some other bits of the plan. So I think logistics and risk register and workforce have to be built into any bit of policy. And I think that's why I was glad that Thea mentioned logistics and feasibility right at the outset. There is an issue about bottom-up policy. You can see some things in the plan have been driven by clinical leaders. PCNs are basically primary care home, for instance, or the work on nursing homes. But there's an interesting thing about how come some initiatives catch the eye of SPADs or ministers, and something else like the fact we've got about half the number of district nurses now that we had a decade ago don't seem to be on the radar despite all the campaigning. I don't have the answer to that one.
So we have a theory that slow burn issues are harder to spot, and this afternoon session is going to explore the fact that when we actually discovered we had a workforce crisis, if you look back, we've been talking about having a workforce crisis for it wasn't really a surprise, it was hidden in plain sight. Yeah. And healthcare acquired infection was a similar thing. I mean, it was well known. Everyone said, oh, it's normal, nothing you can do about it. Falls would be another one, actually, where these problems suddenly, and it's part of this mysterious group, sort of positive group thing, where suddenly people go, oh, actually, this is a big problem and we should do something about it. And I don't think we understand how that happens. So this afternoon, one of the things we can try and do is work out what are those other things that we're sort of are hidden in plain sight, which are sneaking up on us.
Makes me think of I heard Chief Medical Officer of Scotland many years ago talk about if we saw public health crises or some of these crises as a fire, as literally as a fire, we would see them. Yeah. And of course, when we've seen Australia on fire, I think for a lot of people, the reality of certain things came home to them because you literally saw it. And that we see these problems like district nursing, which is clearly very close to my heart, creeping up, and you only get to a certain point, you go, oh my God, it's huge. Yes. And it's like, yeah, we've been telling you for years. But I do think there is a sweet spot, going back to those questions, which is about how you use the public and how you use workforce together, because we mustn't also over sort of sentimentalise our workforce and their ability to change. A lot of our workforce are quite conservative in their views, very difficult to challenge, very difficult to change, find it hard to go along pathways towards really inspirational futures. And a sweet spot is often where you get really good people from the public, you get really good users and carers, you get really good staff together with policymakers, and you develop it all together. But that's much harder than just having a good idea and going with it.
Yep.
Can I also just build from that point about language and kind of community? So there's a slight risk that how people are talking about policymakers in the room, they are talking about a special group of people who sit in Victoria Street or in Skipton House. They sit at a desk and write submissions and go and speak to special advisors or ministers. I guess my challenge to all of you is you are all policymakers. You might not be civil servants, you might not write the submission, but you're policymakers. And unless we collectively recognise, yes, absolutely the pressures you're under in terms of delivering your day job, but also the realities of how civil servants need to engage with the political system and engage with SPADs. We can't have this be an us and them thing, that it's we're all great and we know how to do good policy, it's the civil servants and the public servants that don't. So I just think there's a bit about how we can recognise we are all in this and we all bring different skills and insight to the table.
Right, we've got about a quarter of an hour left. Can I pick up some hands that have been up in order, so to speak? So Peter Smith back there and then Rebecca Rosen. I'll come to the front again later.
Thanks. Peter Smith, health economist. Sorry, I've just realised I'm listening to myself. So I just wanted to develop one issue which I think is a peculiarity of the English national health system, and that is the reluctance to look overseas, even as far as Scotland, in looking for policy alternatives, policy successes and failures. And I was struck, I was involved in teaching a master's programme to many of the students were early and middle career civil servants from the health department. And in the first week, we used to introduce a website run by the European Observatory on Health Systems, which had a huge synthesis of evidence from across Europe and beyond on health policy. And it was remarkable that almost none of those people who had been in post, many of them for a long time, how few of them knew of that website and how few of them actually had engaged with experience overseas. So I just wonder whether there's something peculiar in the UK and specifically in England that stops us looking for these really innovative solutions that can emerge from overseas and maybe not running into some of the traps that we run into by being so blinkered and self-absorbed.
Yeah. Rebecca.
Rebecca Rosen from the Nuffield Trust and also a GP in South East London. I want to reiterate the question that Claire asked right at the end of her first thing, which was we have a tendency to implement policies nationally and uniformly, and in doing so, quite often undo services that have been set up that are running incredibly well, quite often with a proven track record and good outcomes, and we just dismantle them because of the narrative of we have to do this and simplify it and once for England and all the rest of it. And I just want to know the panel's opinion about what they think about that, because with my clinical hat on, there is very little more demotivating than having an excellent service. Our example was integrated health visitors working with us in the practice across a community of 30,000 with exceptionally good and improving outcomes. Suddenly dismantled. It is so demotivating.
Yeah. Would you, I mean, those two questions interact quite nicely.
As Chief Executive of Community Trust, I have spent many, many years having brilliant services decommissioned and recommissioned. I went through the whole of the health visiting school nursing service being put out to tender and winning it, the whole of the IAP service being put out to tender, re-winning it, family practitioner nurses. So I absolutely agree that there is a real problem with that. There also can be a real challenge in a good challenge as part of it, if it's done well, but I think there is a reluctance often to look at the evidence of what's going well. We're talking about public health as well, and then you get into the local authority commissioning rules and procurement rules and how they impact on all of that. But I think, yes, broadly, it's definitely something that we suffer from and don't learn from where things are going well. Just in terms of not looking overseas, I think there's also the other part, which is that the English system gets obsessed with certain models from overseas. There was a certain time when you couldn't go anywhere without hearing about Kaiser Permanente. Yep. And that was going to be the answer to absolutely everything. Or NUCA, which actually I like NUCA, I think it's lovely. Or the New York system, etc. So you get to certain points where there are certain models which we seem to get obsessed with, as well as not looking at all. We seem to do one or the other.
Yeah. So I think several think tanks are guilty of doing shiny reports on some of those international models, so conflict of interest here. I think there is a really interesting point about where we do look overseas. It tends to be Australia, Canada, the US. We don't actually look across the United Kingdom very much. There are one or two exceptions, but more often than not, we don't. That's sometimes because we say, oh, but Scotland's gone down a different route on integration, so we can't really learn from them, as opposed to going, well, why have they gone down that route and what might we be able to take from it? So I think the kind of England versus the UK bit is something that when I was in the department, I sort of didn't really notice that we focused just on England. But then when I moved to DEFRA, and we were kind of, barely a day went by when I wasn't talking to counterparts in Wales and Northern Ireland or Scotland. It was, for me, quite an interesting kind of really bringing into sharp focus that we have traditionally focused on England only and not reached out to learn from our colleagues across the UK.
Yeah, can I just observe on that? The problem with the three-way comparison in the UK is the politicians don't want it.
No.
Because they're terrified of the answer. Yeah. And on both sides of the border, they don't really want to know whether something is going better in England than it is in Scotland, because it gets in the way. So actually, well, Nick Mays knows more about this than I do, but if you want to do this stuff, you need comparative data, and the data has been becoming more diverse, not more in common, since devolution. So it gets harder to do.
So on those, right, the thing about devolved nations, it's useful to, you might argue Scotland is slightly outperforming the other three nations, you might argue that. But what's striking is all four systems are facing the same set of wicked problems about demand and demography and workforce and overcrowding, despite the others not having a purchaser-provider split or not having the same financial instruments, which kind of makes you wonder how much of an influence policy has over some of this stuff, because they're actually universal challenges. And maybe, for instance, if we had enough beds or we funded social care properly, we didn't have the lowest number of nurses and doctors per 1,000 in the whole OECD, along with Ireland, that would be more use than obsessing about policy. But I think Rebecca's point is well taken. Rural and remote communities have very different challenges to big urban areas, for instance, and you don't want to be imposing a one-size-fits-all solution. And actually, one thing Lansley had right when he came into the DH clear-eyed, I think, was that if we focus more on outcomes and not on processes, that was the right way to go. And I'll give you one example. Imposing, I can't say anything here without offending half the people in the room, I realise, but I'll do it. Imposing GP streaming onto every emergency department in the country because it worked in Luton.
Luton.
Yeah, exactly. Yeah. That's not useful, is it? Because actually, when it's been properly evaluated, and there are two big NIHR studies ongoing now, it doesn't really work. What you should do is say, here are some key principles of what good looks like early senior assessment when people arrive in the emergency department, and then let people devise some local solutions and evaluate them properly. I spoke to one well-known chief exec here last year, and he said, well, whatever comes out in the 10-year plan, we'll kind of do what we need to do to feed the beast and demonstrate we're doing it, but then we'll do our own thing anyway. And I think that does happen. But we shouldn't be imposing templates on health economies that have already got stuff right. We should focus on the outcomes and the key bits of the process and let them do some local service design. I don't think we've got that right.
And that would, to some extent, deal with the problem that Rebecca and Claire had mentioned of having to impose a model that is you'd be able to say, well, I'm achieving the objectives of the model. But I've done it by adapting the principles, and I've replicated the principles, but I've not necessarily cookie-cutted the policy. So regional tiers so in Spain, for example, the autonomous community, to be international for a minute, autonomous communities run their own health systems and have large amounts of latitude to develop their own solutions locally. And some of the better, we've just been doing a bit of a history of the last years of regions and the SHA period, and the ones that again did that well, they didn't block national policy, but they took an intelligent approach to its interpretation and local implementation. And I think having some system to provide a bit of a block on the you have to do it this way because the policy says you must, rather than because there's a good evidence base for it and it fits your local context. It did actually sometimes have quite a useful role, and when they went, sometimes we understood what we'd missed. The observatory, for which, by the way, the Nuffield Trust is the UK correspondent, is a great repository of this. But you're quite right. Although the Department of Health do actually sponsor that, they are very, very uninterested, both in Scotland and Wales. And the only interest I've ever had from a national politician in Wales was a surreptitious attempt to get a briefing on how bad it was for use for political purposes rather than for learning. So I think there's more comparative studies of different countries, and particularly in Europe, actually, would be really quite helpful.
I think it's just also worth saying that, again, it's different in different policies. So actually in social care, I think there is much more interest from politicians and policymakers to understand what's Wales doing, Scotland, Germany, France. It's something about our healthcare system where we don't seem to look north of not quite north of Watford, but...
Yeah. Just picking up one of your bits in your earlier presentation about theory of change and picking up on Claire's point, I have slightly fond memories of the early days of the Modernisation Agency, when it was trying to help hospitals do the 4-hour A&E work.
Yes.
When it would go in and say, not this is how you do it, it would go in and say, here's a clutch of tools that other people have used that have worked for them. So you have a look at them and try and work out what would work for you, because your problems won't be identical to everybody else's. And people engaged with that and owned the solution because they'd chosen how they were going to do it, and they did adapt things. But it was quite an effective change mechanism, because it didn't say there's one size fits all and here you go. You know, you work out which of these things that have been useful elsewhere will be useful to you.
Yeah.
We've got time for about 2 more questions. Can we come down the front here and hand over there?
Both called James. Yeah.
Yep.
Ingrid.
Ingrid Wolf, Evelina London Children's Hospital and King's College London. My question is about the tipping point for policy, and I wonder if we have reached such a tipping point for patient-centred care, which seems to elude us at all times, certainly child-centred care, and it seems to exemplify quite a lot of the challenges that Nigel and others have presented this morning.
Should we take the second one?
Great. Thank you. James Morrow, GP and Cambridgeshire and Peterborough STP Board. In Cambridgeshire and Peterborough, we're living with one of the biggest national deficits. About 50 million of our structural deficit is due to perhaps failed policy decisions historically. Nigel's forensically dissected why policies may fail. The panel have elucidated evidence of policy failures. And I suppose in a slightly light-hearted way, I'd like to know what punishment the panel think is appropriate for people who fail to learn from history and repeat the mistakes of the past as policy decisions.
So I'll start with that, because it goes back to my point about collective responsibility. You're all policymakers. You're not passive people who receive directive from above. So what punishment would you like us all to collectively receive? We can all not have lunch today. We can be forced to work. But I think this is why I'm starting to say this concept of there's a group of people sat in an ivory tower and it's all their fault is not going to help us move on from here and really address the challenges we have across health and social care. So we've all got to start to recognise we've got to work in a different way, learn to listen to each other in a different way, and not do a kind of penalise and punish and blame, because in the same way that we're saying we want a culture where we don't blame clinicians, we certainly don't want a culture where we have civil servants who feel they can't speak the truth to the sector or to ministers for fear of being punished by the people sat around this room. So I'm not particularly liking some of the kind of sentiment that's sitting behind some of this sense of there's a group of people whose fault it is and the rest of us are angels.
I think there's an interaction between what you're saying around speaking truth to power, because I think in order to create culture, because I agree with you. I agree I'm a policymaker. I raised it, that we're policymakers from the ground up. But I think that there is a culture, and it's been talked about a lot by people who are trying to change culture like Purana and others, that there isn't a culture of honesty, openness, and the ability to speak truth to power. I think there's often rooms where people feel scared to talk, both to ministers, both to leaders, both to policymakers, even at very senior levels, where there is a fear of, oh, that will be, they'll say, that's not going to be good for my career. So I think there's something we have to do in order to create the environment where what we all need to do is learn and feel powerful. We have to feel confident in the room that speaking truth to power will not be career limiting in any way as well. So I think they go together. Yeah.
Well, Sally's right, of course. Culture of blame is not going to help anybody. Because we have an almost uniquely centralised, politically accountable system, inevitably lots of blame is directed at ministers and officials and senior people in non-departmental bodies in a way that wouldn't be the case in countries where there's more devolution to local managers. The person-centred care tipping point, I think if you were to go back 10... In fact, when Nigel asked the question, my challenge back was, if we were to go back 10 or 15 years, which bits of how things were like then would we want to re-embrace? Because actually a lot of things have got better. People were not talking about person-centred care, patient-reported outcome and experience measures. shared care and so forth in the way that we are now. So there's a lot of awareness, there's a lot of talk, there's a lot of focus on it. Is it a lived reality for most people using services? And such evidence as we have mean we've got a fair way to go. And I think a lot of the reason is because of the wicked problems we talked about. There's a hierarchy of priorities, isn't there? And if, as a hospital doctor working in acute care, it's getting people out of the beds as soon as possible, not having overcrowding in the emergency department, you know, trying to take the least risky option and keeping people flowing through the system. And in something like that, you're going to lose some of that low-key stuff that really matters to people and their families, especially when 1 in 8 nursing vacancies is unfilled. So I think it's the right direction of travel, but to do it better, it does keep coming back to more resource and more staff so they can actually focus on that. I've got a 28-bedded ward, and I have about 4 hours to get round it. If I happen to have my registrar with me, I can suddenly split the ward in half and she can do half and I can do half, and I've actually got time to spend with people and I can have the conversations they want to have. If I'm on call in the acute medical unit, I will see 35 to 40 new patients in a 12-hour shift, right? Well, when you're seeing people at that pace, always with your eye on the clock about the next one, knowing that the hospital, which is rated outstanding, has still got 70 or 80 beds down at the start of every working day, something's going to give, isn't it? So I think the answer is to make person-centered care a reality. People need time, and we need to actually start paying as much heed to outcome measures that matter to patients as we do to things like 4 hours and financial control totals. And at the moment, we pay lip service to it.
Well, we've run out of time. I hope you think it's been a great session. Nigel, I'll not ask you to sum up.
Oh,
just
thank goodness for
thought
that.
you might like the last word.
Yes. So lots of great points. I mean, it is worth reflecting that we had a list of successes. There've been a lot more. Quite a lot of things do work. The system is significantly better than it was 20 years ago. Bits of it may have gone backwards a bit, but it's unrecognisable in some ways. So we should probably celebrate quite a bit of success. I think people made a lot of points about the need to have a much better understanding of the sort of granularity about the front line, about what you're imposing. And I did come back, the continued question that worries me when we do look internationally is about the scale and speed with which we try and do things, and actually going slowly in order to go fast. There was some Latin tag for it, I'm sure Boris would know. It's quite a good lesson here. The second, I think, has been a real interest of mine and something for many years, is getting the research community better at articulating things that will help the policymakers. Sally's point, I think, is a very important one, and one we should leave with it. It's just even the most unsuccessful policies were done by people with good intentions. We haven't got a problem of bad people. We have a problem of inadequate systems and support, and perhaps over-ambition, either in terms of objective or speed. And we might proceed better if we were willing to question what we're doing a little bit more closely at the outset.
Great. Thank you very much, and thank you for your questions, and can you thank the panel for their contributions too? And there's coffee next door. That's why
if everybody could just take your seats.
Was it Iran? All right.
Yes.
Everyone could just take your seats. We're just about to kick off.
I've got my royal free
That would be great,
connection.
thanks.
Is at one time 5 of my family were there.
Oh, right.
2 as
So if you could just take
Who
your
is,
seats now for the next session.
patients and 3 as staff.
And
Right now, my mother-in-law works
recommence.
there.
Oh, right.
And she's the manager of the.
Great, so I'm delighted to welcome everybody back for this next part of our session. If you could just take your seats, that would be great. So thank you very much, everyone. Delighted to welcome you back for the rest of this session. I'm Sarah Scobie and I'm Deputy Director of Research at the Nuffield Trust, and I'm very excited to be chairing this session on digital policies, opportunities and challenges. I think very much building on the session this morning, there's plenty for us to think about in terms of lessons from other policy areas, other sectors, other countries. And we've got a fantastic panel who I'm going to invite in a moment to start us off. So Matthew Gould is Chief Executive of NHSX, which was established last year to drive forward the digital transformation and health and social care. Dr. James Mountford is Director of Quality at the Royal Free London, and Professor Helen Margetts is Professor of Society and the Internet at the University of Oxford, and also Programme Director for Public Policy at the Turing Institute. And so in terms of the theme for the session this morning, there's huge potential from digital, but also challenges and a gap between what's the reality for patients and staff working in the NHS from some of the hype around what artificial intelligence and digital transformation can potentially do for us. So with our panellists, I'd like to invite you to discuss the state of progress and what we want to achieve and how we can get there. After each of the panellists has spoken, we're going to have an interactive discussion. We're going to be using Slido as well as putting your hand up. So if you want to log on to Slido, then please do so. And hopefully we'll have a great discussion. I'll just first of all hand over to Matthew to start us off.
When I was a teenager, I always thought it would be really cool to end up as the leader of a cult. So I was very excited when David referred to NHSX as a cult. But having got over that initial moment of excitement, actually, I don't want NHSX to be a cult. And there's something very uncult-like about what it is and about why it was set up. It was set up 8 months ago. I published a blog yesterday setting out what we've been doing in those 8 months. But actually, at its heart, is a really straightforward notion, a very uncult-like notion, which is one of the issues which has been getting in the way of getting technology right in health and care has been the fragmentation of levers into all sorts of different bits of the centre. And fundamentally, NHSX is about pulling those levers together. We are both part of NHS England, NHS Improvement, DHSC, so we can align policies and budgets and programs and standards and so forth all in a single place. And to be clear, we are very keen that what we do and anything we support should be supported by evidence. It's why we are setting up an analytic unit precisely to do that. It's why we're helping to fund NICE's digital evaluation work precisely to do that. And one of the things I've realized in my time in the job is it's not actually the technology job I thought it would be. It's really a system job.
It's about sorting out, it's about deconvoluting some of the systems, if that's a word, some of the systems that underpin and support the NHS and social care as it tries to make use of technology. And the more I've done the job, the more I've come to the view that if we can get those underlying systems right, slightly more banal, slightly more pedestrian, actually the innovation will then happen on top of it. Because one of the things I've become really clear is that the NHS doesn't have a problem with innovation. Every bit of the system I go to, every trust, every hospital, every GP surgery is filled with innovation, people doing things, brilliant, committed people doing things in new ways, creating new ways of doing things. And we need to get the platform right so that innovation can flourish. So we've been doing a bunch of things, and I wanted very quickly to start off with just explaining some of the things we're doing so you get a sense of where our efforts are. Firstly, I wanted to start with the people side, because ultimately, actually, getting the technology right isn't about the technology. Lots of the technology we're talking about is not cutting edge, dramatically exciting technology. It's actually quite, in other sectors, very standard technology. It's about making sure the people are on side, the people have the confidence and the skills, and that the systems are supporting them. So I'm really keen that what we've called the soft stuff, but actually isn't that soft at all, giving people the skills and the confidence they need, is an area of real focus for us. And we're working with HEE to really scale up the work we're doing on digital ready workforce, and that, which is our term for all that agenda. And crucially, it's not about just the tech people in the system. I think there are a lot of people working in tech and data and analysis. I think we need to do a much better job with them in creating professions so that they have the support and the training and accreditation and kudos that they deserve and need. But I also think it's about the leadership. It's not just about the CIO and CCIO. It's about the chief executive and the board and the director of medicine and the head of nursing and so forth. And so our people work needs to focus much more widely. It's also not just about giving skills. It's about trying to hear from the front line and incorporate the views of the front line, which is when I started in the job, I actually spent a month just going round as much of the NHS as I could, listening and seeing what the ground truth was. So there's the people side. The second thing is we are starting a project which broadly call What Good Looks Like, so that we set out clear, simple criteria for different sorts of provider in the system and in social care about what good and outstanding look like in the use of digital technology now and our best guess for a few years in the future. So that there is hardwired into the way the system does things, the improvement methodology, CQC inspections and so forth, but also collectively a sense of what it is we ought to be doing. And allied to that is another piece of work which sounds incredibly banal, but I actually think is rather important, which is giving clarity around who pays for what. Because one of the things that I think has happened for good reasons, with good intentions, is there's been a series of windfalls from the centre, which has, I think, accidentally had the impact of disincentivising planned long-term investment in the underlying systems and technology and networks and hardware that are needed. So one of the things I'm really keen we do over the next few months, all of this, by the way, co-created with the system, not imposed from the centre. So we'll be launching a big consultation and trying to make sure we really have talk around what the answer is, but creating clarity around who pays for what, I think, is key. We've got a big piece of work around standards, open standards. We want to have a catalogue of open standards, whether it's technical standards so that systems can speak to each other, or standards around how things are described, whether it's sort of medicines or dosages or whatever it is, so that across the system information can flow between systems, between different types of providers, because the systems are talking and things are being described in the same way. Another thing we're doing is I'm soon to announce the appointment of a commercial lead for NHSX, because one of the things I've been struck by is across the system you have providers making big negotiations and purchases once in a generation across the table from providers who are doing these sales every week, and it's an asymmetric relationship. And so I'm keen to try and ease that asymmetry by creating a small function at the centre, working very closely with NHSD and NHSE and others to make sure that we think about what should be negotiated and paid for nationally, what should be negotiated nationally but paid for locally, and then what we expect providers to buy themselves, what help we can give them to make sure we get that right. The Secretary of State, we'll hear from later, has announced the next chapter of our provider digitisation programme, building on the global digital exemplars, is a new programme called the Digital Aspirant. So a programme to help those who weren't part of the GDE programme get to a greater level of digital maturity. One of the things that I'm really keen we do in that programme is show that the governance associated with these programs can be really light touch. There's a minimum we need to do to assure that taxpayer money is being well spent, but in particularly bits of a system that don't have huge bandwidth to devote to this stuff, I want it to be spent on getting the substance right, not on filling out endless reams of paperwork from the centre. So getting that right will be really key. And then just to say, we are also working, part of our remit is emphatically in social care. So we've set up a team to look at what we can do in social care. And crucially, I think, again, the focus needs to be on standards so that information can flow between health and care and in the sector. So we can try and break down some of the silos between the two. All of this is really in the category of fixing the basics, making sure that we respond to the concerns that I and colleagues have heard from the system about the lived experience of technology. In some places, there's some brilliant practice. Too much of a system, there are long login times and real frustration with the technology that people have to deal with. And so the things I've described, I hope, over time, will address some of that. I think it's completely necessary we do that, so we bring staff with us and tackle the things that people in the NHS and care actually worry about when they think about technology. I also think, though, it's not an either-or, do the basics or do the cutting-edge stuff. We have to get the things I've described right if we are to create a platform on which innovation can flourish. And I think if we can do the things I've described, you start to build a foundation on which the potential benefits of technology can really start to be felt. And before I finished, I just wanted to mention, in particular, I've been asked to mention the potential of AI, where, as ever with these technologies, there is a huge amount of hype. As ever, we tend to overestimate the short-term impact and underestimate the long-term impact. But where I do think it is striking that the more mature AI technologies, the more proven, peer-reviewed technologies have the potential to have an impact in some of the areas where there is most clinical pressure and strain in the system, and where we've been given £250 million to set up an AI lab, and where there are two elements of it I wanted to pull out. One is a fund to take some of the technologies that have been proven or have demonstrated themselves in individual locations and scale them to 6 or 8 locations so that we can start to build a proper evidence base more widely and show that or test whether they work in more than just the one location. And then the second element is making sure that we have a proper regulatory frame around this. So one of the things I did recently, one of the advantages of NHSX is we have a convening power. So I convened the chief execs and heads of all the 14 regulators and agencies involved in AI regulation, including MHRA and CQC and in a range of others. And we spent half a day working out a plan for how we make sure there is the right frame of regulation around this so that both staff and professionals, citizens, and indeed innovators can have confidence that what they're doing is being done in the cover of sensible regulation. Final thoughts. None of this will work if tech is seen as something separate. If tech is seen as something for the IT department and everyone else can just get on with their job, it will fail. The potential of technology to help deliver better outcomes in health and care will only be fulfilled if it is absolutely integrated, as it is to the long-term plan, as it will be to the people plan, to what NHS England is doing on outpatients and so forth. If in every bit of the system, the digital element isn't seen as something separate, but is owned by the board and the chief exec and the director of medicine just as much as it is by the CIO and the CCIO. And then the final thing I'll say is, please, I want this to be a conversation. I really don't want to sit in Skipton House and tell everyone what the answers are. I think that would be a catastrophe. So we will be fanning out around the system. I will continue to be spending as much of my time as I can on the road. I am really keen to hear not just from the enthusiasts, but from the skeptics, and I am entirely confident that I will be very shortly.
Thank you very much. James, do you want to share your reflections?
Thank you. So I look around the room, which does seem to get bigger every year at this event, and I see lots of Tara in the front here who know a huge amount about digital, so I'm looking forward to getting a good conversation going. A couple of things struck me from a perspective on the ground at the Royal Free. So I guess picking up, Matthew, on your points in particular about tech not being separate and people. So I want to talk a little bit about utility, bringing benefit, meeting a need. I want to talk about timing and the link of digital into some care redesign and improvement work that we're doing. And I want to talk about patients as well as our staff. And I guess so we are one of the first wave of the global digital exemplars, and there's some digital stuff that's quite new that we are, I think, seeing great benefit from and rightly proud of. But equally, if any of you have been a patient at the Royal Free recently, or I was just saying to Matthew, a couple of his relatives work at the Royal Free, and the daily experience is not necessarily compatible with the status of as a global digital exemplar. So getting the basics right is really, really important. How is this useful to our caregivers? So we see digital as one of three really big themes, the other two being good management and clinical leadership, and embedding a method of continuous improvement with care redesign. So digital and those other two as the ways in which we are trying to improve care. You'll find we're in the process of upscaling much of the digital across our hospitals. We have several and they're at different stages. But people now are able to go to their clinic and have all their systems working within a minute rather than 15 minutes early. You have to go in order to fire up 12 systems and 6 different screens. And then you code your notes 4 times, one for the letter to the GP, one for the patient record, one for your research database. So this type of integration, to your point about standards, one of the really big things for our staff is about a single sign-on. So you tap your card and that signs you into all the things, and that's partially there, it's not fully there. Clinical risk, patient safety, so certain risks that digital can bring, such as prescribing the wrong drug from a digital drop-down menu, but you can be sure that you're looking at the right patient's x-ray. For example, you can be sure that you're prescribing the right drug and the barcode scan for it. Although I first did my first medical job
almost half my age ago in Winchester Hospital in 1998. And I can remember being able to prescribe from the doctor's mess there in a way that's only just coming to some of our services now. So that's quite interesting if you think about the 20 years of digitisation outside. Vital signs being coded straight into the record, that links to the ability to predict and to spot risk. Many of you might have heard about our relationship at the Royal Free with Google and the Streams app. So the Streams app looks at one condition, acute kidney injury, which is essentially the marker for it is a biochemical disturbance. And that's all about getting it's not actually AI, that's about getting the right information to the right person so that that condition can be prevented, or at least further progression of it can be prevented. And you get the rather nice situation where the renal registrar through the Streams app is reviewing the patient before the home team might know that there's anything wrong. So that's an example of meeting a staff and a clinical need. The information is sitting there in our results, but previously hasn't been available to care for the patient. So that's now flagged to the mobile phone of the relevant clinician. So we're trying to stop wasting people's time and stop wasting their spirit through better digital. Another thing we're doing at the Royal Free is redesigning pathways, and we have these things called clinical practice groups, which are redesigning pathways for our big pathways of care. So hip replacement, a standard birth. We do a lot of hepatobiliary work. So about 70% of our clinical volume is going through the clinical practice groups. And one of the things we're doing under the GDE is digitizing those pathways, 20 in the first instance. And if our orthopedic chief was here, he would tell you, and they're a pretty hard crowd to please, the way in which he's able to order a set of pre-op workups and plan to the admission is now literally at the touch of a couple of buttons, whereas previously that would take him 15 to 20 minutes. But the really important thing, I think, is about digitizing this at the point at which you have had your clinical teams redesign the care to the new pathway that you want. So if you bring in the digitization before you have got the momentum and the agreement around standardizing the pathway and embedding a method to improve it, then you could be really stuck, because what you'll do is, rather than hardwiring in the things that you make it easy for people to do the things you want them to do, you hardwire in the variation rather than taking it out. And I mean, the thing which is most spectacular to me actually around this in dermatology, and this is your example of simple technology actually. So we still have access challenges, but dermatology spots, we have a high volume, and the waits used to be in the 30s, 40s of weeks, and they're now down to 4. By changing the pathway, this was patients in consultation with the staff who are doing the pathway coming up with these ideas. And if you're referred now, rather than come to clinic with your spot, you go and see a medical photographer. Perhaps in future you can just take it on your own phone. And then that is reviewed, and the number of people who actually go to a clinic is now only 1/5 of what it was before. So that's a kind of magnitude of improvement that I find just staggering. A couple of things about patients. So, and again, on the theme of simple technology. So we've been working with an outfit called Care Opinion. I don't know if anyone's in the room from there, but what they do is they essentially take feedback and promote conversations. It's all web-based between clinical teams and the patients who are looking after them. And we've done a pilot in our neuro rehab unit, which we want to extend. But the richness of this qualitative feedback, so the patients are commenting, the staff can clarify, they actually measure the uptake in the number of conversations that get created, and then those conversations get put into the team meetings and into the pathway design work that they're doing. And I think, if you offered me a binary choice between ratings, quantitative ratings, and this sort of dialogue, so you can only have one or the other, I would take the dialogue every time. So I'll probably stop there. There are loads of challenges. Not all of our staff are at the same level on the adoption curve. Many people feel slowed down rather than sped up. Probably everyone knows, about the link between burnout and digital. But I think, I feel like we're in the foothills, but we're on the way. And I guess lastly, I totally agree with Matthew's point about just the link into wider operations. So when we no longer talk about digital is perhaps the time when it's really come of age.
Thanks very much, James. And Helen, if I could ask you to give us a perspective from outside the health bubble.
Sure. So I'm not a health specialist, I'm a political scientist actually, so I was very pleased to hear Nigel Edwards utter those words earlier, but I do realise that anything I say is going to be treated with suspicion. But I am an academic researcher who's always focused on the relationship between government and digital technology since the days when that was really quite a sad and lonely thing to do because nobody was interested in it. And I'm sure I know the same was the same in healthcare as well. And when the latest generation of data-intensive technologies came along, machine learning, agent-based modeling, and what has come to be called AI, although that is quite often referring to some kind of snake oil. So we do have to be careful with that, although the Turing Institute is now the National Institute for AI. So of course, we do use that, we use the term while having a bit of a health warning on it. Anyway, when this latest generation of technology came along, I was very keen to try and think of ways in which government as a whole could have a better relationship with the latest generation of technologies than it has with earlier ones. And I wanted to share a bit of that experience to see if it was of interest here. I should say before I start, just to reinforce the point that Matthew made about seeing technology as something separate. Nothing that I can say about kind of things that we are doing, things that we are working on with policymakers outside health, can have any relevance unless there's domain expertise. And that's what health professionals and policymakers, as somebody has accurately described the room, have. And that's a very important point to make. Actually, no technology works in that way, but particularly with data-intensive technology, you need that domain expertise. So we set up the public policy program almost 2 years ago now, with the aim of thinking about how technology could make for better policy making, more equitable resource allocation, more efficient public services, and also how we could build an ethical framework to allow technology to flourish in achieving those objectives. That's because before we started, we went around government talking to literally hundreds of policymakers across departments and agencies to find out what they were interested in and what they were worried about with the idea of data and technology. And at least half people's kind of interest and concern were about the ethical, moral, normative issues of using data and using technology. And we felt that that was very important. There's a real sense, and this partly comes from the engineering world, the idea that ethics is a sort of something to stop you doing things. And I think it's certainly in the engineering, maths, computer science world, it is really important to sort of reinvent ethics and the idea of an ethical framework as something which facilitates and which allows things to happen in an ethical way. One of the things we discovered early on was the possibility of read across here in this area, that there are sort of generic things done in policy making and service delivery that AI can help with. And that is perhaps why there's a read across from outside the NHS to here. I'll give you an example of that.
British government, as most governments really, thinks about things in quite a siloed way. And we discovered that in BEIS, the Business Energy Department, they were thinking about how to identify people at risk of fuel poverty. And their automatic sort of way of thinking about that was to go somewhere else in the department and use a model, a predictive model, which came from the need to identify startups with a potential for high growth. Now, if you think about it, that's not a good place to go. The questions are different. Apart from anything, it's a sort of organizational thing rather than an individual thing. Yet, lots of agencies, including in the NHS, are working on good, innovative ways to identify vulnerable groups. So DWP would be doing that to identify people at risk of food poverty, of not having enough food. Communities and local government department is looking at ways of identifying who's vulnerable to homelessness. At the Turing, we have a project on modern slavery, looking at, with the Home Office, looking at where people might be vulnerable to exploitation. So that's something that a lot of agencies want to do, and it's something that predictive models might be able to help with. Anyway, I guess our experience has kind of led to three things that we're concentrating on, where we feel that there's the most early possibilities, and I'll give you a couple of examples of that. So one of them is simulation and evaluation. I've heard policy evaluation mentioned a lot of times here. And I think methodologies which involve agent-based modeling, a methodology, after all, that has a very, very long history in economics, goes back to the 70s, as indeed does AI in the expert systems field, but never worked very well because it was based on very small quantities of data, so it was really a kind of toy modeling system. Is something that can be used to simulate public policies before actually putting them into action and experiencing unintended consequences. It's a way of modeling that uses actual data rather than rules about how all the agents in a system are going to behave. We have a project working with police forces looking at how we can model the consequences of different levels of police resourcing without actually experiencing kind of basically not having enough police, which of course is another way of doing it, and has been tried, of course. And of course there is a great potential read across there for health agencies in terms of what they might, what health agencies might do with agent-based modeling and the question of resources. The second thing is measurement, detection, and prediction, which is what you have the potential of getting from machine learning technologies. And after all, a lot of people say that AI is either machine learning or PowerPoint. And of course, machine learning is being used in all sorts of ways. We have a project looking at hate speech, for example, how to measure and detect hate speech. A lot of read across there for the possibility of detecting misinformation and networks of misinformation, like the anti-vax movement in the health field. So a lot of possible read across there. Lots of cases of where machine learning is being used for measurement and detection, again, of vulnerable groups. But then there's the question of prediction, risk-based models, which a couple of people have mentioned, to predict where things are going to go wrong or where things are going to go well. A lot of local authorities in the country are already using machine learning to identify what demand is going to be for schools, for places in childcare, for all kinds of social welfare needs. And of course, at the aggregate level, that's quite a non-controversial thing to do. But as soon as local authorities are told that this number of children will be at risk, for example, of course, they want to know which children. And that leads me to my last point, which is the question, going back to this question of ethics. Because, of course, that is a very morally difficult question to answer. It also points to the question of who's providing these technologies, as somebody made earlier. Because if some company, which may be more or less scrupulous, is providing that technology, what will they do when a local authority says which children? What if there's 60% chance that a child is going to be taken into care or is at risk in some way? What do you do with that probability? It's a very difficult question. If it's 90%, what do you do? That's another difficult question, but a different one. If it's 60%, should you even pretend that you don't have that information? Is there anything you can do with it? So these are difficult questions. And the last thing that we're really working on is this question of ethics. Can you build a framework that actually gives policymakers a practical guide to what you do in those kind of situations, how you tackle questions like fairness, accountability, sustainability, and transparency? There are ways around those things, but it is a kind of reasonably complex exercise to come up with something that can be practically used. And I think we all ought to treat that as a priority in concert with the use of technology.
Thank you very much, Helen. Well, I think our panelists have given us a really rich seam of ideas to think about. So you can ask questions putting your hand up or via Slido. I guess I just wanted to perhaps kick off and have a question myself for the panel, which is how you think technology might change the relationship between patients and clinicians or patients in the health service. I don't know any volunteers to offer their thoughts on that one.
Everyone seems to be looking at me. I suppose the place I would start is the relationship that we have in our pockets now with perhaps the next train ticket we want to book, or the shopping that we want to do. I can remember thinking, goodness me, there's absolutely no way that I am going to enter a debit card information into a website. And that came somewhat after a stage where I thought there is no way that I'm ever going to enter credit card information into a website. Now, of course, I've now got multiple of both stored in my pocket with a finger click away. So why do I do that? Because it meets the need. It saves me time. It gives me what I want. And I think a world where your healthcare information, relevant data is shared between patient and the clinical team supporting them, can only drive extraordinary benefits for both in the management of individual patients, but also in how we design the service and remove the waste from it.
So I agree with that. I'd say two things. One is, yes, if we can give the patient the information and the tools to be partners in driving their care, and that's not just for the sick, but the tools to stay healthy, I think that could be extremely powerful. We have Polly here on my team who's been brilliantly leading the team on the NHS app, which I think there's a real potential to help with that journey. There's another element, though, that I wanted to mention, which is if we can do some of the things we've been talking about, in very straightforward ways, we ought to be able to give clinicians time back, which they will then be able to spend with their patients. So technology ought to help relieve some of the huge amounts of time that nurses spend preparing meds, for example, or clinicians right across the board spend trying to either enter or access information. There's a huge slice of time that we steal from our clinicians with all this. And I think if we can give that time back, it will have a profound effect on the ability of clinicians to connect with and help and care for their patients.
Thank you.
Well, one thing I would say there is that I think we are getting better in having some kind of science of public involvement in these kind of things. We are getting better at asking, at understanding what people want from technology, the sort of process of working out what people want to be explainable, for example, and what they don't. We hear a lot of talk at the moment about citizens' assemblies, citizens' juries have got much better. We've gone beyond things like focus groups and towards things that do have some kind of scientific credibility there.
Thanks very much. So I think I'll go to the questions that are coming through on Slido. So a question here about approaches to preventing digital from exacerbating health inequalities. Matthew, would you like to comment on that one?
Yeah, so look, I think it's a perfectly legitimate question. And I spent a day with one GP surgery in the north of England who had very kindly put together a group of their patients to spend an hour telling me how much they really didn't want to use digital technology. And it was actually extremely useful to hear. Because I think there are 2 points. One is the digital technology has to be accessible. It has to be not just for the sort of digitally confident and the digital natives, but the technology itself, as far as it is possible to be, has to be accessible, intuitive, straightforward to use, which is why we're determined to try and get patients in the design, in the governance, in the leadership of the programs, the program level, indeed in my senior leadership team as well. But then also, I think we need to accept that not everyone is going to be able to or wants to use digital tools. So there have to be non-digital channels that are as good and as accessible. And that that shouldn't mean not doing the digital, but I think it means when you do it, you have to have accessibility absolutely front of mind and test what you do against it. And you have to make sure that there is a non-digital alternative available. I think at its best, technology has the ability to allow a system to focus on those who most need the attention by dealing with those who don't need that attention in other ways. At its worst, if we're not careful, you exacerbate inequalities because there are digital haves and have-nots just as there are health haves and have-nots. And there is always a danger. It's a very good question because there is always a danger, unless this is really front of mind in what you do, that you just exacerbate that inequality.
So I'm minded, a number of us will have heard Victor Debowell talking about the key things that healthcare needs, and he talks about access and equity, and technology as a key enabler, but it can obviously take both of those in good or bad directions. Just an example from conversation with one of our diabetologists on this. Two things that she said that I found quite interesting. One is don't forget how much people struggle, often the most complex and people living in the most difficult conditions with the most difficult disabilities, to get to a clinic. And so actually moving to Skype consultations, in her view, was not only reducing the inequality of access, but actually, this was the really interesting bit that I'd not thought of at all, was flipping the power relationship between the two of them. Because she was in her office, the patient was in her home. Not that the patient had struggled for 3 hours to come to sit in a waiting room for then a magical door to open to then be on the doctor's turf. So that was one aspect of it. And then in the same clinic, the level of ownership that a patient can get to their condition if they've got a real-time blood sugar streaming coming onto their phone can lead people who previously might have wondered what it was all about to actually become highly active.
I'm just going to take a couple of questions from the floor, although there are some really great questions coming through. Thea, I can see your...
It was because it was about this, and I think maybe Claire was also around this area. So it's about the health inequality. So I've got the experience of trying to embed the My COPD app, which has been touted as extremely useful. And initially, certainly, trying to embed My COPD app within community respiratory teams in Leeds was a disaster. Because many of my patients were living in abject poverty, very chaotic lives. It was not something that they could utilise or use in any way. And it was a very small minority of people who are able to utilise that technology. What's been interesting is actually wrapping around a digital inclusion team, which is the council's team, a great deal of support and help and advice. We are able to embed it a lot further. But I think the point I would like to make is therefore the cost and the change and the cultural change that's needed to embed a new bit of tech in order to ensure that it doesn't increase health inequalities is absolutely huge and needs to be considered in all of this.
Thanks here. Claire and...
Thanks very much. I just want to make 2 points. With respect to health inequalities, it can actually reduce health inequalities. With we have an e-consult, e-triage system, and in fact, what we find are those with mental illness, those with sexual health problems, those where English isn't their first language, are very frequent users because they can actually get their child, their adult child, with them to try and communicate with their GP, and they can also do it in their own time. So I think we've got to look at it at different ends because it can improve inequalities and it can reduce inequalities, other than, of course, that very small number of the population who don't have access at all to a smartphone. But the second point I wanted to make, I thought you would say, and I was waiting for it, when you said digital will help reduce the time that the doctor or the nurse spends on this and therefore allow them more time for, and I was waiting for the themselves. Because actually what I think digital, not with their patients, now of course we need to have more time with our patients, but the one thing that's really lacking that digital hopefully will try and improve is the amount of time that doctors and nurses can spend actually reflecting on their work, having space to do their work properly, having breaks, which I'm sure everybody in this room has, is on the golf course every day, not working. So I think we've also got to accept that it's beneficial for the staff not to spend more time with their patients, not to open another lane of the motorway so that they're just working just as hard but in a different place, but actually more time with themselves or with reflecting on their own workload.
There was another question just on the same table.
Thank you. It's Charles Alessi from Public Health England and HIMSS. One is I think we need to address this inequalities issue head on, because I think the points made around inequalities are perfectly valid, but perhaps the language we use is not the most conducive to all straits of society, and we need to understand that. And also, the medical language we use is medical language. We can learn an awful lot from even people which we hitherto have perhaps not ever engaged with, and the gaming industry, for example, that somehow found it extraordinarily easy to get people to do the most unnatural things, which is put money on horses in a way whereby they don't even get the thrill of the race through the internet. And some of the ways and behavioral methods that they have used have actually been employed towards the delivery of health and care in wonderfully imaginative ways. And we've seen this being deployed in different parts of the world, not yet in the United Kingdom. The second point I wish to make is about burnout. Specifically about burnout, people talk about digital transformation as being equivalent to burnout. Now, I think there is a connection between the two, because digital transformation equals change of pathways, equals change of ways of working, equals a whole series of issues, where inevitably, unless that is very perfectly managed, it just increases the stress on the individual. But burnout is also associated with everything from Dr. Google to the enormous amount of information around pathways that people now have to take in. In my day as a young practitioner, all I had to do when I was on my emergency stake, I had a few drugs in my hands, and I had to make sure that people were warm, were comfortable, were not in pain, and preferably didn't share the bed with the person next to them. But that's basically it until the morning. Now there are pathways for everything, not only for everything, but for different people within everything. And it is outside of reality for humans to be able to cope with all of that, unless there are well-developed clinical decision support systems, digitally, which follow a clinical pathway rather than an administrative one. This is a long conversation, but digital is our future if we deploy it correctly, or a disaster if we don't. And I'm really pleased that Matthew is in listening mode around the deployment, because that's going to make the big difference. Thank you.
Thank you. I'm just going to take another couple of questions, because there's lots of hands up. So try and hold some thoughts, then I'll ask you for reflection. So Alison.
Thank you very much. My name's Alison Lear. I'm a professor of modelling. I'm really interested in the assumptions that are being made around work. So it's a bit from Claire's point, actually. So we know that in the past in other industries, when there's been digitisation, the work hasn't got less, it's just become different. And I was really intrigued by a couple of the comments about how nursing work was changed. I'm sitting on the nursing table here. Particularly the stuff around the automation of vital signs. So it assumes, I get contacted pretty much every week by some SME that's cracked safe staffing or cracked safety. So the collection of vital signs just as data, absolutely. But we know, I mean, there was quite a big study by somebody funded by NHR about 18 months ago, that a registered nurse actually doing vital signs as opposed to a healthcare assistant collecting data is better for patient outcomes. So when we're talking about this digitisation agenda, are we really considering, as Eric Holnagle would say, the work as done, not the work as imagined?
So perhaps we'll just pause there for reflections on those. And then I know we've got a couple of other hands that have been up. Anyone you'd like to comment on those points? Matthew.
So look, there's a ton there. Can I just give a series of thoughts? So the MyCOPD app story I thought was really interesting. And for me, I think there are two lessons I draw from it. One is there are definitely some applications which we know when they're effectively deployed can have a very positive benefit in terms of freeing up time, productivity and so forth. But often the bits of the system that most need the benefit from that aren't the bits that have the bandwidth to be able to deploy it. So Tara Donnelly, our CDO who's sitting at the front, is standing up, and we're working out and listening and talking to people about how we do this, but standing up a capability to assist with the deployment. So precisely so the bits of a system that most need the benefit of those technologies can get the benefit. But there's another lesson as well that I draw from that story, which is I don't think collectively we do an optimal job at sharing what we know and what our experience. Partly because everyone's very busy, partly because we don't have the mechanisms in place to share it, partly because I'm not convinced everyone is comfortable standing up and saying, yeah, we tried this and it didn't work. And here's why it didn't work, and here's the lessons we draw from it. And there's a question about blame culture, and I am really, it's something I feel very strongly about. Until we can say, actually, we tried something and it didn't work, it will be very hard to get this right. The point about time, Claire's question about time and time back, I mean, I totally take the point. I think it is nonetheless really worthwhile to try and liberate that time. But I am still haunted by something I heard, which actually wasn't anything to do with technology, but I was listening to a survivor of domestic abuse. And she had been suffering domestic abuse for years. And she said the moment she felt she had permission to say, yes, I have been a victim of domestic abuse, was when the GP looked her in the eye and said, gosh, what you've just described to me sounds like it must have been very difficult. And if the GP had not looked her in the eye, but had been looking at the computer screen trying to pull up information, that exchange would never have happened. So one way or another, I think there's a role for us to do to give clinicians the ability to spend that time with the people they're looking after. The last 2 points, I think, for me, are really about the necessity of making sure everything we do is designed with the user at its center. That when the idea that you can come up with a brilliant system and chuck it over the wall at the clinicians is hopeless. It has to be user-centered design. There are some, as Helen has talked about, there are some really good techniques and methodologies that have been developed for doing this. We get it right when we deploy those technologies. We look at work as it is rather than when we imagine it when we use those methodologies.
Thank you. Helen?
I just wanted to come back at that point about imagined work, because I think this quite often happens. We compare what the technology is doing with some imagined Halcyon past where we were doing everything perfectly. And what the technology quite often does is, particularly the data-intensive ones, is they reveal what was happening before. So there's a lot of talk about bias in machine learning arising from the training data being biased. And this is quite often the case, but that can be the case. But the bias reflects bias that was in the system before, in the kind of human system, that's been reflected in the data and reinforced in the technology. So there is a sense there that the technology can sort of highlight those things and perhaps make it easier to do something about it in the future. But it's a really good point about imagined work, because I think we do kind of imagine how things were before.
I think it's mostly been said. I mean, you could go on to any ward at Barnet Hospital, one of our hospitals that recently had the upgrade, and you could find doctors and nurses there and therapists who think that the change has given them half their time back. And you could find on the same ward, same type of staff who think that it's slowed them down hugely.
Thank you. So there was a question on the second table and also at the back, in the middle of the back.
Thank you. Soraya Sita, NHS dentist. You mentioned that the AI will be targeted to where there are areas of strain and pressure. How will you determine that? Because I feel everywhere there's strain and pressure. Will it be on a macro level, so like deprivation, or will it be on a systems level, or will it be on procedures? And based on the previous session, how will you ensure that that is scalable to the populations? And then a final question, if you don't mind, which is a bit cheeky, is do Helen and Matthew talk? Thank you.
Shall we we'll just hear the other question, the other questioner, because you may also have multiple questions, and then I'll ask my panel to deal with it all.
Okay, thank you. Eileen Burns, I'm a geriatrician in Leeds, and I work partly in Thea's organisation as well as in the Acute Trust and the community. So we have got quite good, I'm here, Matthew, we've got quite good systems that actually do allow me to see quite a lot of what's going on in other parts of the system. So that's a real positive thing. It's still clunky, it's still not as easy as we'd like it to be, but it's good. On the health inequalities front, I just wanted to flag up the issue of older people, who we know are the main users of health and social care systems. They're the group who are learning fastest, the biggest growing learners for digital, but there's still a huge amount of older people who don't have access to those technologies and are afraid of those technologies and really aren't going to go there. So I think we can see massive advantages in terms of how the system could work in a more integrated and effective way for older people. But in terms of the older people themselves being expected to use systems to book, for example, GP appointments, we need to just be really mindful that we don't disadvantage them. And then my final thing was, can we make all GPs, whether they're on System 1 or EMIS, all be on the same system?
Okay, so a few different points there. Matthew, are you happy to kick off?
Yes, let me start with the easiest one. Helen and I do talk. I mean, not so often it makes my wife nervous, but we've been working together not just in my current role, but in my previous role when I was Director General for Digital Policy for the government. Your first point about how the areas that we're chosen to support in AI with the fund. Well, it's an open fund with open application with two bits. One is a bit where we want to support innovation that has shows real promise, but hasn't yet sort of reached a point of maturity. The bit I was talking about that you referred to is the second part, which is a larger bit of a fund, which is to take technologies which have, where there is a serious evidential base of efficacy in what they do in individual, normally one or possibly two locations, and scale it to more locations. So there, I mean, an example would be the ability to read mammograms, where there is there's decent evidence, but for us to deploy it much more widely, we need to see it works in a series of different locations. So it's about building that evidential base. So that's the way round we're doing it. The point about care of the elderly, I mean, I totally agree. I spent a very happy hour and a half earlier this week giving evidence to a House of Lords Select Committee on exactly this question, where the Science and Technology Committee is looking at the use of data and technology in care of the elderly. And I think their report will be really exciting and interesting, precisely because it will tackle the needs, the constraints and the potential to help that particular bit of the population. On the point about all GPs using the same system, I can see the attraction, but I have to say my blood runs cold a bit thinking about a single system for the entire country, because that's when you get really strong lock-in. It's when you get a provider who doesn't have to be responsive to user need because they've got the monopoly. It's when actually things stop moving. So you get an immediate benefit in a short term because everyone's on the same system. And then I think things get worse because you don't have the pressure of having different providers. So I think the answer is not a single provider. I think the answer is really clear standards that all providers have to obey so that data can flow, so that things are described in the same way. And then actually you can have the benefit of having different providers and you don't get stuck with a single one.
Thank you very much. And I'm conscious that we're nearly out of time. So I don't know, James or Helen, if you've got any final reflections for us.
So David, in the session earlier this morning, mentioned the 4-hour ED target and how it's not particularly helpful to judge an ED or, let's say, a whole hospital by that number. What we're trying to do across our pathways is to say, in heart failure, just as an example, what does good look like across 4 dimensions: clinical outcomes, the patient experience, the health of the population, and the use of resources. And we're adding in staff experience into that. And you just, without digital, you just can't get reliable real-time information on those metrics that matter. So there's little that I see that's more powerful or inspiring than when a clinical team, together with their patients and families, have come up with this set of metrics, and we can offer them that and how they're doing and see what they're testing and changing links to how they're doing on those metrics. That is incredibly powerful.
Yeah, just to that last question, I think the question of whether elderly people are never going to use a technology, for example, that is an ethical question which does have to be built into the use of the technology. And it does come back to the ethical point. We have to break down ideas like fairness and say, you know, there's fairness in the data, which can cause bias, for example. There's fairness in the process, which would apply in this case. And then there's fairness in the outcome. We've got to be able to measure that outcome. And yeah, we have to confront that.
Well, thank you very much to our panel. I hope you'll all join me. And now we can move over to lunch.
Are we all set? Right, can I encourage you to take your seats, please? As John said when we planned the programme, it's quite an undertaking to try and curate an interesting collection of input, and people can bring different insights. And we thought it was an excellent opportunity to hear from the new Chief Medical Officer about a really important area, which is not coronavirus. Life goes on, and in particular, multimorbidity goes on and grows. So we thought it would be a good opportunity to explore some of these issues. You may have seen Professor Whitty's article in BMJ earlier this year. It's one of our biggest challenges. But we will have just allot a very small bit at the end of his presentation and the Q&A to pick up the issue of the moment and ask him to say a few words about that and answer a couple of questions. So if you have questions about that, just save them because we will get to them. But first of all, let's hear from Professor Whitty about the main topic that we asked him to talk about, multimorbidity. Professor Whitty, thank you.
So actually I was given an even wider topic than the multimorbidity. I was asked to talk about health over the next 20 years in 20 minutes. So I'm not going to take any prisoners. I'm basically going to go through data to make a few points which I think are sometimes underappreciated in health planning and decision making, because that's very much the audience I'm talking to. And I'm not going to explain things like demographic pyramids because I'm going to assume that everyone in this room knows what they are. So I'm happy afterwards to give a epidemiology lesson for those who need it. This is the demographic pyramid for the UK from 1911. I chose that year because if you go any further, you get into the world wars, comparing it to roughly where it is now and roughly where it will be in about 25 years' time. And the first thing to say is the change that we had demographically over the last century was massively greater than the one we're about to get. But the one we're going to get, of course, is very important. But, and this is the important but, I think a lot of people do not realize that if you look at the rest of Europe, the demographic pyramids mean that they are going to have a much harder landing in terms of actually aging than the UK is by some distance. And these are the demographic pyramids for Germany, Italy, and Spain. Almost all of those, the middle bulges, are between 50 and 60. And of course, those people are about to retire, and then they will get ill health. The reason I'm making that point is we have always assumed that if we got our planning for our numbers of doctors, nurses, and healthcare workers, social care workers wrong, we could actually basically buy them in from our nearby continent. The competition for resources on this is going to go up very substantially over the next few decades. And that's also true if you look globally. This is a very famous and important slide from Hans Rosling, the late Hans Rosling. I'm not going to go through the multiple important points on this. He mainly used it to illustrate the point that actually the wealthier a nation, the better its health outcomes. But every country in the world is moving from bottom left to top right. And if you look forward 20 to 30 years, most of the middle-income countries will have a health structure and burden of disease which is pretty similar to our own, but with some additional ones which are legacies of the fact they're lower-income countries historically, and therefore they also will be in competition for social health workers and others. So I think we need to think quite seriously that our ability to buy in things when we get our own planning wrong is going to decrease over time, and we need to plan on that basis. The second point, internal migration. The debate tends to be around external migration. That is actually for health much less important than internal migration. In the UK, in general, we have a pattern where we move into large cities at the age of 18 for to either be students or work, and we move out of cities after our second child. That's very stereotyped. You may not do this, but if not, you're the minority. The result of that is that what you get is the cities remain eternally young. Their demographic structure stays the same, but the equation has to balance. And therefore, the rural and small town areas are getting older at a much greater rate than you would expect from any of the overall projections. So I've just illustrated this, and I could have done this in any combination of a city and its rural hinterland. This here on the right is Newcastle, projecting forward to 2037. These are the ONS data. On the left is Northumberland. Everybody in the bar on the top left is over the age of 90. And the same would be true, for example, if you look at Leeds and Harrogate. And the same is true for London and its hinterland. What does that mean in practical terms for us as a country? Well, this is the map of the UK when I qualified in medicine, roughly now, bottom left, and where it's going to be when I retire, provided the retirement stay the same as expected to be. And what you can see is the large increase in people over 85, where the health needs will be, are in the rural and small town areas. And yet these are ones which it is often harder to attract health staff to, harder to attract nursing staff to, harder to actually provide hub and spokes for things like door-to-needle times for stroke patients. So we're going to have to take account of this shift of burden of disease towards the rural areas over the next 2 decades. And that's going to be exacerbated because what we're going to end up with is a gradually worsening working age to retired age ratio over time. So this is, if you put that and you layer that on top of the fact we're going to be in competition for people who are health and social care workers with all around the world, I think this means we have to think very seriously about this now if we're not going to get into an extremely predictable problem. The exception to this, the one major exception to this, apart from a few diseases which tend to be higher in people of some of the ethnic minorities, is mental health. Mental health does tend to cluster in towns, and always will, in my view. And that is basically because people tend to acquire mental health illnesses in their late teens through to the early adulthood, and then they continue after that point in time. So that is the one thing where that is less true of. So the next point I wanted to make was about the concentration of mortality. If you look over time, these are data back to the 1850s, because I think if you want to think about the future, you have to think about the past. And what we've seen is a steady concentration of mortality over a very, very stereotyped part of the age spectrum. So it used to be that you'd of course die in childhood, that's well known, but you could carry on dying all the way through your life. Now it is incredibly rare for people to die under the age of 75, in our society, and very rare, actually still, for people to die over the age of 100. And the concentration is getting tighter and tighter as time goes by in this increasingly stereotyped way. And if you look at the more recent data, if you look at changes in mortality, the light blue line at the top there is people over the age of 90. There has not been an improvement in mortality rates in people over the age of 90 for a long period of time. Whereas the bottom one is the change in mortality of people aged 75 to 79. That is continuing to improve at quite a rate. So what this shows is this concentration of mortality is going to continue over the next 2 decades, and there are significant implications for how we provide the health service as a result of that. Now, the way in which the health service is configured has changed throughout its life course, and it will continue to change. The biggest shift in the NHS, which again I think many people don't realise who have not looked at this, is the huge shift from a bed-based service to essentially an outpatient-based service. And what you have on the left in these brown things is the NHS when it was formed, and on the right where we are now. And the number of beds in the NHS has gone down, even though the population has actually gone up. The situation has completely refigured for many diseases. I'm making that point because the next point I wanted to make is one of the things that I think is one of the biggest threats to the NHS if we do not sort it out. There is a belief by my own profession that the reason why the rates of pressure on the service are going up is entirely due to ageing. This belief is wrong. There is an aging component to it, but if you look at these OBR data, this is the rate of increase in outpatient activity every year. And annualized every year, the rate of increase is between 5 and 7%, irrespective of age. Because what you've got on the right there is the different age brackets. And therefore, this increase in demand for outpatients, which, as I say, is the direction of travel for most of healthcare, is something which is being driven not by age, but by other factors. And I think that is an issue we need to think about very seriously, because if you're compounding up at 6 or 7% a year, you're talking about really quite serious numbers. Now, I wanted to just touch, before I move on to individual diseases, on life expectancy at birth. It's an observable fact, pointed out by Michael Marmot correctly, that life expectancy at birth has stalled in the UK. And these are the data over time, and the graphs are pretty stark. That's a fact. It also coincides with the economic shock. And my own view is linking those two together seems a perfectly reasonable thing broadly to do. What I am much more uncomfortable about is people then linking it to individual policies of individual governments. And the reason for that is this. These are, I've just chosen the 4 largest countries in Europe, and basically the graphs look the same. So over-interpreting this bit of government policy, caused it, strikes me as intellectually quite weak. Most of the change that you either see or don't see is in this age 69 through to 80, broadly. And that's the area where it has ceased to improve more recently. And I think a lot of that change was due to changes in cardiovascular disease, which I'll come on to. So now a little bit about individual diseases. The patterns of diseases that we have to deal with change the whole time. At any point in time, the professions and the public believe that the current burden of disease is what is normal. Actually, these change very dramatically. And I'll just give a couple of early historic examples before I go into my own views about where we're going to go next. These are broadly infectious diseases in the dotted lines, cancer in the dashed lines, which I'll come on to last, and cardiovascular disease in these solid lines in the UK over the last 100 years. And what you can see is that if you went back 50 years, cardiovascular disease absolutely dominated all other forms of mortality by a very, very large amount. And now we're in a situation which has come down a very long way and is continuing to do so. I'll come on to those data. Infectious diseases, my own trade, dominated very heavily at the beginning of the last century. It's going to dominate again in the future, because if you don't die of anything else and you're an elderly person, that's what you die of. But at the moment, we're going through a bit of a lull. My own bit of trade has done a good job. But if you looked historically at the NHS, when it was formed, all the things in green are people dying of infections, and all the things in blue are people dying of cardiovascular disease. The NHS was dominated by infectious diseases in its early years, and it is only more recently that other things, first cardiovascular and now increasingly cancer, have come to dominate mortality rates. That trend, in my view, is going to continue, although I think the cancer rates, for reasons I'll come on to, are likely to go down. Now, just to unpack a few of these data, and I'm going to go through these quickly because most of you know these data, but I want to make a general point. Lots of people do mathematical models, and lots of people do things where they read the Nature and the New England Journal of Medicine, and based on the latest paper, they predict what the changes in medicine will be. My view is the best way to do it is to look at the data from the past and use a ruler. If you look, I'm just going to go through whole bunches of bits of data, and I hope I will make my point reasonably clear. These are the changes in coronary heart disease rates in the UK. These are the changes in stroke rates. Now, just have a wild guess where that's going to be in 20 years. You can try and model it, or you can use a ruler. I think the ruler will help. And cardiovascular has been one huge success story. Because are based on drugs which are now off-patent, they're now competing, so the number of drugs has gone up over time, but the cost of drugs in cardiovascular disease has actually gone down. This is an area where we're getting healthier and it's getting cheaper. And the good news just keeps on rolling on with cardiovascular disease, because increasing amounts can be done relatively non-invasively, which previously required major operations. So this is basically cardiovascular, a phenomenal success story. Doesn't mean that there isn't further to run. This definitely is. That, of course, though, means a group of people who would have died of cardiovascular disease now are not dying. Excellent. And that is the reason why we're getting a very large increase broadly, and this is simplifying, but not much, in dementia. The incidence of dementia is not going up. The rate of dementia is not going up. In fact, if anything, it is in fact going down. I'm about to show you those data. But the prevalence is going up because once you've got it, you've got it. And a lot of these people would have died of cardiovascular disease before. Until we sort this out, this is just going to carry on going up. So this is a really major target for science because there is no other route out of this one other than scientific advance in this area. That's not to say there have been no changes. These are interesting data from Matthews et al. It's one study, but I think the best study I know. And what it demonstrates, if replicated, is that the rates of incidence of dementia have gone down quite substantially in men and hardly at all in women. In my view, probably because the vascular risk factors are also the same as the risk factors that drove quite a lot of dementia in men. So if you remove those risk factors, then the dementias improve. But this is not going to solve the problem, and as you can see in women, there's been hardly a change over that time. What this means for the UK geographically is that over time we're going to start moving from the biggest burden of disease being in the areas dominated by cardiovascular disease, particularly around smoking, to the biggest burden of disease is actually going to be in areas of older people for which dementia is a proxy. And that's going to shift the geography of disease in the UK in a predictable way, which I do not think we are currently planning sufficiently for. Then cancer. Broadly, there's prevention of cancer and there's treatment of cancer. For the cancers at the top of this, which is includes the major diseases of men and women respectively, prostate and breast cancer, treatment has improved dramatically. So over the last few decades, we've moved from a situation where only 25% of people would be alive and well after 10 years to a situation where it's now 50%, and that will continue to improve. The failure, which I'll come back to, is right at the bottom, and that is lung cancer. Right, back to our rulers. This is survival over time. The last bar, incidentally, is half decade, the others are decadal. And what you can see is these are 10-year survivals, which I think are the most important to look at. For prostate, breast, bowel, melanoma, again, use your ruler. Guess where these are going to be. Hodgkin's lymphoma, leukemia. And of course, sadly, for the ones that do badly as well, you can also predict where they're going to be. This is lung cancer, a disease which is basically a cancer entirely for profit. So if we look at that's a success, but the bad news on this is that this is not an area where we're losing large numbers of drugs that are actually coming off patent. These drugs are still all on patent. The science is developing rapidly. They'll carry on being on patent. And if you look at the cost of these drugs, these are data, I've just presented them from that well-known socialist rag, Fortune magazine, and it's making the point that to buy 1 year of life from cancer, inflation normalized, we've moved from a situation in the US, the UK data are slightly different, but the trend is the same, where it was just over $50,000 per life year to one where it's now over $200 per life year. We haven't bought anything with that increase in cost. That's just an increase in cost. That's inflation adjusted. Bit on prevention, smoking trends coming down too slowly, but they are still a way to go. And much of the remaining inequalities, the kind of things that Michael Marmot was highlighting last week, a lot of the avoidable differences are driven by smoking. The occupational, if I'd been given this talk 30 years ago as CMO, I would be talking a lot about occupational diseases. The last of the great occupational cancers is now peaking this year. That's the epidemic driven by asbestos, which is a combination of mesothelioma and lung cancer, 50-50 basically in terms of the roots. All the others are much less important. Accidents have gone away. The thing we're not doing well in workplaces is health improvement and health promotion, where I think we really need quite a radical shift of direction. But stopping people dying because of work, we've really got very good at. Stopping people being healthier because of work, we have not. And then a couple of other preventative areas. Pollutants. Things are not as bad as they sometimes appear, but the fact, that most of the pollutants have got better, but this hides the fact that actually the rate of improvement is less good in the parts of the country where people live. So in cities, the rate of improvement in pollution is much less good than it is overall. Having a really polluting factory in the middle of a field become less polluting is great for the environment, but doesn't actually have much health impact. So the cities is really where we need to think about. Screening and vaccination of cancers, I'm not going to go into in detail. Very happy to pick up in questions. The 2 points to make are on this. I just wanted to make in passing really were screening really works in cervical cancer and works to some degree in breast cancer. And then there are some things in terms of genetic diseases in neonates. Much of the rest of screening is highly controversial, and many of the things people talk about for screening actually will do active harm. Nobody's going to screen me for prostate cancer anytime soon, because the probability is it will lead to me having unnecessary, rather unpleasant procedures, and it has absolutely no impact on mortality. The same is true for many other areas. We need to think about this in a much more sophisticated way. And then there are a bunch of cancers which we're going to get rid of by vaccination. HPV being the main one for cervical cancer in the UK, globally, hepatitis B and C driving most of the liver cancer in many areas, and in my own view, potentially Epstein-Barr virus drives a number of other cancers, which I think are probably preventable. Before I come on to my final section, just to acknowledge that the stunning improvement globally we've had has been in child and infant mortality, but in the UK we've continued to have an improvement, but it's been relatively slow, and neonatal health remains not in the best group in Europe or the world, and we ought to be thinking about that, I think, quite seriously. And obesity, I'm not going to go into, I'm just acknowledging that's a growing threat, which I think has been talked about enough. I don't have anything new I wish to say about it today. The final point I wanted to make before I just summarize is about multimorbidity. And this is what our chair talked about earlier on. We all know that we have not bought a healthy year of life for every year of life we bought. It varies around the world how much you get, but for every year of life you buy, some of that is an unhealthy period. I think what is less widely acknowledged, although it's now well known, is the fact that as you grow older, you actually get a lot of increase in multimorbidity. And the shift of medicine has been from single diseases, where the big benefits have come from specialization of the medical profession, and we're moving over to a multimorbid era, where most people who have either got no diseases or lots of diseases, where specialists with no generalist skills are probably not the right doctors and nurses to have. We need to be going back to an era where people who can maintain their specialist skills but retain their generalist skills. If we do not do this, you're going to have people coming with 6 diseases having to go to 6 specialists, none of whom talk to one another. This is a problem for the medical profession. It is a problem the medical profession has got to sort out, in my view, over the next 2 decades. Preferably over the next 2 months, but that's probably a bit optimistic. Finally, just to acknowledge that occasionally things come along, however good your strategic aim is, which knock you off course for a while. We're not heading into an H1N1 1918-20 flu pandemic situation, but the coronavirus does present some challenges for us. It definitely will for a period. How big remains to be seen. But the events happen, and when events happen, the great majority of them tend to be infectious, and we're seeing an example of that at the moment. So, my summary. There are a lot of areas where we are winning, and if we just continue doing what we're doing at the moment, we will continue to win. They include heart disease, stroke, much cancer treatment, some cancer prevention, smoking, albeit slowly, child health, but not neonatal in my view, and urban health. All of those areas are going really well. And then there are some areas where we could win, but on current trajectory, in my view, will not, which include multimorbidity, dementia, frailty, often mistaken for multimorbidity, is different, mental health, which I haven't talked about much, but which has been really, really disappointing how little that has improved, although there have been some major improvements. Obesity-related diseases clearly heading our way. Sally Davis would kill me if I didn't add antimicrobial resistance. Getting the demand-supply ratio right, and understanding why there's been this phenomenal increase in outpatient activity when that doesn't really appear to have medical logic, and one which I think I am really worried about, rural health. Thank you very much.
So we'll open the floor, but we've got a couple of responses that I thought we'd just ask people to provide us with. Jennifer is over here. Yeah, Misha, I'd like to take this. Thank you. And Jennifer, I think we asked you to give a few responses to that tour de force, which is...
Thank you. I'm the plant here, the plant one. So thank you very much, Chris, for your very, very interesting set of slides. Just something slightly different. That is the Marmot review you referred to this week, came out. Stalling life expectancy, we know, but also, as you also know, life expectancy going into reverse for some communities, not least women, but also for men in some deprived communities. Growing gap in health, not just between rich and poor, but also between poor and poor. Poor in the northeast compared to poor in London and the southeast. So my question really is, how do we effectively address this? We haven't had a health inequality strategy for a decade. Is it now time for one?
Yeah. Thank you. So, firstly, the fact of the inequality difference in mortality, and even more actually severely in morbidity, if you look at that, is an observable fact. Lots of people have described it. Michael Marmot's described it probably best, but there are many other people. Many fewer people have actually described a situation where we can deal with it that is both likely to work and realistic. And I think this is a big challenge for us to deal with. I think it's best dealt with by taking the groups in society in manageable problem sets that cluster together. So, for example, this year I'll be doing my annual report on rural health, where I think there's a group of issues, particularly around ageing, but there are some other ones, and coastal towns, because there is more in common between Blackpool and Margate than there is between either of those towns and their nearest inland neighbour, for example. And we should see those problem sets and see them as a national problem and deal with them as a national health priority. Now, many of the solutions will not be in the health sector, but I think if we divide them up into problem sets, we're much more likely to address them than if we simply say, well, these geographical areas have got big differences and what are you going to do about it, which I think has slightly been the tendency to date.
Great, thank you. Chris Naylor, I haven't seen you. Yeah, excellent, good. Thank you. Just probably introduce yourself if you would, please.
I will do. Yeah. Hello everyone, my name's Chris Naylor. I'm the Chief Executive of the London Borough of Barking and Dagenham, East London Borough. If people can't picture where it is, it's the bit on the EastEnders map they never quite get to on the telly. So thank you very much for that. Unfortunately, I broke my glasses at the weekend, so I couldn't quite see all of your slides, but I got the tenor of your argument. And I think the point you were making about let's not hook all of this onto austerity was right, and I'm not quite paraphrasing what you were saying. And I say that as a person who runs an organisation that's had its budget cut by 62% since 2010, and where I observe that the parts of the system in my locality that are most under pressure are those bits that haven't had any austerity at all. I suppose the bit for me really is, my authority is one that's gone through profound change over the last 30 years. We're sort of post-Fordist in all senses of the word. Like we used to have a massive Ford factory as well as that employed 58,000 people, now employs 3,000 people. The economic fortunes of the place have changed dramatically. In 2015, when I started working there, the average healthy life expectancy of women was 53 years old, 25 minutes away from the most successful city economy on earth. We've been doing a lot of work recently with health colleagues to understand the journeys of people into acute services, my services, their services. And the data tells us, and none of this is rocket science, it's people with low pay, people experiencing debt, interestingly enough, is a big trigger for people, mental health, etc. I guess the point I'm sort of rambling towards here is that if I take my ruler out and look at the sort of national finances, in sort of 10 to 15 years' time, unless we radically alter the trajectory of spending on health and social care, I think the wheels of our economic settlement in public services, they fall off. Because I just don't think our economy is going to grow sufficiently to meet that rising cost. I don't think there's any appetite to see the level of taxation rises that we would need. And in any case, I think that would be probably a finger in the dike. So I guess the kind of, there's a question in all of this. I think it's certainly for the local government world, we've had to shift our stance away from meeting need to trying to understand in quite a radical preventative way root cause. And I think when you do that, there are questions about housing and employment and economic distribution, sort of structural barriers that hold people back, which are the key to unlocking a lot of this. I don't know what your thoughts are on that.
Thank you.
Well, I think the short answer is yes. I mean, that is clearly right. One of the questions for people like me is, so what's the role of local government, what's the role of central government in trying to address these serious issues? And that's one of the reasons I think it's worth thinking about problem sets and taking geography out of it, because central government does have a role. I think if you've got a common problem set across the country, it does not have a role if something is a very, very local problem, which we much better understood locally. So I do think we need to try and get those to work together. I should also say, I think there's I have a concern that the amount of research that goes on in local authorities is very small. This is not the fault of the local authorities. This is a structural problem, and we need to sort that out because the evidence base is not strong enough in many cases to be able to point to a solution and say, we're pretty confident this is going to work. And so I think that's an area we in the centre ought to be absolutely helping local government in addition to more practical things.
Oh, interesting, yeah. Okay, Ingrid, here.
Thank you very much indeed. Really interesting talk, which I'm sure everyone enjoyed as much as I did. I wanted to just ask you a few questions about the child health point, because you said that it was in the winning category, which I sort of agree with. Things are getting better, but I also sort of disagree with. Partly because of the things that are worrying me. One of them you picked up on, which was infant mortality. And it is ticking up now for the last 3 years, but most worryingly is it's ticking up only amongst the poor. So that speaks largely to the Marmot report yesterday. So that's one thing that's worrying me hugely. And then the other one is that if you look at all other ages of child mortality, and you compare us with European countries, we are declining, so it's a good news story, and this is where I agree with you, but we're not declining as fast as in other European countries, and that's where I disagree with you, and I'm worried about it. What can we do about it? I think it's partly NHS, partly not NHS, of course, but, and here's my question, as regards what you showed about the demographic shift, and the emphasis on the elderly and all of those urgent drivers about social care and absolutely legitimate problems. What impact do you think that will have on the attention that child health gets, and what do you think we can do about it?
Well, the first thing is to say, I'm glad to say we're agreeing on both points, because I actually made the point that, in fact, we're not in the leading pack, and we should be, because if you can do it in Finland, you can do it here, broadly. In terms of child health, I think we need quite a significant rethink on child health. I'm really worried about what's happening in paediatrics. I'm quite worried about what's happening in quite a large number of areas of child health elsewhere. And I'm also worried about what's happening to the intellectual underpinnings here. Academic child health is going down rather than up, and this is something which I think is clearly a serious issue for all of us. So I broadly agree with the problem set. The solution is not, I don't think there's, to be honest, I don't think there's a huge competition for resources between children and elderly care. I think that the difficulty occurs in the bit between those two, and that there I think the competition probably does become more of an issue. But most of the public and most politicians wish to protect child health, rightly. I think the problems are more to do with the fact we haven't systematically done all the things we know work. Because most of the things that would get us up to the top of the leaderboard, we know what they are, we're just not doing them systematically.
Would you expand just a little bit on your anxieties about paediatrics, because that's kind of intriguing. I don't want to leave that hanging. Do you mind? Is that okay?
Yeah, if you look at sort of vacancy rates of paediatrics, if you look at movement into that area, it's really going in the wrong direction. And there are a number of reasons for that, but it's quite a worry. And it always used to be that huge numbers of people really, really wanted to do paediatrics, and that ceased to be the case. It's not really obvious why. I could hypothesize, but I think we need to sort that out, because this is an area which, many other areas of medicine, people can switch between a lot more easily than they think they can. Switching between adults and children gets a lot tougher. And so if you don't get your workforce right on this, you have less ability to apply a kind of gear change in flight.
Yeah, excellent. Claire, and then there's a lady here at the back.
Thank you very much for mentioning generalism. The late Barbara Starfield, who I'm sure you know, the famous academic researcher from America, did some fantastic studies that showed that the more GPs, they weren't called GPs, you have per head of population, the better the health outcomes of that population, irrespective of the numbers of hospitals and all of the. So it's an independent factor for the number of generalists. What role do you think the CMO has in trying to work with the medical profession and Health Education England to try and improve and reach Matt Hancock's, I think, very good target of 5,000 more GPs? I think we actually need 10,000 more GPs. But also to reduce the increasing subspecialisation, whereas as a GP now it's virtually impossible to find someone that, other than geriatricians actually, who look after the totality of the body. So what? Because you said in passing that was for the medical profession, but what role do you think that you have? And fabulous talk, thank you very much.
Right, so two things. I mean, firstly, I think that I and all the leadership of the medical profession, many of whom are in this room, have a responsibility to say, look, we all accept that the move to specialisation is fine, provided you retain generalism. It is not fine if you lose it. And several people in this room and others, for example, co-signed an editorial in the BMJ making this point. I see, for example, Bod Goddard in the audience, others, making this point really clearly. We've got to do something about it. This is in the gift of the medical profession. And CMO is one of the leaders of the medical profession, but there are many others. And I think we collectively have got to sort this one out. On GPs, the bit that isn't my job is trying to balance the books and try and get all the numbers right. The bit I do consider is my job and to worry about is that if you try and do it really fast, the danger is you'll get GPs into the places that are already GPs. And actually, my big worry is that if you look at the map of the UK of medical need against general practice, this is not an even distribution. And there are bits of the country which you go to, and they're lovely areas. You think, why would no one want to work here? You know, let's say you go to Margate. They're really struggling to fill every vacancy. So I think that the bit which I should be adding in is let's think about the areas where we really need them even more than we do anywhere else. Take your general point.
Great. Laura, was yours a coronavirus point or yeah, in which case, can you hang on to it? And we'll, I think I've got Anne-Marie Rafferty and this gentleman here. I can't see who you are. I'm sorry, the light is... do you want to put your hand up and then someone will get a microphone to you? Yeah. And then there's Anne-Marie. Yeah. Anne-Marie, do you want to go first? Yeah.
Yeah, cheers. Anne-Marie Rafferty, President Royal College Nursing. Thank you for a fabulous talk, Chris. My point was on geography, which Nigel had alluded to earlier as being one of the neglected areas that we that we under-analyse in healthcare. And just thinking of your rural and coastal towns areas, what can we do to actually incentivise people to go and work there? And would you consider pay systems to be part of that? And if so, would you be petitioning Secretary of State to change the pay systems for nurses as well as doctors, possibly?
Right, so I have two general principles, which is I never talk about money in public. My advice on money is private because it becomes in the political sphere, and the other is I don't talk about individual patients, which may be relevant to the coronavirus questions. But other than that, I do consider this as an important area to think about. I think I understand the medical profession better than I understand the nursing profession. I'm clear about that. In the medical profession, the biggest predictor of where people work is where they train. Yeah. And so I think that what we really need to be doing is getting training into the bits of the country which are actually weak at the moment. And I think that will, over time, now that doesn't solve the problem in the short term, but I think in the long term, that is probably the more durable solution as to how you do it. Pay differentials and so on tend to be relatively quick fixes, which very often are surprisingly undurable.
Yeah, I think Luella, we've done some research on that we can share. It's not the most effective method. And there's also the question about, do you want to live and work in these places? Gentleman here, yeah.
Yeah, so that was timely.
Say who you are, please.
Yeah, Jihad Malassi. I'm a GP part-time and clinical chair for Thanet CCG. Yeah. And I'm also, with my other hat, clinical director for Hospital Transformation Services. And I want to thank you both and Luella for coming to Thanet, for helping us with our hospital work and with our general practice PCN type work. Actually, you stole my thunder in a way, because I wanted to know what the strategic view is on how we link up what hospitals provide as anchor institutions, as well as looking at coastal deprivation, the indices that you've described and putting that in a package that we can deliver nationally. I don't know what your view is on that. I feel that locally and regionally we've done everything that we can possibly to recruit, to retain, to make life interesting, to offer dynamic jobs that cross sectors, that share jobs between secondary care, community care, mental health and so on. And now with the new university opening up its medical school branch, I think that will be an exciting innovation and an exciting jewel in the crown, as it were. But that's another 13 years before we get somebody at the end of that pipeline. So what is our answer to that?
Well, I think that, well, thank you. And again, enormous admiration for the work that you and your colleagues do there. There are no easy fixes on this, but the two things I think we need to start doing now, and someone, for instance, called it out from the audience, I didn't see who it was actually, but they made the right point, which is what we've got to do is make this an attractive place to go to and then an attractive place to stay in. And I don't actually think we really understand the drivers. And I think I get an awful lot of people coming in and telling me this is the thing which people really care about. And A, they almost never have any evidence. And B, they all have a different idea. So this is something where we actually basically need to ask the question. And then we need to arrange the incentive structures around the things that people really care about and use that to rebalance the system. If pay is one of them, fine. My own view is it may well not turn out to be a terribly strong part of it, but we have to go with the incentive flow because we're not going to tell people where to go. They have to be invited to go and wish to stay.
Yeah, absolutely. We had a session this morning about looking at technology, and I was just wondering whether you might reflect on what are your thoughts on the sort of burgeoning growth in various types of technology, everything from AI to new devices and new medicines that are coming on stream, and what sorts of aggregate impact do you think that's likely to have in terms of how we cope with some of the trends that we're seeing here?
What, in 1 minute?
Yeah, absolutely, yeah.
Well, I mean, let's start off with the Silicon Valley cliche that all technology is less important in the short term and more important in the long term than people think about.
We had that one this morning.
Yeah, I mean, which is broadly true. Yeah. There are some really obvious trends. I mean, AI, for example, clearly is going to be very important in pattern recognition. I mean, diagnostic radiology, diagnostic histopathology will be machine read within my professional lifetime, for sure. Quite a lot of the things people claim for it are not going to happen, pretty obviously. But if you look in aggregate, I think one of the things that is most striking to me is a lot of people assume that technology makes things more expensive. It doesn't. It actually can allow a less skilled person to do something which a more skilled person previously had to do. Now, a relatively quickly trained technician or I can do an echocardiogram and can be just as good as the cardiology consultant who's had 30 years of training in cardiology. And the same is true across the board. So I think a lot of what we should really in particular be concentrating on is those technologies that allow our medical workers, doctors, nurses, all the other professions to do their job better and quicker and probably with less training to achieve the same or better levels of healthcare. And that is a subset of all the things that are talked about. And my own view is that's where we should concentrate our fire. That's what will give us our biggest bang for buck.
Excellent, thank you. James, did you have a quick question? Do you want to? Our microphone. No, we do need to get a microphone to you, so perhaps if someone who's got one could, because the problem is it's live stream, James, so...
Oh, sure. So James Mountford from the Royal Free Hospital. It's nice to have a talk where you think, well, here's 4 questions I'd like to ask about each slide. So I'm just going to pick on the outpatient one. And the long-term plan says, I think it's 1/3 of outpatient appointments we're going to cull. And your slide suggests that may be more challenging than we had realised. Could you expand on that?
Yeah. If you just let us assume you just take the data from the OBR as broadly right. I mean, you quibble about the exact details, but let's say 6% a year on average in every area. I do not believe we are getting 6% worth of extra health out of that 6% a year growth. So it's made up of 3 things. Stuff shifted from inpatients, good. Stuff that's new medicine, that's doing something which we previously couldn't, good. And utterly useless activity. Now, you can all work out which is only good if you're the person being paid for it. So we can all work out in our own minds where we think they are, and they'll vary by different disciplines. But I think we should be taking a very serious look at this and try and see if we can strip out that last bit, which I think is quite a considerable part of it, without impinging on the other 2 bits. And that's the art, I think, of trying to achieve this. This doesn't strike me as impossible to do. Like everything, it depends on observing what's done, working out which bits work, and stop doing the bits that don't work. There's not much to it, more to it than that.
Yeah. So shall we move on and just ask, I think you were saying, you make a few remarks about coronavirus, and I think there's Laura Donnelly who's got the microphone. But do you want to say something first before
Shall I just do a quick summary, just to situate it, and then very happy to answer basically questions and anything. I mean, the key point to make, which is an obvious point, but I think can't be made strongly enough, is this is a global problem or it is nothing. So if this becomes a global epidemic, then the UK will get it. And if it does not become a global epidemic, the UK is perfectly capable of containing and getting rid of individual cases leading to onward transmission. I expect there will be some onward transmission in the UK. We haven't had it as far as we can see to date, but that's just a matter of time in my view. But if it is something which is containable, the UK can contain it. If it is not containable, it'll be not containable everywhere, and then it's coming our way. And at that point, we've got a strategy on this which has 4 tactical aims, and they're relatively straightforward. Contain, if we can contain. If we can't contain, delay, because we need to push this out into the period of the year away from winter. It also buys us some extra time to do research and understand this. It may give us some advantage because there may be lower transmission rates, in my view, in late spring through to autumn. So I think there are 3 reasons why delay is useful, but it may come at a social cost. Research, because we need to understand this better, otherwise we're going to have an inefficient response. This isn't primarily about new drugs and new vaccines. They're important, but they're probably for next year's thing if this becomes a major issue. But lots of things we can do now, repurposing of drugs, understanding, mathematical modelling, social science around this, and then mitigation for the health service so that the impact of the first wave, which will probably be the biggest, not absolutely, so definitely, is minimised because there will be a beginning, a middle and an end. And depending on how bad it is, the middle may be quite tricky. And we need to get ready and try and work out how we can actually basically front load or back load other activity. So the bit in the middle, that's what we're doing. And then it passes through. That's a summary of where we think we're going.
Great. Laura, you might just want to walk away from the speaker that you're sitting under for fear of blowing up the system. Yeah, thanks. Yeah.
Yeah, okay, thanks, Chris. You touched on a couple of things.
You need to just introduce yourself, if you would, please. Yeah.
Laura Donnelly from the Daily Telegraph.
Thank you.
Yeah, you touched on a couple of things I was going to ask about. Obviously, we're seeing a rising threat, and you talked about some of the measures to delay could have a social cost. So I wondered if you could sort of enlarge on that, and wanted to ask, when do you expect the first mitigation measures? What do you expect the first mitigation measures to involve if we do see an outbreak? And also, what could the public do to play their part in an outbreak situation? Would you be wanting to saying to people, try not to put pressure on GPs, try to avoid, be accepting of the fact there may be delays, non-elective care pushed back? And I think you talked there about, front-loading activity or back-loading activity. So if you're able to expand on those scenarios for the NHS.
I think you've just sneaked in a whole load of questions there.
I'm not going to be able to do justice to all those questions. They're all very good questions, but I would need 20 minutes to give a proper answer, but I'll try my best. In terms, the most important thing from my point of view is for us to firstly work out, which we're trying to do through a combination of science and modelling, which are the things which could delay this or flatten the peak. And flattening the peak is very good for the NHS. It may not be good for society, and we're going to have to think that through. And some of the things we have to do are going to come at a social cost. Everybody knows that the kinds of things you consider are reducing mass gatherings, school closures, which may or may not be appropriate for this particular virus. We don't know yet. We need to find that out. There are several other things. Now, to be clear, we're not saying we will do them, but we have to look at all of them and say, how likely are they to work, and what's our evidence base here? What's the social cost of this? Because one of the things that's really clear with this virus, much more so than flu, is anything we do, we're going to have to do for quite a long period of time, probably more than 2 months. And the implications of that are non-trivial. So we need to think that through carefully. The biggest thing we can do at this point, I think, is there are things which work, or probably work, and there are things the public thinks on perfectly reasonable common sense grounds work, and they're not the same things. And it's very important that we try and make clear that things that actually don't work and have a big social cost don't work, and don't keep amplifying things which are actually just socially dangerous and not terribly useful, and push over to the areas where we're going to have to, as a society, have a serious discussion about how we're going to manage these trade-offs between, let us say, school closures and changing the shape of the epidemic. These are serious questions. I think as a society we're perfectly capable of having them, but we need to be aware of the fact that there's no quick fix here. This is something which is going to be done really systematically, thinking through cost and benefit for everything we do. And anything that colleagues in the media can do to help, in a sense, amplify the serious debate and move away from the what I consider is utterly trivial debate, which just confuses people, I think is incredibly helpful. So I really would value help from people in doing this, because this is something we face as really quite a serious problem for society, potentially, if this goes out of control. It may not, but if it does globally, then we may have to face that. So that was a kind of a bit on the social things. And so remind me the other ones, because I was so keen to answer that one properly.
Well, just before you do, would you just enlarge a little on what are these areas of sort of mythology and mistaken analysis?
So, for example, I think there's a perfectly reasonable belief by the public that if we just banned a few flights, that's going to solve the problem. Actually, the modelling shows even if you banned a lot of flights, all you would do is delay things by maybe 15 days. If that was a huge amount of ban, that would be a lot of banning. But this kind of keeps on coming round and round and round. And yet there are things which really, really work. So this goes back to the other points. I now remember it. Yep. There are some things that really, really work. And by far the biggest two are actually washing your hands, which people underestimate. It's incredibly powerful, I'll come on to why, and preventing, if you cough and sneeze, putting a hand in front of it, hopefully with a handkerchief in charge of it. Why is that? Because there are only two ways this gets into you. By breathing in someone else's air, which they've coughed, that's for them, that's why you want them to put something in front of their mouth, or through your hands. Your hands are by far the biggest way in which you get germs from somewhere else into your mouth or eye, and that's the way you get infected. Everyone touches their face the whole time. No one else touches their face apart from their intimate partners. It's your own hands that do it. That's why washing hands really, really works. Washing hands protects other people, it protects yourself. And so the debate should be around these things that really do work, where people really can help. And the same is true about stopping coughing, stopping droplets getting into the environment, particularly in closed environments like these. Rather than on many of the other things where people, perfectly reasonably believe they're going to work, but in reality they don't.
Great, thank you very much. Brilliant tour de force talk and also summary on coronavirus. So we get 2 for 1. Thank you very much indeed. Thank you. Brilliant. Yeah. Good. Thank you.
Right, well, hello. And we're kind of rather lucky, I think, because as the last set of questions to Chris Whitty showed, it's a busy time, not just for the NHS, but for health systems globally. So we're very lucky to have Matt Hancock here as the Secretary of State for Health. Matt's going to talk for about 20, 25 minutes or so, and then we'll have a round of questions. So, Matt, go.
Well, thank you very much. Thank you very much, Nick, and it's wonderful to be here in this extraordinary setting and at this vital conference. And of course, the whole country is concerned about the developing situation on coronavirus, on COVID-19, and we're doing everything reasonably possible to keep the public safe. I want to start by praising the exemplary response of my officials, Public Health England, the whole NHS, and the wider health system. And I think you'll all agree with me, and everybody in this room will agree with me, about the brilliant work of the Chief Medical Officer, Chris Whitty, who's set out the plan to contain, delay, research, and mitigate the virus. Now, that plan will be driven by the science and guided by the expert advice, which is marshalled by Professor Whitty. And tackling this virus is imperative, and it's taking up the overwhelming proportion of my time. But while we grapple with the virus, I'm absolutely determined that that must not take our eyes off the long-term challenges that we also need to rise to, and the long-term changes that we need to make to our healthcare system to make it the best that it possibly can be. And that's what I want to focus on today. Delivering our manifesto commitments, of course, including 50,000 more nurses and 40 new hospitals. It was great to see the news this morning of over 8,000 more nurses in the NHS over the last year. And addressing the priorities of people, infrastructure, technology, and prevention that are the long-term priorities of the department. So at this conference today, I want to ask this big long-term question and formally set the health system a new goal. The question is, how do we ensure that in today's world that there is always public confidence in the NHS? In a speech to the Royal College of Nurses in 1948, Nye Bevan gave a famously gloomy assessment. He said, "We shall never have all we need. Expectation will always exceed capacity. The service must always appear to be inadequate." Now, I'm generally skeptical of those who say this time is different, but I want to argue today exactly that. My argument, and I appreciate this is quite a dangerous thing for a health secretary to say, especially at a Nuffield conference, is that Bevan was wrong. The service does not always have to appear to be inadequate, either for patients or staff. This time can be different. And the reason is that today's technology, unlike previous technological advances, allows us to do more in healthcare at lower cost. Now, I don't think that's ever been true before in the history of the NHS. There have been amazing advances like heart transplants and chemotherapy that have allowed us at greater cost to save more lives. And this is good. These are good technologies. But the power of modern technologies are that they allow us to improve outcomes and reduce costs at the same time. Radiology in the cloud is cheaper and faster than a system based on couriers and CD-ROMs, for example. In fact, Chris raised in the Q&A examples of improvements that also save cost. And while technology on its own solves little, technology that clinicians want to use because it meets their real-world needs, designed with their input, done with them and not to them, this has game-changing potential. And we know this because we can see it right across every other part of the economy, and we can see it in parts of the NHS. Get it right, and by the end of the decade, we can have an NHS that functions as a platform rather than as a set of loosely aligned, disconnected, incommunicative silos. An NHS focused on preventing sickness, not just treating it, enhancing life, not just prolonging it, where staff do more of what they came into medicine to do, caring and treating and healing the human things that a computer can never replace. And we can do that because we've removed or improved the grind of routine process. And to make that happen, I think we need to change the way we think about how change happens in the NHS. Now, policy makers love the idea, and I can tell you it's tempting. Policymakers love the idea that change is something you do with a top-down reorganisation and big bang structural reforms. It's why the last couple of decades are littered with failed attempts to transform the NHS by structural reform from on high. But guess what? it's not all about us policymakers. The answer to better healthcare lies less in complex reforms cooked up by the centre. We've tested that idea to destruction. It lies in millions of incremental improvements carried out at every level of the service, every day, by people who feel and are empowered to make things better in pursuit of a common goal. The small tweak to a process that improves patient flow. The trust that saves hundreds of hours of clinical time with access to real-time test results, for example. The streaming that manages record demand on our A&Es. These are the things that transform the NHS. Now, they don't happen on their own. They require strong accountability. They require the right data so the system can constantly learn about what works. They require resources, including, of course, the record £33.9 billion funding increase that yesterday passed through the House of Lords and will be enshrined in law. And it requires trust. And this is something about culture. Trust in clinicians to make those improvements, trust in local systems to serve their population as a whole, trust in everyone who works in the health service to seek out and make these improvements, and trust in patients to play their part in their own health. Now, this is how change happens in big organisations like the NHS. But this method of marginal improvements requires people also to have a common mission. And my case is that we must free people up to innovate. And in all the big organisations where freeing people up to innovate has worked, it's where you have a common goal. And for me, I think this is something that we can achieve in the NHS because it's so clear what the common goals should be. Today, I want to set out 2 goals for our healthcare system. Big picture goals, not just for the front line of the NHS, but for the system in its broadest possible sense, the department, the central bodies, social care, and the ecosystem that surrounds us. One is a clinical goal, the other a goal of user experience. Both are equally important. I want to stress that. I think they are equally important, and each reinforces the other. Now, the ultimate clinical goal, I think, is to increase healthy life expectancy in this country. As a nation, we've set the goal of 5 more years of healthy life expectancy by 2035. Not just adding years to life, but life to years. But this clinical goal is not enough on its own. Everyone in the NHS goes to work to serve patients, not just to treat them. Indeed, the whole NHS serves our country just by existing, by giving peace of mind to everyone, even if you very rarely use it. So the second goal I want to set is to increase public confidence in the NHS. Confidence that the NHS will always be there for us, that the NHS will look after us and care for us with dignity and respect, that it'll treat me as a person with a history and a future, not just a series of unconnected, siloed clinical episodes. Now, public confidence is not the same thing as public support, important as that is, or even public satisfaction with the quality of an individual treatment. These things are smaller. How you're treated at reception, whether the staff have pride, whether the hospital is tidy, whether somebody explains to you what's happened and keeps you properly updated. These things might not matter from a strictly clinical point of view, but they should matter to an organisation paid for entirely by the public, which exists to serve the public. And I want to draw a parallel to what's happening on coronavirus right now. We've seen this approach working. It is an explicit goal in our response to coronavirus, not just to tackle the disease, but to maintain public confidence. And we should take this attitude to health services in normal times too. In the second quarter of 2019, the NHS received 50,000 written complaints on various subjects. I don't know if you know what the one subject that accounted for the largest proportion of complaints was. Communications. It wasn't waiting times. It wasn't the clinical and medical treatment. It was communication. So I'm setting the NHS the challenge that it should be as good at process and admin as it is at medicine. That if you've got a chronic condition, you shouldn't have to carry a ring binder of notes from one appointment to the next because your provider can't access your full medical record. That we shouldn't be asking you to make a stressful journey into hospital when you could get the same result at home using modern methods. That when you're notified of an appointment, that notification should never arrive after the appointment was meant to take place. That is one of the most frustrating things, and it happens right now in the health service. The National Health Service must be just that. National health and the service. Not just a hospital system, but a service for the nation's health. So I want to take each of these three in turn, because they are all important. Let me take the national first. So if we step back and ask why the NHS is so important, one of the reasons is that the NHS is part of our national identity. We love it because it's always there for us unconditionally, through some of the best moments in life and through some of the worst. This is what maintains the public's support for the NHS, which is so important. As the Prime Minister puts it, it's like the whole country figuratively gathering around your bedside when you fall sick, doing everything it can to make you well again. But that shared ideal is one of the few things about the NHS that is truly national. Because the NHS is not some centralised command and control state like Bismarckian Germany, and I can assure you as Health Secretary, I know that. It's more like the Holy Roman Empire, a story of fragmentation and duplication and high levels of regional variation. There's no single national back office, for example. Local providers have their own teams and systems for every conceivable non-clinical activity, from booking appointments to registering patients to organising staff rotas to ordering medical supplies, with massive duplication of effort. Nor is there a national data architecture. I first discovered this through personal experience, like many people do. My sister had a very serious accident. Some of you may know about this. Just before I became Health Secretary, she had a near-fatal brain injury. She received amazing life-saving support at Southmead Hospital in Bristol. She underwent 6 months of rehabilitation. And when she went back to her GP to get approval to reapply for her driving license, despite having known her all her life, her GP had no idea about the injury at all. No record, no details. And that is not a unique experience, it's an everyday occurrence. So when I say national, there's another aspect to national as well, and this has been highlighted acutely by the report by Michael Marmot this week. We have a checkerboard of local variation. Look at life expectancy. I think this is a very serious problem. A person born in Wokingham can expect 72 years of healthy life, just down the road from here. 72 years. In Nottingham, it's 54 years. In Blackpool, 1 in 4 women smoke during pregnancy. In Westminster, it's 1 in 50. So this is the first part of our project. In the 2020s, we must make it our mission to put the national back into the National Health Service. At the patient-facing end of the service, that means levelling up across healthcare, ending some of the postcode inequalities. So, for instance, your chance of seeing a GP doesn't depend on where you live, not just delivering the 50 million GP appointments, extra GP appointments that we committed to in the manifesto, but making sure they're focused on where they're needed most. Being a national service means having consistent standards that all patients can expect. You want local variation where there's local variation in conditions, and it'll be a central task of the new integrated care systems in every part of the country to take into account local conditions when improving the health of their populations. But we need less unwarranted variation in both commissioning and delivery of services. Why should 3 cycles of IVF be allowed in some parts of the country and some other parts offer none? A local part of the NHS deciding it's okay not to offer IVF with no accountability, it's absurd, it's unacceptable in a national system. It also means, national also means, having a platform approach to the way we deliver some of the things like the back office. Now, what do I mean by that? Building wants at the centre where it makes sense to do so suppliers and commissioning bodies don't have to recreate the plumbing each time. Look at one of the things I announced over Christmas, one of the most popular things I've said as Health Secretary, maybe a low bar. the NHS login, our National ID Assurance Platform. It takes many minutes to log in to the many, many different systems. And the number one best thing I've had feedback on from clinicians is the NHS login once announcement. And there's a whole new growing ecosystem of this sort of service, from GP appointment bookings to remote consultations to digital maternity services, all of which require you to prove who you are. And we need to make sure that we do that simply and we do it once. We're also looking at a consistent way to identify staff across the system. But the most impactful and clinically useful platform we can create is a national data architecture for the NHS. It's a massive opportunity for patient experience, clinical excellence, and the next generation of research. Fixing this is not, repeat, not about building a single giant centrally owned patient database in the basement of NHS England. Instead, it's about creating an architecture so systems can talk to each other and so data can be safely accessed where it's needed. The whole country. We need the whole country to be covered by local shared care records. We need those shared care records to be able to speak to each other with common standards. We need clinicians to have the trust and confidence to use them. And I can announce that we've just published our new draft digital health technology standard designed to make it easier to commission great new digital health services. It requires developers to follow these standards on interoperability if they want us to buy their stuff, and there's much more to come. And today we're kicking off our engagement on our tech plan for health and care, setting out how technology will support the delivery of the NHS long-term plan. And this includes establishing what good looks like in all forms of tech-enabled care and clarifying who pays for what and what we need to do to drive these improvements. And I'd urge all of you to get involved, everybody, whether you're interested in technology or not, because developing this plan should not be left to us at the centre. It is too important for that. Now, there will never be a big bang moment when we flip the switch and say the problem's solved. Like all genuine improvement, this is an incremental, iterative process. And done right, this approach must be entirely embedded in evidence. It's about what works. And the evidence is abundant, it's strong, and it's growing. Bringing technology in the NHS into the 21st century works. Modern use of data works. Ignoring that evidence is as much of an error as blind faith in any technology. So I'm determined to drive this agenda, because if we get the technology and the data right, we can do incredibly powerful things. So that brings me then onto my second letter. Health. According to the best evidence we have, only about a quarter of what leads to these longer, healthier lives is the result of what happens in hospitals. The remainder is down to genetics, the environment, and the lifestyle choices that we make. As a healthcare system, I think we actually have quite a strong track record on both improving some of the broader determinants of health, the inputs, and the health outcomes. So smoking rates, I talked about the local differences in maternal smoking rates, but smoking rates have halved in the last 35 years, and we now have one of the lowest rates in Europe. We lead the world in managing long-term conditions like diabetes, with fewer than 1 in 1,000 patients being admitted to hospital in any given year. Deaths from cardiovascular disease have halved since 1990. Cancer survival is at an all-time high, male suicide at a 31-year low. We also have some of the finest public health officials in the world, and I'm very grateful for the work that they're doing in response to COVID-19. But we can and must go further. For most of its 70 years, the NHS has been focused on curing a patient of single illnesses, putting ever more funding into big acute hospitals. This has had an impressive impact on lifespan, but as it enters its 8th decade, as we've seen, those increases in lifespan have started to slow. And it's clear that the NHS also needs to focus more on health span, the number of years a person can expect to live healthily and independently. And that is true for the wider health system too. Prediction and prevention are mission critical to delivering these 5 extra healthy years of life. It's partly about smarter use of the way we use NHS resources, things like dedicated alcohol care teams in hospitals, where they have the highest rates of alcohol-related admission, or much more support to help people quit smoking, and making sure that our screening programs are radically improved, so they're easy to use and no one gets left behind, and putting more resources into primary care, community care, and asking our army of pharmacists to do far more to keep people healthy in the first place. Like recently, rolling out non-drug therapies through social prescribing right across the country. So this approach is all about recognizing that not all the answers are in the NHS. We need a cross-government action on air pollution, for instance, properly insulated homes, urban design, supporting cycling and walking. And again, people have been talking about this since the 50s, and why is this time different? Again, I think there are big things that mean that we can move faster. Firstly, we have more and better information than ever before, and a lot of this is distributed outside the system on Fitbits, smartphones, and other internet-linked devices. And we're also creating increasing amounts of genomic data, including our project to sequence 5 million genomes. That is all data that helps us to fill in the big gaps. And there are still big gaps. I just want to pick out a couple. Big gaps in our knowledge about what works and for whom. Take drug responsiveness. A few years ago, Professors Eric Topol and Nicholas Stork put out a study showing that the responsiveness, the intended clinical response of the top 10 drugs by gross sales in the US, overall, 75% of patients receiving those drugs did not have the desired or expected benefit. It ranged from 1 in 5 patients with schizophrenia deriving a benefit from the market-leading schizophrenia drug to only 1 in 16 patients with MS. This is known as the number needed to treat, which means the number of patients you need to treat to prevent one additional bad outcome. Until we can safely use all the data that we hold about individual patients, that number will remain stubbornly high. Cancer is another example where we're making a huge amount of progress on this. The major trials funded by NIHR show that many people given surgery or radiotherapy for prostate cancer will do no better than those without treatment. But we don't know which people in advance. But increasingly, we can marshal all the data about a patient and then treat each patient as an individual, finding the treatment that's right for them, bringing the number needed to treat closer to 1, saving the NHS and patients the cost and pain of unnecessary treatments. So that's the first big change that we can harness. The other big difference is that we now have the computing power to do the marshalling. Already, AI can perform as well as human radiologists at detecting certain cancers. Let's embrace that. AI recently developed at MIT found new antibiotics for tackling drug-resistant microbes. This is why we've set up a 250 million AI lab in the NHS to identify and, crucially, to scale the most promising technologies and to get the regulation right. And by the end of the decade, we need doctors to have all the relevant data and the training to use them about the patient in front of them. Not just the patient's full health record, but the genomic data and any self-generated data they want to volunteer and data on similar cases. And we need to have the AI and the other decision support tools to process that and need to have them doing the right training to understand it all. It can be done, and it's being done in the most advanced parts of the NHS. We need to turn the NHS from a national hospital service to a health service, making sure that we're focused on the health of the patient. And that finally brings me to the third thing that I want to say. The NHS. The S is for service. I've drawn a deliberate distinction between health and service, between clinical outcomes and public confidence. To help me explain, maybe I could tell you a story. I mentioned the problem of different care settings not being able to access patient records. At Barts in East London, they've solved that problem for chronic kidney patients. It works like this. The renal unit at Barts have a data sharing agreement with 160 local GP practices, allowing consultants remotely to view full GP records with patient consent. It means they can see a patient's creatine levels over time, which of course is a crucial indicator of kidney health, as well as the medical history, comorbidities, past hospitalizations, and so on. Following reviews of the notes, the consultant records her advice on the Barts system and the practice gets a notification. The small minority of patients who need further investigation then get triaged into traditional face-to-face clinics. The vast majority of patients don't ever have to go to the hospital, and they get reviewed much faster. Before the virtual kidney clinic started, The average time from referral to the first outpatient appointment was 64 days. Now the time between referral and assessment is less than a week. It's too early to say if it's improved clinical outcomes, but that is not the point of the exercise. The point was to improve the service. Because if you're in a nursing home with chronic kidney disease, then getting into central London to go to Barts can be a real ordeal. And the virtual clinic improves patient access to the NHS while removing a whole rigmarole of arranging transport and travelling in and worrying about tube delays and tracking down missing referral letters and sitting around in waiting rooms when you're not very well. Not only did patients enthusiastically consent to their records being shared, but like all the best service improvements, they were amazed that it wasn't happening already. There are loads of other areas where we can make the service better. And as I said, the medical advances in the NHS are amazing, but the process advances are far too slow. The Royal Mail should not be the default mode of communication between patients and providers. Patients should have access to their own medical records. We know it improves the quality of the data where they can spot a mistake, and it can be life-saving. In Southampton, they gave prostate patients real-time digital access to their PSA results as soon as they come out of their lab, unmediated by a physician. It's incredibly popular, even amongst older men who don't necessarily have the digital experience. And the reason is that people want to manage their own care. And wherever possible, healthcare should come to you before you have to go to healthcare. This is not as radical as it sounds. And I know that there are some people who scoff at this agenda. But let me give you one example that we now take as read. 30 years ago, you had to go to a doctor to get a pregnancy test. Now, of course you take the test yourself before you go to the doctor. Of course you do. And it's not just about the technology. The capital building program that we've got is not just about those 40 new hospitals, it's about meeting rising demand and ensuring the best possible service for patients as well as clinical outcomes. Because patients don't only care about the clinical treatment, they care that the hospital looks smart, that it's clean, that staff are friendly and well motivated, that the food is good, and crucially, that they're told clearly what's going on. These are the things that matter to patients, and they need to matter to every single person in this room and every single person who works in the service. For the NHS is a service, or it is nothing, and we are at the service of the nation. At Great Ormond Street, they now note a child's favourite food or football team to help the staff make a connection with the child. I love that. A simple change that can make an incredibly stressful experience just a little bit easier. So there you are, the NHS, our national health and service. And to entrench and underline the central importance of that sense of service, that's why I'm setting today the explicit goal of raising public confidence in the NHS. I think overall we have a hugely ambitious and exciting agenda. Everyone here has a part to play. It's first and foremost about the people, about how we get the most out of our people, and about how we get more people and how we motivate and incentivize and support and train. And I'm very proud to see the staff survey results moving in the right direction. And it's brilliant news that we've increased the number of nurses in the NHS by over 8,000 in the last year alone. And with the people plan, we'll set out yet more about how we can support every single person in the NHS to reach their potential. It's about infrastructure, fixing the roofs, getting the modern buildings that we need to deliver modern services closer to home. It's about prevention of ill health to reduce pressures on the system. And yes, it's about technology, because there are historic problems that we can now fix by bringing the technology of the NHS into the 21st century. We all know that demand and expectations are rising. We can't afford to stand still. We must reshape our health service to harness the resources that the modern world can offer and deliver a national health service of which we can be proud. Thank you very much indeed.
Whichever you prefer. Matt, thank you very much indeed. That was very wide-ranging. Another goal for the NHS to achieve. Tiny bit of me might at some point ask, how are you going to measure confidence in the service?
Yeah.
But before we do that, can I just say, I'm aware there's a good sprinkling of my old trade here, the hacks, so to speak, and they are going to want want to ask about coronavirus, but we are here to do some other things. I promise you we will come to it, but first of all, we'll do some other things.
Yeah.
Can I just pick up a couple of points from the speech? You were suitably scathing about Big Bang, top-down reorganisations.
Yeah.
But there is a proposal for some NHS legislation.
Yeah.
So can we take it from that you have no immediate plan to make integrated care systems statutory? And secondly, there's a lot of reports that the government would like more powers of direction over NHS England, greater control. What have you not been able to do without that control so far?
Well, I don't think that that designing system improvements from Whitehall with this Big Bang approach is the way that you improve service delivery on the ground. The way you improve service delivery is by empowering people on the ground to make incremental improvements and listening to them about improvements that need to be made. So with the bill that was announced in the Queen's speech, the primary goal of that is to reduce some of the burdensome bureaucracy that previous reforms have put in place, that for instance, disallow the integration between primary care and community care. People often sitting in the same office, not allowed to directly communicate with each other for legal reasons. And also to empower the ICS principle of population health. But I want that to be a bottom-up driven process. We've already got many parts of the country where ICSs are working very well, but I don't want to say everybody will be will move at the same pace. People need to move at the pace that works for that system.
Right.
The ICS principle is absolutely where we're going, and we've got to get the powers right for that. But it is but it's got to be a bottom-up type reform that goes with the grain of how we allow people and help people and remove the barriers to people making improvements locally.
Right. And does the Secretary of State need more control over the actions of NHS England?
Well, there have been questions raised about when you merge NHS E&I, for instance, which were designed in the 2012 Act to be counterbalancing forces within the system, and they've been merged in order to reduce the bureaucracy.
Yep.
But the primary goal of this piece of legislation is to remove the burdens and the barriers that get in the way of people making the incremental changes on the ground. That is the way I think that all big organisations improve.
Yeah, great. One of the priorities you mentioned in your speech was prevention. We still don't know what the public health grant is going to be for the coming financial year, let alone for a longer period. It has been squeezed badly. So if prevention is a priority, in a sense, where's the beef, so to speak?
Well, the beef is in a very broad agenda, of which the public health grant is a small piece. The public health grant is increasing this year, and we'll get the exact allocations out very soon. But actually, prevention is a much broader agenda, as I tried to set out. The reducing air pollution is part of the prevention agenda. That doesn't come through the public health grant. It comes through DEFRA policy.
Yep.
Improving housing is and making it more the design of housing more pro-health, and in particular more pro-strong mental health.
Yep.
That's a prevention agenda. So, of course, the public health grant is important, but it is a small part of the overall prevention agenda.
Right, right. And could I just come back to one other bit, which is, this is entitled The Government's Vision for the NHS and Social Care.
Yeah.
Are care workers skilled workers?
Oh, I think they are, yes.
So how will they be able to come in under the current proposals for immigration control?
Oh, well, the proposals allow for a points-based system, and we've got to set out how that'll work. The important thing about the immigration system that we're bringing in is that, and I suppose this is a consequence of leaving the European Union, is that it's the UK government that'll be able to decide how to set these rules. But I'm acutely aware of
But the way they seem to be set at the moment is unlikely to allow immigration for that class of worker.
Well, you've seen how we've responded to the challenges of needing to increase employment in the NHS and bring in more people, nurses and doctors in the NHS with a specific NHS visa. And the Home Secretary and I have an ongoing dialogue about how we can make sure this system will work for social care. But I can't prejudge that.
But there is an
set of
ongoing
discussions.
dialogue. There is an ongoing dialogue. Right. The other thing is, of course, the Prime Minister promised to fix social care once and for all.
Yes. That's right.
And we've all been
We're
waiting
on it.
for about 30 years for something.
No, I know. Look,
and can I just make one point? You know, the Do Not Reform, the Care Act, is already on the statute book. You start with that now.
Well, we had a debate in Parliament on Tuesday about this, and there I said that the failure to deliver reform to social care hasn't been a failure of policy making. It's been people not recognising that this is an exercise of political economy. And we've got a plan, firstly, to seek consensus and to start doing that within 100 days of the election, and we are, I think, on day 78. Secondly, to put more money in the short term, and we've done that, increase the spending power next year by £1.5 billion. It's a 4.4% overall increase in local authority spending power. And then third, to ensure that we have a system in which you don't have to sell your home to pay for care. And I think that's very important for maintaining public confidence in the reforms that we're going to propose.
If you stumble across the cross-party agreement bit, you are in a government with an 80-seat majority, so
it's
decide what is right.
Seek cross-party consensus.
Right. Okay, fine. Let's open it out. Could we just save coronavirus questions for a moment? Yes. Sorry, the lights are in my eye. I can see a hand, but not who.
Thank you very much, Secretary of State Anne-Marie Rafferty, President of the Royal College of Nursing. It might all be dangerous to quote Bevan, because at the beginning of the National Health Service, he did describe the shortage of nurses as approaching a national disaster, which undermined the very viability of the NHS. That was in 1948. And of course, we do have a national shortage of nurses, and there's a very ambitious target, and I think would speak for Donna as well on this, that the Royal College of Nursing is delighted to be working and helping to provide that. But in my day job, we did some research that also demonstrated that a key way of building patient satisfaction and converting that into public confidence in the NHS was actually recruiting and ensuring sufficient staff in the service itself.
Yes.
But it's not just actually registered nurses which we need, it's the proper skill mix and indeed the actual shape of the workforce, because at the moment we lack sufficient progression of senior nurses into the top position. I mean, there's just far too few coming through the system to be able to support the hordes of nurses beneath them, as it were. So it's building that support structure. So 50,000, is great to help you to get there, but that's something of a kind of down payment to help deal with the vacancies. And we've got to build in the long term beyond that. And I just wondered what your thoughts were for the beyond the 50,000.
Okay, brilliant. There's a Lyndon Johnson had a phrase. He said, in politics, people only ever ask, what have you done for me recently? We only set out the 50,000 target in November, and it's great to have the RCN asking for more. Of course, we've got to deliver the 50,000, and we will, and we're working together on it, and I'm very excited about it. But I totally agree with the premise of your question, that is only part of the workforce answer. The people plan is intended to, and will be, broad right across all elements of nursing and all elements of the people who work in the NHS. I found it utterly astonishing that when I arrived as Health Secretary, there wasn't a Chief People Officer for the 5th largest employer in the world. Absolutely nuts. And in the past, people planning, workforce planning, has been some sort of top-down statistics exercise, as opposed to working with the 1.4 million people who we've got. And so all of that is changing, and I think that Prerna is doing a brilliant job as the first Chief People Officer. I think it was telling that we had to go to the United Nations to hire someone, because it means that she can work with all the different constituent parts of the NHS using her diplomacy skills. And but the nursing, the 50,000 more nurses is incredibly important. As I say, 8,570 announced this morning. Good start. But if you want a proof point for me demonstrating that I agree with you, it is that when we set the new bursary up immediately after the election, we did not set the bursary just for nurses, but we set it for AHPs as well. And that, in a way, shows our commitment to this broader agenda.
Great. Nick Black. And
Nick Black, London School of Hygiene. I'm delighted to hear your enthusiastic support for innovation and recognition that in 1.5 million health and social care workers out there, staff, got brilliant people with entrepreneurial skills to really innovate. And to hear it from the Secretary of State saying you will empower and support that was really welcome. I share your view that that's how the transformations are going to come, not by top-down levers. Later in your talk, particularly around under the area of national, I got a strong message about much more traditional command and control approach, an almost abhorrence of variation between different parts of the country.
Yeah.
How do you reconcile those?
Yeah, that's a great question. And I'm very grateful for the opportunity to set it out a bit more. And I used IVF as the example. I think that the best way to run a large organisation like the NHS is to have national standards that everyone must meet, and then huge amounts of empowerment to the local in delivering on that. Of course, we do this, for instance, in every Royal College, which sets clear national guidelines as to how any particular practice area of medicine ought to operate, and then, of course, gives the clinician full professional freedom on the ground to get on and implement those as they best see fit. There's a wonderful quote which says, don't tell somebody how to do something, tell them what you need done. And so these standards should be thought about. So IVF is the best and most egregious example. It is not for a CCG to decide whether you should have 0, 1, 2 or 3 rounds of IVF available. The idea in a democracy with a national service that a local body which does not have democratic legitimacy, it's different when a council does it because they are elected locally, they should make what is in effect an allocative decision between different parts of the country. And there are other examples on that. I think some of these things are already set nationally, others ought to be. And then there's another part of what I was trying to say on the national, which is about more about outcomes rather than policy, where clearly we need more focus in some areas, and in particular some quite strong intervention, for instance on maternal smoking, which I think is something that is unbelievable in terms of the inequalities that it leaves behind in the next generation too. So what I was trying to say is that what we should do nationally is consider and set national standards, and then we should leave local areas to do their very best within those tramlines.
Right. Over there, thank you, Anita. I'll take one more general question, and I will come to Corona.
Anita Charles from the Health Foundation. I wanted to pick up the question of the social care workforce, where the Migration Advisory Committee, in all their work on the new migration policy, was very clear that at the heart of the problems with the social care workforce, which undoubtedly will be exacerbated through the migration changes, was poor terms and conditions, which linked directly to a lack of funding. And so we have in development an NHS People Plan. You are Secretary of State for Health and Social Care. We have no social care workforce plan. Apprenticeships that starts in social care have halved over the last year. Many of the staff are on national minimum wage, and we have rocketing very high turnover. So what is your responsibility in the context of a changing migration policy to provide leadership on the social care workforce?
Well, of course this matters, and it's important not just in terms of immigration, but you're quite right to raise the broader issues. Now, funding into social care has risen in cash terms by 11% over the last 4 years, and that's obviously a good thing. And you mentioned the national living wage, because one of the issues in social care is what I regard as skilled jobs being done by people on the national minimum wage, as was, and now the national living wage. I'm a huge advocate of the rising national living wage. I was a big champion of it being brought in. And even though it has a fiscal impact on my department, I'm a fan of it going up because one of the solutions to social care is to ensure that there is a more highly skilled, highly paid workforce, and that we don't just rely on absolute rock bottom wages. And some social care providers do this and do it brilliantly, but it is tough and the margins are very tight. And this is why we need that long-term solution that we're committed to provide.
Right, thank you. I'll take a coronavirus question. I will take it from a journalist. Victoria?
You don't have to say journalist with such feeling.
I care about it. 40 years I spent doing it.
Victoria MacDonald from Channel 4 News. There are at least, I think at the last count, 13 schools that have decided to close down. You have consistently said that they don't need to do this, but does this not suggest that they are not trusting your advice?
No, we've said that there does not need to be a mass closure of schools, and that the individual decision is, of course, for the head of that school, and they should take into account the professional advice that is being provided through the Regional Schools Commissioner system. It's very important that, of course, schools will and want to protect the health of their students, but we've got to do that with decisions that are driven by the science, and that's why we've put in place the advice for schools when there are pupils who have tested positive for coronavirus. So we've made the advice clear. I entirely understand the desire of every head in the country to ensure that their pupils are safe, and what we have to do is make sure that the advice is available so that they can take on board that scientific advice.
Chris? Oh, sorry, I have to microphones on, coming that down here.
Chris Smythe from the Times. Professor Whitty talked earlier on about if we do get to a pandemic situation, you might need to think about measures like shutting down mass gatherings and so forth, but it would depend on how much disruption society was willing to put up with to ease the pressure on the NHS. I mean, when it comes to things like, getting rid of the end of the Premier League season, London Marathon, whatever it might be, how much disruption do you think the public is prepared to put up with if we get to that situation?
Well, we want to minimise the social and economic disruption subject to keeping people safe. And of course, that's always going to be a balance. And we're going to be led by the scientific advice into what works. And I think Chris was very wise when he was describing that there are some measures that might sound like a good idea, but don't have a scientifically advised benefit. And they're the things we really need to avoid. And then there's another group of things where they may have a benefit in terms of keeping people safe from coronavirus, but they also do have an economic and a social impact. And there we have to balance those in order to keep people safe.
Nigel, I'm running over a bit, but that's permissible, isn't it? Yep, right. Hand over there.
Thank you. Hello, Emily Morgan from ITV News. Given the seriousness now of coronavirus, there is obviously huge public concern about it. There is also huge public confusion about the advice being given to individuals. Isn't it time now that the Prime Minister came out to reassure the public and set up a task force to deal with it?
Well, we have a very clear governance system in government for how we are dealing with this crisis. I am updating Cabinet. I obviously speak to the Prime Minister regularly on this question. And then I'm chairing a weekly COBRA which brings together the cross-government response, because many of the responses are outside of the department, and I chair that weekly cross-government COBRA meeting. So we have the governance in place. We have a drumbeat of COBRA meetings and meetings with the Prime Minister and reporting into Cabinet, which is how a government should function in order to deliver the very best decisions based on the science to keep people safe.
Fantastic. I'll take two more questions, if they're short, and ideally not about coronavirus. There's a white shirt there with a hand up. Sorry, I can't quite see who it is. The lights are...
Hi, Lawrence Dunhill from HSJ. Can you give us an idea when the review into the waiting time targets is going to be published, and any clue as to what's going to be in it?
Well, this again is going to be clinically led, the clinical review of standards, I presume you're talking about, which Steve Powis is leading on, and we expect to publish in the coming months. It's very important here that we make changes. If we make changes, then we make the changes that are advised by the clinicians to improve flow and improve patient safety, at the same time ensuring that we have the accountability that I was talking about earlier, that is so important, and ensure that we if we make changes so that they improve the way that emergency departments can operate.
One more. Yes, there.
Naomi Fulop, UCL and Whittington Health NHS Trust. Really pleased to hear about your focus on service and the service aspect of the NHS. We're going through a winter of the poorest performance of the NHS, figures just published this week. Everybody in this room will either have experienced or have family members and friends who are struggling to get to see their GP, who have elective surgery cancelled, who are waiting for long times on trolleys in A&E. How do you think that relates to building public confidence? Yeah. What's your responsibility and what are you going to do about it?
Yeah, so these are, of course, important parts of delivering good service. I mean, emergency departments actually, in terms of their performance, have been seeing more people than ever before. There's 1 million more people. This is a question of increased demand, but of course it then leads to challenges in terms of access. The point about public confidence is that yes, waiting times are one consideration, but actually when you ask the public, they're only one consideration, and making sure that people get high quality communication, both about waiting times and the process, but also about their treatment, is the top cause of complaints. And making sure that staff are well supported and have high morale is actually also extremely high. So we should not judge the NHS simply by one performance metric. We should judge it by the overall benefit that it gives to the public and in particular patients. So I'm determined to tackle the performance issues that you raise, and the increase in money going in and that increased hiring is going to be very important for that, and harnessing all the modern technology that we can get our hands on that works, but also making sure that that is done in such a way that patients feel the benefit in the service that they receive.
That's great. Matt, thank you very much. It's been very good to have you here. Take care.
you to take your seats, including the panelists. Welcome back for the final two sessions this afternoon. And we've heard a lot today about what you might describe as macro policy. We're now moving to what you might describe as the kind of meso policy level, getting closer to the actual front line of what clinicians do on the ground. And the NHS has a long history of having three-letter acronyms. And it's also spent at least the last 25 years trying to work out how to overcome the fragmentation that's been caused by successive reorganisations. So I had a look earlier today at the NHS Confederation acronym buster, which I highly recommend to people. And that lists at least, I got bored after a while, at least 20 different acronyms that relate to collaborative working that have been used over the years. So people remember LDPs and HIPs and the like? Yeah, I'm getting a few nods. So what we've got today around our panel are people who represent the latest incarnation of those three-letter acronyms that represent system working. We've got colleagues from the ICS, the Integrated Care System, from the ICP, Integrated Care Provider or Partnership, take your choice. In fact, there are 3 different definitions for ICP in the acronym buster, and colleagues from the PCN. So what I'm going to do is to ask each of them to introduce themselves and to talk to us in turn about, not about their governance structures, but about what they're actually able to do now and the things that they're actually starting to do on the ground that are making a difference to the people who use services, and what they're able to do now that perhaps they couldn't do before, and what's still getting in the way for them. So Claire, you're going to kick us off.
Thanks, Helen. So hello, I'm Claire Fuller. I'm a GP and I'm the lead for the Surrey Heartlands Integrated Care System. So Surrey Heartlands is, obviously it's not a real place, it's a made-up term that describes nearly all of Surrey. We're a Wave 1 ICS and we've got a devolution agreement population about 1.3 million, and we have 10 statutory organisations within our footprint. We're nearly co-terminus with our local authority, and it's that relationship and that partnership that's critical behind a lot of the work we've done. We used to have 3 ICPs, we now have 4, and an ICP for us is an integrated care partnership and describes the flows of the population flows that go into an acute trust, and we have 4 acute trusts within our footprint. We have 24 PCNs, so primary care networks. So we now know from the operating guidance what an ICS is there to do, which is lovely. So ICSs are there for system transformation and system performance management. And in my role as ICS lead, I lead assurance of the system. And I'm surprised actually that since I've been here, I haven't heard anybody talk about the magical system by default, which now seems to be the new magic phrase that goes on. The thing I think ICSs are actually about is population health and reducing health inequalities. And I think the best way to describe that, I'm going to give you an example, which is about how we've tackled the first 1,000 days, which is one of our priorities in Surrey Heartlands. So if you look at the early years indicators across Surrey, actually we do better than average. Our children do very well. But what that does when you take it as an average across Surrey is it hides the fact that within that there are pockets of inequalities. So if you lived in a deprived area of Surrey, if you receive free school meals, if you're part of the Gypsy Roma traveller population, if you have a learning disability, or if you're a young carer, your outcomes will be a lot worse. So if you're born in Spelthorne rather than born in Esher, if everything else is equal, from birth we already know you will die 6 years earlier. Free school meals, so one of the early years indicator we look at is your level of development at the end of reception, so age 5. On average in Surrey, 78% of our children receive rated as having good levels of development age 5. If you receive free school meals, 29% will be rated as having good development, which is just a shocking difference. Gypsy Roma travellers we've got are our largest ethnic minority group in Surrey, and we have the second largest population across the country in Surrey. It's well documented the poor health outcomes for those populations. So what have we done in terms of actually improving the health inequalities for those groups? So we've worked with communities. So rather than doing the classic top-down, send out a questionnaire, send out an invitation, we've actually worked with communities. We've set up a citizen panel that is demographically representative by postcode and over-recruited for carers to make sure that voice is statistically significant. We have an outreach Gypsy Roma traveller worker who goes into the communities. And then particularly, so our immunisation rates are terrible. So in Surrey, our immunisation rates were below herd immunity. So that means in Surrey, people will die from preventable disease. So instead, again, of just sending out letters saying come for an appointment, we've gone to talk to people. And actually, what's really interesting is there was an assumption it was very much Wakefield driven, but when you actually listen to parents, it's about access. They can't get in to get the appointments that they need. The appointments are in the wrong places at the wrong times. And actually what we're starting to do now is work with food banks and do the immunisations there, do mobile clinics that drop off and pick up time so that women can bring, also mums can bring their children. Using technology differently, we've got the delightfully named BadgerNet, which is our maternity record, which is accessible from all of our acute trusts, and women hold on their phones so they can take it wherever they go. And we have a co-located maternity helpline. So all the external calls that used to go to labour ward now go to the ambulance service, where we have a rotating strategic midwife who takes those calls. And the impact of that has been to actually create an extra person per shift on labour ward. Instead of having somebody doing this the whole time, actually those calls are taken, and with a 30% reduction in conveyances to hospitals, which is a massive impact for women. We've got a Children's Workforce Academy, which is doing leadership and OD across health and care for people that work in children's services. And then from April, we're going to move to a single integrated commissioning team for our children's services, which will be led by the local authority. So the interesting thing is, what is different about being an ICS? So if you look at how we would have done this 5 years ago, so 5 years ago, somebody would have come and said, what are you going to do for children's? And we would have gone, we'll look at the NHS pathway, we'll set up a community clinic, put a paediatrician out in a GP surgery and think we've done marvellously well. And yes, that's still quite a sensible thing to do, but in terms of improving outcomes for the population, that will improve your outcomes by 10%. And we know that unless you work with partners, with education, with health, and do the preventative work, you're not actually going to unlock the full potential to improve the health inequalities of your population. So the working in partnership and actually addressing the wider determinants of health are the thing, for me, that make ICSs different. And that, for me, is why that's why we should all be in an ICS.
Thanks, Claire. Now, these things are not mutually exclusive. ICPs can be within ICSs. And Matthew, do you want to talk to us about what's going on in Croydon?
Yeah, thanks, Helen. So I'm Matthew Kershaw. I'm the Chief Executive of Croydon Health Services Trust, but I'm also what's called the place-based leader for health in Croydon. And my job is to run the trust as an organisation, but more importantly, particularly in today's context, to try and create a system of health in an integrated care partnership in Croydon. And to do that, we've done something quite different in that we are, in essence, running Croydon as a single entity. Some people think that I'm both Chief Executive of the Trust and Accountable Officer for the CCG. That's not true. It has been said, but it's not true, not least because that's, at this stage, illegal. We do many things differently, but that's not one of the things that we want to try and do differently. What I do, though, is manage the delegated authority from what will be South West London CCG come April the 1st, 2020. So in a few weeks' time, we will have a delegated budget from South West London CCG, delegating resources, responsibility, decision-making to a local place-based committee, which I will run with the chair of the Trust and also the clinical chair of the Croydon Place within South West London CCG. So it is about bringing power back to Croydon for decisions to be taken closer to the population that we serve, because we believe very passionately that ICSs definitely have a place, and we work strongly within our South West London ICS, but we think that evidence suggests that most transformation happens at a place level and a neighbourhood level and not at an ICS level. So what we're trying to do is keep as much responsibility and authority locally within Croydon. Now, to support that, we've got a bunch of single executives working across the totality of the Croydon health space. So we have a single executive team working across the whole piece. Now, that's been quite tricky to implement, and we're now at that point, and from April of this year we'll be running it as that Croydon single system. Now, we think that's important in Croydon for the reasons I've just described about transformation happening at that place, but also because there are some conditions in Croydon that we think make it even more important. So Croydon is a very connected place. If Surrey Heartlands doesn't feel quite like a real place, Croydon definitely does, I can promise you. It's a 400,000 population, it's very diverse, it has huge health inequalities, it has scale and challenge abound. What it also has is a very, very strong sense of place, strongest sense of place of anywhere I've worked in 28 years in the health service. And that is a very, very positive thing, except when it's going badly, because there's nowhere else to go. So it's a bit like when it's going well with your family, it's fantastic. When it isn't, and you've got nowhere else to go, then you've only got yourselves to look at to solve the problems. And that's what we're trying to do, because Croydon has had a history of not actually working very well together. And when you're so close and not working together well, then actually the people who suffer are the patients that we serve and the staff who work for us, and we're trying to change that by the way that we're working going forward. So it's really important for us that we take this opportunity, and we think it is a real opportunity. Now, we're building on something that has existed for a couple of 3 years, something called the One Croydon Alliance, which is about the health and care partners in Croydon working together. That's the start of this, but we're definitely building on it. And we're building on it because we think if we create a system within Croydon that works collectively together, we can deliver better outcomes for the services we run now. So we're doing a lot of work on elective transformation, we're doing a lot of work on emergency care transformation, which we don't think we could do if we weren't as connected, working as a single system as we are. We also are trying to change how the finances and the funding works. Croydon has historically worked in a significant deficit position. We now have a single control total, we have a single plan, we have no purchaser provider split in Croydon to speak of, and that's freeing up a lot of time and changing the dynamic for many, many people around the board table, but more importantly in departments between the Trust and the CCG, who are now working together in a way that they haven't done hand in glove for many, many years. And we think that's going to deliver better outcomes on an elective pathway and on an emergency pathway. And that's really crucial. The third aspect of the actual change on the ground is we think this helps us with working on the health inequalities agenda and, crucially, the social determinants of health. So the Marmot report that was out this week that basically said it's all got worse over the last 10 years, part of the job of the Integrated Care Partnership in Croydon is to start to turn that around in Croydon. And we haven't done that yet, and that's the next big job for us to do, I believe. And so to do that, you do need three things, I think, to make the integration really work. We don't want to talk much about governance, but governance is a part of it. You do need to have a well thought through system that is supporting and making this work. But that needs to be secondary to the two big things that need to be in place for integration to work. The first and most important is relationships. You can't do any of this without having good working relationships. And I've worked a lot in the health service and always thought I had good working relationships with colleagues. Actually, I think what I did was pretend to myself I had good working relationships with colleagues, and then I used to go back to wherever I was working and slag off the people who I was then working with. That's not actually about real relationships. That's about playing at it. For integration to work, you absolutely have to be trustful, you have to be honest, and you have to work together, because if you haven't got that, you've got nothing. So you need relationships, you need governance, you also need to be getting on and doing some work, because one of the big risks of this is it's a lot of people talking about working together differently, and the people who are actually doing the work on the ground don't see it at all. So it's something about translating the ideas of integration into the reality of life for patients, the public and staff. And if we can do that, then we'll really be doing something transformational for Croydon, and that's clearly what my job is. Now, our state at the moment is that we're just about to go live with big changes in April of this year. In October, we're then bringing in the local authority, who are already around the table in the discussions, but in October we're going to start piloting doing some pooled budgets and aligned budgets with the council, because by April 21 we want to have the adult services of the council completely and utterly managed in tandem with the health side of the situation in Croydon. So we'll have a health and care board running everything in Croydon, with local authority officers and councillors working with lay members and non-executives and the single executive team to manage the situation overall in Croydon. And then we bring after that children's services in as well. So it's quite an ambitious objective, but we want to create a single health and care environment in Croydon, completely connected, working for the benefit of our patients, our staff and the public that we serve.
Thank you. It's interesting what you say about relationships. I've always thought that good relationships can be measured by what you say about your partners when they're not in the room.
Mm-hmm.
So Simone, do you want to talk to us about how primary care networks are developing in your part of the world?
Absolutely. So I'm Simone Newell. I'm a GP partner in the Blackmore Vale Partnership, which is in rural North Dorset. We're 27,000 patients, having merged about 5 years ago through necessity. Not through wish, I have to say, but 5 years on, we were in a very different place and very pleased to be merged. I'm also the clinical director of the Vale Network. We're about 40,000 patients, and that's actually just 2 practices coming together, ourselves and another practice of 13,000. So that sounds quite straightforward, but historically, we never really talked. We work very differently. So actually just being brought together in a room, having some form of common purpose has actually improved our relationships and started to build some trust, but there's a long way to go. And I think the theme through all of this is about relationships and trust, and it really doesn't happen overnight. But it's not all about GPs, and I think that's the really important thing for me about primary care networks. It's about collaboration. So we were very clear that actually one of the reasons networks came into existence was to, relieve pressure in primary care. And how do we do that? Well, we have to empower our patients, and we have to think differently about, how we deal with patients, how we treat them, and sort of encourage them to be part of the solution. So we have a mission statement, and we just talk about a collaborative and a holistic approach to the health and the well-being through really patient empowerment and sort of self-care. One of the things we did initially was we just gave all of our staff lanyards, so they all have a sense of community. Even if they're the community staff, they're not employed by us. They work across both sites, but it's just those little things that start to make people feel different. And the one thing, we had our first big meeting and we decided that we'd have a joint Christmas party. Sounds crazy, but actually that's the first thing to building those relationships. Much better, possibly after a glass of wine, than sitting around a table in a formal environment. So, it's been quite a journey. I think we'd already started some of that work with Primary Care Home. We were already thinking about the 30 to 50,000 population and the benefits that has. We know that, with teams working around that size, you're small enough to care, but you're large enough to cope. And I think we've seen with some of the integration of our teams and the additional workforce that we've started to recruit, it's really improved morale and resilience, I would say. Apart from that, what have we been doing within the network? I think it's given us a bit of time to start to think differently. We've been working with the Altogether Better programme, and we've been absolutely gobsmacked by the patient response to becoming health champions. And I'm just humbled by how much of them will give up their time. We've got mindfulness groups, trained psychologists that have a job, but they're still coming into the practice. And I think that's the difference, is that rather than be siloed independent contractors, we're moving to the thoughts that actually perhaps we do need to involve, our partners, our patients and our communities to work differently. So we've worked with our social prescribers and our health champions, and we've now got a whole menu of wellbeing activities so that as GPs we can signpost patients to. And again, I think there's been evidence for this through the Altogether Better programme. Up to 40% of patients come to the GP with a non-medical need. They come to me about their debts, and I'm like, well, I don't know about that, but now I can signpost them to somebody who can really support them. So I think that will make a real difference to our workforce pressures with time. But it is early days, I have to say. Population health management, so we've been working with Optum initially, looking at real-time data and actually focusing some of our frontline staff to work differently in a more proactive manner. I think this is one of the big things that I have a bugbear with, that the NHS is wonderful, but it's incredibly reactive. And actually, on the front line, we need to be more proactive and get out there and sort of catch these people before they fall over. So we've been identifying people at risk in our frail cohorts of patients and directing our nurse practitioners to call them up, cold call them. Some of them are like, why are you calling me? I'm fine. But a lot of them are really, really welcoming. And the girls then will go out. And actually, we've developed care plans. It's not just tick boxes, it's about actually what matters most to me and really using that personalisation agenda. So I think that's been really powerful. We've also got some other roles. It has been quite difficult to recruit. And so this is work in progress. And I think when people seem to think that networks are going to solve everything, it's going to take time. So relationships, trust, and time. And, you know, it is work in progress. But we have got a first contact mental health worker, we've got a first contact physio, and we've got a network pharmacist who's just starting to do medication reviews. So we're starting to see a change. Excuse me. And then there's the community. And this for me is the most exciting part of networks. It's actually, whenever I've gone out into the community, it's usually to tell a negative story. We're closing beds. The CSR says we've got to do this differently. And it's been really difficult. But going out to the community, we've had a meeting. We've invited everybody we could think of, police, schools, local authority, mental health, everybody, and just got them around the table and said, okay, as a community, as part of our network, how can we work as a team to support you and our patients and the population? We've done a piece of work around rural food poverty, because actually there's a lot of food poverty in rural areas as well as the more urban areas. And so we've now got a group together. We're looking at developing a charity so that we can fundraise to have a local pantry, which is not just a food bank. It gives people a sense of purpose. They pay a small amount of money. They get £25 worth of food, but actually then they can volunteer and they get supported into food choices and how to cook. So that's when we would have never done that without the network. We just wouldn't have gone out to the community. And we've also fundraised for a trishaw, one of the sort of tricycles that are powered, and we've just bought one. So we're going to take that out to the residents of our care homes and get them out in the air. You know, that feeling of the wind in your hair type thing. We know there are other places that do it, and there's an evidence for that. So hoping to give our population more of a sense of well-being. So I think that's probably it. I think I would say a word of caution. Mine sounds really optimistic, but sometimes it's really difficult, just the relationships between practices and how we've worked over years. And we're just 2 practices. So if you've got 5, 6, 7, 8 practices coming together, some historically don't work together, don't even like each other, and that now they're expected that they're going to be working together to deliver service specifications. We mustn't lose sight of that relationships and trust are really important. But I think it is an opportunity, and I'm really happy to be part of it.
Brilliant. And I've got visions of fleets of tricycles going through the Dorset countryside.
Have you seen Gold Hill? It's really
yes. Nikki, can you give us a perspective from the national
Yes,
end?
I wanted to reassure something first, that we weren't going to put tricycles into the service specifications, which I know some of you will have been wondering about. Hi, I'm Nikki. I'm a GP in South London and medical director for primary care at NHS England and NHS Improvement. And I think in one sense the conversation could sort of stop here, because everything that's happening is happening at exactly the right level. There was a moment between Claire and Matthew when I thought there was a bit of a Dragon's Den opportunity to see what bit of the system you might want to work in. But actually, I think for us it's very much, it is very different. It feels different nationally, but it feels different across the spectrum of systems and ICPs and primary care networks. And if I do what Claire did, which is take us back 5 years, would we have had a national engagement about our specifications for primary care networks? Probably not. So I think we are in a different position. What we're seeing, both nationally and locally, is a different type of leadership, something that feels much more locally owned, much more distributed, much more about recognising what the needs of a community is. I highly recommend you stay on and listen to Fazana later on, who'll talk about Bapti, isn't it, your young man who died by knife crime. And because of that young man, Fazana's created a social movement in her patch to start to tackle some of the things that have really been difficult in her area. Kat, who's a nursing CD in Yeovil, has embedded lifestyle medicine into the work that they do across their PCN. That wouldn't have happened unless those groups had come together. But the themes that run through each of the introductions so far are very much about time and trust. When we started to set out the direction of travel for primary care last year. So appreciate that was after the primary care network, after the primary care home sort of philosophy really was bedded in some areas. I started training for a marathon, and it was almost purposeful because I wanted to see how long it would take. because this stuff does take time. We can't do it overnight, and we very much recognise that, and I think it's really important to say that. It's about complex relationships that won't have already sort of had the time and space to understand how to work together. And we want to create that, but what we have got is, for once, I think, a level playing field, a level opportunity to access a playing field for patients, for communities, that's really set out through the primary care network specification. It gives a chance to see what could be happening over the coming years in each of the systems that we're trying to support and develop, and very much with us sort of stepping back and allowing that local ownership. Helen, you asked about what we could inadvertently hinder, and I think it is that, I mean, we have a sense of wanting to see pace, wanting to see outcomes. There's lots of reasons for that, and Matt spoke about things like the 50 million appointments and whether patients really are satisfied, whether they really are confident about the care that they're getting. This stuff does matter, and we know that there are patients who are calling 200 times in the morning to get an appointment, and we need to be able to move away from that. But I'm hopeful. I'm going to be optimistic because I think that is the way that we're going to be. I know that Leah is here from our local RAG Pulse, and I don't want to be quoted as saying I'm overly optimistic, but I have a balanced level of optimism, because actually we have to stabilise what's happening in general practice, and we have to push on. We have to create a model of care that works for our workforce, which is changing, but also for our population. My children will access care very differently from the way that people currently access care, although I think they probably would like to go on those tricycles. So let's see.
That's great. Thanks, Nikki, and thank all of you. So I'll open it up to questions from the floor in a moment, but before I do that, I'm going to try and frame my question positively, taking Nikki's cue. You've all been really positive about what you're doing in your local communities and the difference that you're making, and actually what you can do now that you couldn't have done a few years ago. So I suppose my question would be, what else could the national system do to enable you to do even more of that, to not, using Nikki's words, to not hinder, to not get in the way? You might want to pick up on the question that Nick asked the Secretary of State in terms of potential legislation in the future. Is there legislation that you'd like to see? Is there legislation you would possibly not like to see?
I would be writing things down.
Anything else that you think could be even better to take away the barriers that make it more difficult for you to do what you want to do than it should be? Where do you want to start?
How shall I start? So a lot of everything we've done without a change in legislation, and it's all been done through influence, it's been through relationships, and it's been incredibly hard to achieve, and it always feels that you're only ever one conversation from a disaster, often. If you'd asked me 6 months ago about legislative change, I'd be, no, it's all fine, we don't need any of that, it's absolutely fine. And over the last sort of couple of months, I've started thinking, it would make it a lot easier if we were actually a thing, even down to just employing staff, even down to the conflict that still sits there between, or the tension that's there between the role of the ICS and the role of the CCG, and then the role of the membership within the CCG, the roles of governors within the acute trust, the roles, the statutory duties of the boards that sit within. And over the last 6 months, we've done a lot of work with our non-exec and our lay community, really, in terms of moving to viewing themselves as organisations within a system rather than organisations on their own.
Matthew?
So I'd say I'd legislate for flexibility rather than prescription. So I definitely don't want a blueprint. One of the joys of the work that we're doing is there isn't a way of doing it that we're being told to that looks great somewhere else, but doesn't look great in Croydon. What we're doing is creating what we think works best in Croydon for the people of Croydon by the people who work there. So for me, the thing that the centre could do most to help would be to continue to allow that flexibility to exist. Now, flexibility isn't without a check and a balance. There's got to be some process and some guidance and some limitations. I accept that, but as much flexibility as we have at this moment, the better, I think. And that if there was one request I'd make is don't write the rules too tightly, because the moment you do, you'll drive out the transformation and the enthusiasm in places, because it will look like we're being done to, and quite a lot of people will walk away or turn off at that moment. So I'd say keep it open at this moment and not close it down.
Okay. So my wish list, I think, would be a system solution to shared IT. We are battling, we are really battling across organisations to share IT. We've been a pilot for something called shared admin with System 1. And unfortunately, when we turned it on, the provider turned it on for everyone across all of our sites and both practices. And so everybody could see everything. And it created a huge amount of fear that actually this wasn't a network, this was a merger and nobody had told them. So I think a system solution to shared IT and something to do with how we get around different organisations' governance when we're working together. So, for example, we're trying to set up a community-led club modelled on the Lindsay-led club. And our community nurses have said they can't do that because their organisational governance is different to the governance behind the Lindsay-led club. And it's just like, but it's for the care of the patient. You know, so how can we get a solution to those sorts of issues?
Any thoughts, Nikki?
Do I get to make a wish?
You can make a wish.
Fantastic. Look, I think they're all things that we absolutely feel and recognise, and there is a definite consensus nationally that you know we have to give out the power, the responsibility, the accountability, and very much the concept of system by default. And I don't think that becomes an acronym, which is wonderful. I don't think it quite works. It hasn't yet. But very much starting to deliver care in the right level, for the right part of the system. And I think that recognition is absolutely there. And that's very much the work that Amanda's been leading to say, how do we start to do that much more freely? Matthew, you know that we're absolutely in the same place. We've had this conversation before. I want to see that flexibility. And right now, I'm delighted that Yasmin in West London, who's a PCNCD, is running a Moroccan cookathon. I would much rather that's what she's spending her time doing right now, because actually she's also doing a whole bunch of other stuff to look after her community, with her community, than sitting in a kind of endless meeting. So I think we can help do that, and I think we can help sort of show that some of the things that might be being asked for are not the right things, and help to just guide and set the tone for the rest of the system.
Thank you. So, your turn. Questions from the floor? There's one right at the back there. You can say who you are as you ask your question.
Thanks, really interesting discussion so far. Neil Tester from the Richmond Group of National Health and Care Charities. And just reflecting really on Chris Whitty's final slide earlier on, saying putting multimorbidity at the top of the list of things that we're not currently on a trajectory to fix. We're thinking a lot about the experience of people with multiple conditions at the moment and see lots of potential at ICS level and particularly at PCN level to address that. Simone gave that example about a PCN pharmacist and medication reviews. Matthew talked about that focus he wants to move on to about the Marmot agenda. So it feels like there's loads of potential there, but I'd be interested to hear if the panel are already sort of seeing visibility in those systems at those levels of multiple conditions, and if not, what would be the things that would enable us to get that really necessary focus?
Who wants to pick that one up?
Ooh. Well, I think I could possibly start. I think for us, population health management, just using the data analytics so that you can identify those people with those long-term conditions, those comorbidities, and then you can actually, you know, focus in on them in a proactive way. There's also that thing about prevention, you know, and the one condition that runs through all of the comorbidities when you look at the data is hypertension. And the problem is, as somebody said to me, hypertension is not very sexy. So, you know, it doesn't really it just gets pushed to a side. But we need to get better at prevention, you know, much earlier on, I think. And then we can look at, you know, how we then are able to reduce the amount of comorbidity.
So I'd say the short answer to your question is the desire is strong, the delivery is less so, if I'm being absolutely honest. But if you don't have the desire and the will and the relationships to try and do some of this stuff, because it can't be done by one bit of the system, it has to be done by a totality of the system, you're definitely not going to get there. So the desire is there, it's part of what we talk about a lot. It isn't really happening in a transformative way at this stage. I think what would help is allowing our system work to carry on in the way that it is, because it is on the agenda, we will get to it, but we've had to do a whole load of stuff to get the thing set up in the first place. Now we need to move on to exactly that sort of thing. So hopefully in the next year or so, that will be the thing that we spend most of our time talking about, but that hasn't been thus far, it has to be said.
I'm just going to challenge slightly the concept of levels. So I don't view them as having an ICS level, an ICP level, and PCI. I view it as we are a collection of organisations and a collection of populations, and it's about what is the right population that you need to deliver that aspect of care. So I know I talked about the ICS, but I was really talking about things that we did across a population of 1.3 million. So in terms of multimorbidity, it's the population health management piece. It's making sure that we are providing the right care to the right people that need it in the right place. So I think that's absolutely the role and the thread that goes through for whichever population you're looking at.
Quite right. Thank you. Now I could see Claire had a question.
Yeah, it's not really a question, it's a comment. So I've been around this for 30 years, and my practice currently runs about 15 practices. We're a multi-site. I really hate the word models. I find it really awful. What we should be doing is defining what patients need in terms of access, continuity and prevention, then setting a series of standards against that, and then the model will fall out. It'll be different. It'll be different in rural Margate than it will for inner city London. And what I worry about is we get fixated on models, and then, I'm not criticising because I think what you're doing is fantastic, but we get fixated on models, and the current model is the PCN. I don't know what the next model will be, or the next model, as if it's the model that drives the change. It's not the model that drives the change. What drives the change is determining what patients need. And finally, 15 years ago, we had in our practice a 50,000 population. We worked with our neighbouring practices. We shared an on-call rota 24/7. We shared staff. We had about 50 allied health professionals, including the community beat officer, and because that's what we worked. And general practice will do that. But it can only do it if we have a stable general practice population. And at the moment, we haven't got a stable. We've got a peripatetic locum population, certainly in London, maybe not the other way around. So what I think that we need to be addressing is how to bring the workforce in, and then how to determine what we're going to deliver against a set of standards, rather than fix a model and put little square boundaries around it and say hunky-dory, we're all going to work, happily together. So it's and a comment.
Nikki, you want to respond on the model side? Claire, I wouldn't ever disagree with you. I do agree with what you're saying on how we should not be defining sort of models of care, but I'd often say, and particularly when I'm out in general practice and in networks around the country, is sort of forget about what it's called. We're always talking about the three-letter acronym and whether it's a primary care network or something else. It doesn't matter. What matters is the relationship and whether you are able to take that population focus and create and support the workforce. And you and I have shared a number of exchanges recently. I'm making you leave the room. We've shared some exchanges recently about how worried we are about our workforce, and I'm absolutely there with you. But what I want us to do is, outside of some of the national politicking, which we've all got to kind of manage, is actually focus on what we're doing locally and stay away from the acronyms and the kind of confusion about whether it's this type of model or that. We'll do our best to stay away from that as well and allow this to flourish, because I genuinely think it can. And it's the first time we've got 5 years and probably more of consistency of a way of working, and that's what we've got to make happen.
Thanks, Nikki. Now, I could see that James and Ian had questions. Has anybody else got a question? We've got about another 8 minutes. So any other questions? So we'll take 3. We'll take Ian and James and the lady in blue.
Hi, Ian. NHS England improved. Fear it's another quick comment rather than it's your wish list question. And I agree. I think legislation can help a bit, but only up to a point. Need flex, and it's the three-letter act. As you say, we've had hundreds of those. Wish list. I think the obvious one is actually around the money. So obviously we've had the long-term funding settlement. We've had further manifesto cash. Actually 85% of the total additional funding promised in the Tory manifesto actually was for health, specifically for some workforce issues. I think the critical thing is seeing what the HEE budget settlement will be and whether we get a multi-year funding settlement. I think the other critical one is premises. And that's a huge OD opportunity. We know we haven't got fit-for-purpose primary community estate, let alone hospitals. Wouldn't it be wonderful if we could have not just 40 new hospitals, but 1,250, say, fully fit-for-purpose, new or refurbished primary care hubs, as well as then the tech funding, the public health, and the social care funding that we've discussed.
Thanks, Ian. Who's got the microphone next? I've got the lady in blue there, and we've got James. Here. Oh, different lady in blue.
Good afternoon, everyone. I was quite intrigued at the discussions around how the panel are actually working to provide services within their local communities. And I think it's about time around demographics. Claire talked about the gypsy population in Surrey and the need to provide services to meet that demographics of patients. I think it's about time with the NHS in the sense that we spend so much money in trying to design services that do not always work for every community. So I think going forward, this is really good because this is a typical example of looking at the different areas, providing services for the local community for to fit in with what their local community actually needs within the NHS. And as a senior sort of NHS manager, I think it's about time we started working towards that. So I quite recommend that. I know there's issues about the new models of healthcare, but we need to dress it up into something anyway, in any case. But I think that's really good. I'm quite impressed with that.
Thank you.
GP in London. I just wanted to draw attention to the Pulse headlines that came out today saying that there's 260 odd fewer full-time equivalent GPs this year. And actually the PCN sort of idea was all about stabilising general practice. And yes, we know that there's going to be a lot of allied health professionals coming in, but we also want to avoid the situation of role substitution. So actually, how do we bring the focus back on recruiting and retaining our workforce and making it a really enjoyable place to work?
Thank you. So kind of connecting those things, we've got Ian's wish to get a budget settlement for HEE. We've got some questions about how we actually think about the workforce differently, and something about the infrastructure and the premises as an opportunity for doing things differently and for doing things differently in a way that really meets the needs of local populations and their different demographics. So any kind of reflections on those?
Yeah, I mean, I think that thing about the reflecting the local population's needs. I mean, if you think about colloquially my context, Croydon sits in southwest London, STP, ICS from April hopefully, and I have to say Croydon is very, very distinct to Kingston and Richmond and Wimbledon in lots and lots of ways. And the big part of the agenda for us is within a framework that is set at ICS level, which we are very supportive of, having enough flexibility to respond to the needs of our local population, which are very different. And there's, I think, plenty of examples historically where decisions taken at a 2.5 million population level don't quite match the specific needs of our population of 400,000. And we're really, really keen to take this opportunity, not to go rogue and have the independent state of Croydon, although there are some people who would quite like that, but seriously, to do things that matter to the population that we serve. Now, that doesn't mean ignoring what's happening elsewhere. It doesn't mean running 180 degrees away from it. It does mean, however, having some flexibility and ability to make choices that matter to the patients and the public that we look after. And I think this is a good opportunity to do it, as long as we connect up to the system at a bigger level, so we're not going off and doing things that ultimately are going to be detrimental to the bigger piece, because we are part of that wider system as well. And I think it gives us an opportunity to do that. It's not easy, but it's absolutely what we should be doing.
So my reflections from the comments are very much how NHS focused the comments are, and also how our wish list was as well. And particularly when we come to workforce issues, the people plan is about NHS workforce, but to deliver the long-term plan, we need to do it in partnership. So it's about social care, it's about voluntary sector, it's about unpaid carers as well. So my reflections are that I completely agree with all the wish lists, but we just need to be really careful. If we undermine those partnerships, we won't deliver the things that we need to do.
reflections, Susan?
So I'm probably looking through rose-tinted spectacles a little bit, but I suppose my thoughts were actually if the work we're doing with our social prescribing really works, and if we're redirecting that 30 to 40% of our people that do attend the surgery very, very regularly, actually if we're directing them somewhere differently, then actually that will make a difference to our workforce pressure and how we recruit. And I suppose as a GP, we can't recruit GPs at the moment. So we've gone down, we've had to innovate and go down the nurse practitioner route. And it's been amazing. We've got about 8 nurse practitioners. We've got a nurse practitioner partner now within our organisation. And it's helped us to look at things differently. So I think, and this won't be popular, that perhaps we just need to shift the focus away again, as I said earlier, about it being all about GPs. And even Mr. Hancock's language, he talks about GPs, but actually nurse practitioners, you know, they do a very good job. And we could be more of a GP consultant and, you know, have a whole ancillary staff doing most of what we do. When I'm in surgery, most of the things I see, they don't need me. A nurse practitioner does them even better because they're more thorough than I am. And then there's the thing about premises. We had Councillor Keith Cunliffe came to talk to us yesterday about the Wigan deal. And the first thing that he did to save money was he got rid of a lot of premises. And this may not be popular, but actually, why don't we use premises differently? So if we want a hub, why don't we look in the community and see what else is out there? And certainly with our food, our local pantry, we're using the local authority. They've got lots of dormant rooms. So I think it is about thinking differently.
Great. Nikki, you get 10 seconds.
I can't even, I won't add to that. I mean, nursing, absolutely underline that. But on the premises piece, we've got a real issue about sustainability in our environment, and I am slightly anxious that we end up on another set of building programmes. So let's look at our communities in the true sense of the wider community and make sure that we're responsible with what we're doing and how we're spending our money and using our assets. This is our chance to get a truly diverse and representative workforce and leadership at the table, and it's time to embrace it.
Great, thank you. I'm really struck by what everybody said about the connections that you feel to the community in a way that perhaps in previous iterations of the NHS working with itself we haven't done, and also by the real recognition of the need to build relationships and build trust, and that takes time. But sadly we are out of time now, and Nigel and Fiona are going to come and take our place, so thank you all.
So something a little different, where we're going to get you to do some work as well, perhaps. And hopefully the change of pace will bring you. It's been quite a full-on day, actually. I'm beginning to feel it. We referred earlier to this way that we find issues that appear to have crept up on us and become very big, but when you actually look back, we all knew they were there and we all knew they were coming. So we mentioned the growth of antimicrobial resistant organisms and healthcare-acquired infection, which crept up on us over about 5 or 6, maybe 8 or 10 years even. The workforce crisis, we did see that coming. If you go back and look, people were talking about it. We didn't seem to, though, get to the point where we felt we should actually do something in many ways. So we thought it'd be quite useful to just get you to do a bit of scanning to see, well, what are the other things that are hidden in plain sight that maybe they're slow burn issues. And this seems to be the characteristic of these things. They're slow burn rather than, we're very good at crises, but we seem to be quite poor at dealing with the slow burn. So we asked a number of you to nominate a few areas. So we're going to hear from some of those people, and then we'll see if we ask you if we've missed anything. Then we're going to ask you to see which do you think are the highest impact, highest likelihood ones, and at the end of that, we may be better prepared for the next crisis, or we all may just go back to our dormant state until it gets really bad. So that's so Fiona's going to take us through, and we've got short contributions rather than longer talks now. So off we go.
Great. Yeah. So we asked people, we asked all you who were coming to nominate. We had a fantastically rich response, and we've tried to do some grouping of the themes And we've come up with 3, and which all interlink with each other, really. And I'm sure that there will be more that come up. So what we're going to do is we're going to some people have been volunteered, shall we say, to give a couple of minutes more context for each of these 3 themes. Then we're going to have a few moments to say, okay, is there something blindingly obvious that we've clearly missed that ought to go onto this neglected burning issues list? Then we're going to have some table discussion. And then at the end, we're going to have an outbreak of democracy, and we're going to vote for the things that we think, if they happened, might have the most impact, and some assessment of how likely it is that these issues, which, as Nigel says, are currently hidden in plain sight, actually may become a real issue for us all. So the first issue, we've been talking about it a lot in-house at the Nuffield, about are we a bit complacent about the place of the NHS as the national religion and its place in society and its unassailable legitimacy? Maybe we are. And what are some of the issues that you might group underneath that may actually pose us some problems in the future? So the first contributor I'm going to ask to get up and give us a couple of minutes of provocation is Greg. Greg Fell from Sheffield. I can't see you from here. There you are. Okay, you're going to come up here. You can do it from wherever you like, actually. I shall make room.
I'll do it.
Do it from here. Okay.
I was asked to speak with no slides, so I'm going to speak with no slides. 2 minutes, 3 minutes maybe. 2? 2. All right. Boss says 2.
Time to sit down then. That's because you're not mic'd, Greg, that's why.
Technical support. So Greg Fell, I'm Director of Public Health in Sheffield. And I'll talk about the ethics and the opportunity cost of orphan drugs. I'll stray into other areas. Making decisions about whether or not to allow or not allow NHS funding for stuff isn't new. And the debate about expensive and not cost effective is not new. Our decisions in this space carry enormous opportunity cost. And I think, as some people have said already, the drivers of cost growth in the NHS is not the ageing population, but overdiagnosis, new technology, and new cases of illness. So that underscores the importance of prevention. This isn't new. It's not that unpredictable either. And it's worth saying frontline clinicians make rationing decisions every day. NICE have done an amazing job over 2 decades, probably more. I criticise NICE from time to time, but I'd far rather be in a nice world with NICE than without it. NICE are constrained in many important ways. Firstly, most importantly in this space, they cannot consider the affordability, thus the opportunity cost of the things that are recommended in technology appraisal programs. They're bound to consider the cost effectiveness, but not how much it costs to implement. That matters for reasons I'll come on to. Secondly, commissioners or payers are rarely involved in NICE decisions. I've been there, I have been, but it's more the exception than the rule. Thirdly, generalist clinicians are not as involved as they should be in the NICE process. And all of those things matter and have allowed really, really expensive, sometimes really effective drugs into the system. That carries opportunity cost. Second point, NICE have been circumvented in a number of really important ways. Chris Whitty's already said the cost per person per year for cancer drugs has hiked exponentially over the past 20 years for no additional value. The Cancer Drugs Fund, last time I looked, was 300 million quid. I could run the country's parks for 300 million quid and probably buy more health than the Cancer Drugs Fund buys. The end-of-life premium, you can have a cost. You can approve a drug for £60,000 per QALY compared to £30,000 per QALY. There is no empirical evidence that there's a societal preference for an end-of-life premium, and again that matters, and that's allowed expensive drugs into the system. Orphan drugs. So you'll have read about Orkambi, an expensive drug for cystic fibrosis patients. CF's not terribly uncommon. Orkambi costs £100,000 per patient per year for their life. Eculizumab is the most expensive orphan drug I can think of. It's £250,000 per patient per year for life. Immunotherapies for lung cancer. The lung cancer doctors, don't know if any of you in the room are really excited about immunotherapies for lung cancer. Lung cancer is not uncommon. So these things matter. They get into the system. The orphan drug agenda is inflammatory. Right, okay, the orphan drug agenda is inflammatory. The skilled use of political and social media, this frames how policymakers think and act, and that matters. Here's the rub. The opportunity cost is vast, significantly vast. That's your social care budget. That's your CAMS budget that's being spent there. And there's little to no public discourse on the opportunity cost, and there's little to no public research on whether or not there's a societal preference for really expensive drugs or not. Be minded that that is your social care budget. That's your mental health budget being spent there.
Wow. Okay. Greg, thank you. I'm going to thank you. If you could, oh no. Okay. Okay. Okay, Catherine. Sorry, I wasn't going to drag you up here, but you're here now, so.
Thank you.
Go, Catherine Lissett.
So I'm a diabetes doctor in Torbay in South Devon, and my question's about, following on from what Greg said, is about rationing and how we do it. So we know that we have to make difficult decisions. We know that we're told we have to fund IVF, we have to fund lithianin, we have to fund certain expensive drugs. The question comes, how do we make that decision? How do we engage the people in our communities in that decision? Are we open and honest that we need to ration? So my question is to have a debate about how we make those decisions. Do as an STP, we create a people's panel. Do we try to get true equity of people involved in that panel, as Claire was describing, involving carers, and then do we ask them to rank what therapies they want? How do we decide whether we fund a park, CAMS, medical therapies? Can we have that national or STP-wide decision about how we fund? Is that the right thing to do? Do we trust our populations to make that decision? And if we aren't asking them, does that mean that despite all this hype about being patient-centred or people-centred, we don't actually trust our populations to make that decision? So my request is for an open and honest rationing discussion with all our service users about what we pay for and how we spend the money.
Thank you very much indeed. Thank you. Hi. Okay. So, as I said in opening, the closely related overlap. So one aspect of the troubling discussions we've been having about the legitimacy of the NHS is the NHS coping with new challenges, also coping with challenges to its authority, if you like. And here is a related issue, questioning, challenging of the validity of expert opinion, whether it's anti-vax, the erosion of trust in experts. Is that a big threat for us? Should we be taking it seriously? Got two people who are going to talk on that topic. Stay there, aren't you? So Vanessa, could you take the microphone over there? And first we're going to hear from Charlotte Williams.
As a reaction to the backlash against expertise, I'm not going to take the lectern. I'm going to talk from the floor. So we've heard today about the growth in subspecialisation, particularly within medicine, and in the pursuit of science, the increasing splitting and subcategorisation of diagnoses. And often for patients, they need to access that diagnosis in order to unlock care. So particularly in things like educational needs and other areas, that can give an ownership and an expectation of a response. But what's the downside of this for our patients? So through access to information that's been opened up through the internet and other fora, I can own that diagnosis and I can use that in positive ways to interact with my clinicians and plan my care. But are there risks with that? I see two possible risks. One, a tension with the tyranny of expertise. So Western culture says I should respect professionals, that they have a higher sort of moral status through their additional learning and knowledge. But is that some know-it-all coming to tell me about what to do in my life when I exist in my world with my belief system? The second risk I see is the proliferation of misinformation. So I can perceive that diagnosis and how that relates to me, or I can perceive what the symptoms that I seem to be experiencing in my world, And I can have my own interpretation of that, and I can see the interpretation that's given to me and the interpretation that I make as the same. And as a result, I can encourage others to do that. In a way, I'm not seeing the workings that exist behind that opinion from my specialist. So I think these lead to questions for us in terms of healthcare services as what's our role of the clinicians of the future and the role of engaging our population in a different dialogue around diagnosis and expertise.
Thank you very much. And now Claire Lamer.
So I'm a paediatrician, so I'm going to frame this as a paediatrician, but you can contextualize this to any part of medicine. So myself and my colleagues are increasingly seeing that when we interact with children, there are actually 3 groups in the room every time there's a consultation. There's the patient, there's their family, and there's the social media support group. And that leads to a number of different challenges. One of them, which I think is crucial, is where the expertise sits, whether it's with the clinicians or whether it's with the social media support group, and what that means for trust between the families and the clinicians. I'm clearly oversimplifying, it's more nuanced than that, but I'm trying to explain the kind of challenges that we face. And what that leads to is a really difficult situation for 3 different areas. One is the patients and their families themselves, they're very torn. 2 is the staff, particularly nursing staff, who have to interact with families if they're inpatients, often with life-limiting conditions, on a daily basis and really struggle to manage those 2 differing areas of expertise. And 3, and I think this is often a forgotten area, that what tends to happen in a situation like this is that the levels of intervention get driven up. And what that means is it's an ever-increasing level of intervention because the social media support group then pushes to the next level, potentially with the next patient that's involved. So our challenge as clinicians is how we balance all of those various different elements in a way that is true to our responsibility to the patient, but also to the families.
Thank you. Thank you very much indeed. So the third theme that we've identified is very, very broad indeed, as have the other 2 been. Looking at the way in which major events impact on our ability to run a health service and the way in which we respond as a service to trauma. And the context that some of the submissions came in, some submissions were talking about big public traumas like the Grenfell Tower disaster, and others much more locally about a caseload right in front of them and a tragedy right in front of them. But in both cases, how well equipped is the NHS to deal with those issues? So if it's all right, I'm going to ask, first of all, Fazana to speak. Would you like to speak from there or from here? You'll come up here. Okay, thank you.
Thank you, everybody. Can you hear me? Can you hear me all right? Yeah. Hi, I'm Fazana. I'm a GP in Newham in East London and also clinical director for one of our primary care networks. And I wanted to talk specifically about the trauma of knife crime. We heard a lot today about how much there's been progress about CVD, and that's had a positive but a knock-on effect of people living longer in dementia. But our children are dying. Just in my own practice, I run a list of 5,000 patients. I have lost 2 children just this year, victims of knife crime. We have a clinical cabinet that many of our trauma surgeons sit on locally, yet we're seeing an increase in knife crime. I think that trauma is not just one of the wider determinants of health that we talk about. The wider determinants of health are actually a major cause of our current health issues, and they're intimately entwined. I think as we can risk profile diabetes or heart disease, I believe we can actually risk profile the problems of knife crime, and I think we need to take a much more proactive attitude. I've just out of my head thought about risk factors such as housing, issues, homelessness, maternal health of our young people, as Greg's described the difficulty, CAMS now, school exclusion, bullying at school, county lines, which is rife in many cities and even in rural areas. And there are other risk factors such as our young children going into A&E with fractures, that have been from self-inflicted and punching. So I think that we need to treat these traumas just as we would treat our physical illnesses such as diabetes and heart disease and cancer, because I think that's going to be one of the major health issues in the future.
Thank you. Thank you. And coming up to join us is Catherine Scott. Welcome. Does that work for you? Okay.
Hi, so I'm talking about trauma from a much broader perspective, and the idea that I submitted was more about the convergence of what I see as it's a big room, sorry, of three trends. So firstly, a negative trend in being that there is, however you want to measure it, an increasing number of crises that are leading to psychological trauma, and they can be man-made. So, talking about terrorist attacks such as Manchester Arena or Grenfell, and knife crime, as Fazana's just talked about, and also an increasing number of refugees and the trauma that's created from migration and from being from fleeing from either climate change or from war. Then there's also a growing awareness, particularly in the psychological community, about the impact of adverse childhood experiences. Now, this is an area where, we're talking about things like abuse and neglect, domestic violence, having a parent who has mental health issues or is substance misuse issues, and actually that some of the responses to that are happening in the other devolved nations are much further ahead than we are here in England. And then obviously natural disasters, flooding is all over our TV screens at the moment, and that can create trauma from leaving your home or from being separated from family. I think there's two positive trends that kind of come in at the same time. One is around the fact that our expectations around mental health and our expectations about what will be done for our mental health in these sorts of scenarios is changing, and we're expecting more. And coupled with that, what psychological professionals actually have to offer is growing, and the improvements in our evidence-based interventions and what can be done in terms of screening, debriefing and specialist interventions around trauma. So as those three issues kind of come together, why is it important? Well, I think at every level of the system, we need to be thinking about trauma-informed practice. So that can be right from kind of government disaster planning. So how do we think about psychosocial trauma at that level? Thinking about our emergency service personnel. I read something yesterday around the fact that previously, police, long-term sick in the police force used to be mainly due to musculoskeletal problems, and now it's mainly due to mental health. So there's a real population out there that we need to be thinking about and how we're going to support them, people in recovery organisations facing the same issues, and then thinking about trauma at a community level and around individual level. So in response, I think as Fazana put so eloquently, we need to anticipate and predict and think about how we can prevent this, we need to respond to it, and we need to use trauma-informed practice in order to help our populations recover. Thank you.
Thank you. That's great. We've probably got enough to talk about already because there's such a rich diversity of issues. But I will just take a couple of minutes in case there are people sitting there thinking, yeah, but this issue really needs to be brought into the arena and onto the table discussions. But I'm going to be strictish. So, for example, if we take what Chris Whitty said, I wouldn't have accepted workforce because we have known about it for a long time, but the particular issue of paediatrics that he brought seemed quite new. So before you put your hands up, if you can think about, if you've got an issue that you think is burning, but it's pretty well known, then try and refine it or come up with something that isn't quite so obvious. I'll give you a couple of minutes to think about that, and we'll see if we get some additions to the list, and then we'll move into table discussion. Sorry.
Ruth Isden from Age UK. I won't quite add ageing to the list because although we seem to know about it, we also seem to have a great capacity to forget about it. But I think it's actually ageing in some of the unique contexts that we don't think of older people in. So we're increasingly aware that actually all sorts of people in circumstances which we don't think of older people. So within the LGBT community, in homeless shelters, living in severe poverty, in secure mental health units with learning disabilities, in prisons. I'm often told there aren't older people in these contexts, when actually increasingly we're seeing evidence that older people are aging in these contexts as we're aging across the piece. And actually what we're seeing increasingly is services don't know how to deal with this. So older people services don't know how to deal with people who are bringing that level of social complexity, and too often services that are used to dealing with people in those circumstances don't know what to do with older people who arrive. So I think we're missing a trick when we think of older people in that very stereotypical older, frailer, kind of mainstream way, which we're starting to get to grips with, but we're missing the fact that actually people are aging across the piece. People who've been in dysfunctional circumstances all of their lives are still in dysfunctional circumstances when they age.
Thank you very much.
Can I just add to that? Andrew Sutcliffe, the Chief Executive of the Nursing Midwifery Council. Actually, one of the things that we're missing from the ageing debate is people who are ageing without children. So if we go back to some of the things that Chris was saying earlier, there is an expectation that we will rely upon informal carers, family members. 1 in 5 people over the age of 50 is ageing without children. I'm not going to have somebody looking after me and doing the things that I'm doing for my mum and dad. And actually, there's an awful lot of us that are going to be in that situation. I really don't think we're thinking about that one.
Okay, thank you. Over here. Thank you. Is that Richard? Yeah. And then you at the back. And then I think that's probably going to be enough. Yeah, Richard.
Hi, Richard Bomer, Nuffield Trust. The one that I think is going to sneak up on us is that we are successful. And every time we're successful, we create whole new populations of needs that we didn't think about when we were trying to be successful. I'm showing my age now, but when I was at medical school, there wasn't a thing called cancer survivorship. And now we have whole populations of patients with cancer survivorship. There are increasing number of diseases that we are not able to actually cure, but we can put into remission with monoclonal antibodies and advanced medications. But those patients still have needs. They just have very different kinds of needs for which our systems are not. So I fear that we're going to create this whole tail of different needs that we haven't thought about because we've been successful. And we don't think about what are we going to do with success. We think about, gosh, how do we get to be successful?
Okay. Thank you. And gentleman at the back, and then we'll summarise and we'll go on to the tables.
Rob Yeldon from the Charter Society of Physiotherapy. I'm probably a bit too close to a speaker. My bid is for rehabilitation to be considered. At the moment, rehabilitation is hidden in penny packets across a whole range of individual patient pathways, so it's not really considered as a need in its own right. Matt was talking earlier about adding the quality of life to years, not just number of years. If we think about the impact on social care, on secondary prevention, rehab is going to be increasingly important. Yet we know currently most patients who would benefit from rehab are not even offered rehab across a whole range of conditions. So I think in the next few years we're going to see greater demands for a parity of rehabilitation being treated as an absolute priority in the same way as we would treat surgery, medicine, nursing and all the other elements of the NHS.
Great, thank you very much indeed. So we'll move into table discussion. So in addition to the 3 issues that we have on the slides, we're going to capture the conversation that we've just had. So 2 different aspects, 2 different challenges posed by ageing, the differing needs of less advantaged groups and the needs of people without informal carers, the consequences of success and what that may mean for new treatments and new developments that will be required to support survivors or people who live to have another disease altogether, as Chris Whitty said earlier with dementia. And then I guess you're arguing that if we don't make rehabilitation something rather more central and more of a priority, then we're missing a major opportunity to improve quality of life. Is that a fair summary? Good. Okay, so we're going to, if you'd like to stay at your tables, some of our trustees, senior associates and staff kindly volunteered to be facilitators of the table discussions. Would you, if you remember doing this, would you kindly put your hands up now so I can see where you are? Okay. So if there's any with two, I think if you're all on different tables, that's great. If you don't have somebody who's kindly put their hand up, you're going to have to shift for yourselves. So if one of you could kindly take on the role of taking a few notes and just keeping the discussion on track. Okay, over to you.
Yeah, so what are you doing? What we would like you to do is to think about what will happen if you don't do this, where will the impact be felt, and do you have any solutions or thoughts about what we should be doing, okay? Just 10 minutes, we'll just do 10 minutes on that, okay, and see how you get on. Yeah. Okay. Good. Let's. We're not going to do a huge feedback. Don't worry. We will collect your thoughts though, but maybe we'll just have a. Oh, that table looks like it's going to have to give some feedback. So, okay. Have I got you back? Have you left us some sort of tangible record of your conversations? That we. No, you've failed. You've totally failed. Let's just get a few headline thoughts back. So there is a roving mic. Who'd like to share something that you thought about? Or Nick, there's Nick. Thank you, Nick, and there's Pete Smith. So.
Okay, we actually managed to merge the first two and focus
they do sort of,
on legitimate, on the grounds that number two was very much about this increasing potential clash between the traditional expert of the doctor, the nurse, or whoever, compared with the patient, who is becoming much more expert, backed up with social media and anti-vax people and God knows what. And in fact, number one, the legitimacy of the is in some ways that's at the individual patient level. The legitimacy of the NHS is almost at the macro level of a public view against that of the sort of people in this room where we'd all feel that probably vaccination was a good thing. And to shorten it enormously, our solution was that we'd like to see lots of experimentation with deliberative democracy at all sorts of different levels.
Okay. Great, thank you. Yeah, they do sort of, the first one was more macro. My shorthand for it was, when Matt Hancock was saying, the NHS is a greatly loved institution and we're right behind it, I thought, well, that's what we used to say about the BBC. So, first they came for the BBC and I didn't say anything. So that was, and then the second was more about this point about everyone's an expert. If you've ever taken a taxi, for example, Pete. We'll come here and then we'll go to Pete. Yeah, yes.
Hello. Well, at our table, we the first thing we did is to look at which of the issues we thought was the most important and pressing, and it was entirely unanimous, which was trauma. But we also felt we ought to be fair to the other issues, so we discussed them as well. And in particular, we talked about prioritisation and discussed the Oregon experiment in the 1980s when that was put to the members of the public as to what should be prioritised, and it didn't work because the members of the public had a very narrow picture of what was relevant. So we did agree that in relation to prioritisation, it should be nationally planned, regionally managed, and then locally owned. But in terms of trauma, we had a very good discussion, but I think the most important thing that we discussed was that we had to involve the relevant groups into finding the solution, and that it had to be a bottom-up approach and not a top-down approach.
Good, thank you. Peter.
Thanks very much. We had a very enlightening discussion, and we focused on how the health system should be designed in order to accommodate these left field things. And so we talked very much about trying to introduce flexibility and agility into the health system. And that can play across a wide range of parts of the health system, but just to take some examples, it implies a workforce that is trained and accepts the need to be agile and flexible. Governance should be flexible and not rigid in the accountability lines it has and so on. Cross-sectoral collaboration ought to be encouraged by the system and not completely stymied by it. And systems of finance oughtn't to be getting in the way. And of course, underlying all of this, you need information systems that are actually helpful and timely and so on. So in doing those sorts of things, we would reckon that you could design a resilient health system that would actually be able to respond to these things in a sensible and efficient way. So that was the way our discussion went on this.
Great, thank you. And picking up actually, so the point that Chris Whitty was making about generalism, in fact, this point about generalism and the ability to not just work in your own little silo seems to work at different levels of the, it's come up a number of times in the conversation. And as a way of making the system perhaps more robust and agile, that does seem like a good thought. Anyone else like to share something? Luella, yeah.
So we had a really interesting discussion along similar lines about this issue around social media, and actually one of the things that we rapidly came to with a couple of things. So one is the problem of cognitive dissonance, which is both healthcare professionals and patients and groups can want multiple things all at the same time and hold completely contradictory sets of views which you completely believe are true all at the same time. And this actually means that having a rational discussion in any direction is problematic. And then we also moved on to the fact that experience of, I think a number of people at the table were very struck by the fact that of the notion of Chris Whitty's window of death is narrowing, that most people now die in a very narrow 20-year period, which means fewer and fewer people are experiencing death, and how anxiety about death drives medicalisation at both ends of the spectrum. So increasing expectations about what's going to be done when you are in the death window and the cost of that, but also anxiety in the younger groups that was being brought up about medicalisation of conditions that previously actually didn't exist, and how the solution to this is still actually yet more healthcare, and how do you manage that in this incredibly how do you manage all of that? And is this just societal expectation driven by fear and anxiety, as you've previously mentioned? And how do doctors engage and set an agenda for that, given how complex these discussions are and that doctors frequently
So that
don't
social
deal with
media
it very
thing, it actually conceals a much deeper vein of big issues that are going on that we haven't even, if you just scratch the social media surface, you haven't really got into what's actually driving some of that behaviour. Excellent, good. Yeah, we'll come to Ian, yeah, it's Ian here, yeah, good.
Hi, we had a really interesting conversation to try and almost have a taxonomy of how some of these different things came together, and we crudely split them into the big question of what are the kind of things that are going to mean the NHS is not sustainable, and we put them mainly in two buckets. So within the context of unexpected demand shocks and unexpected supply arrangements. And on the demand side, we talked a little bit about, and this goes to your social media point, our failure to understand the changing nature of how we are living and what that means in the widest sense. On some of the particular risk factors, a failure to really understand the consequences of obesity and what we're going to do on obesity, which we haven't talked a lot about. The potential medium to long-term health consequences of the climate emergency, as well as the questions around the changing nature of asymmetries of information, which Claire, you were so articulate about. And then on the supply side, the things that you may not have factored in properly to almost our supply-demand model, the extent to which we have a proper grip, not just through defensive medicine, but changing nature of clinician risk tolerance. So the extent to which people are just now ordering a shed load more tests, for example, and that's actually one of the reasons why A&E is getting clogged up, and nobody talks about that. They just say, oh, there's more patients. And Peter's done great work that explains that. Or things like, picking up on the carers point, what's the ratio between the total quantum of informal care in society versus formal care, and the extent to which, if that significantly shifts in the way we're not looking out for, it will have profound adverse consequences for us.
Great, thank you. So we'll take one more. You've all done a really good job of kind of regrouping what we gave you, which is going to make the next exercise rather more difficult, but never mind. We'll do it anyway. It's all fun. It's just fun for this next bit. Nav, yeah.
I just wanted to give a different nuance around the paternalism versus sort of self-actualization that's going on in society at the moment. So it's kind of linked to social media point, but different. And it's kind of what I call high street healthcare, that people are now have the ability to access a whole raft of diagnostic tests in a variety of different settings which are outside of healthcare. And that's particularly noticeable outside of England and the UK. And I wonder what over the next decade, if you can scan your heart and you can get your ECG done, you can get point-of-care tests done in a variety of settings, what the impact of that could be around.
Because presumably at some point in transaction, there will be a bit that says you now need to go and see your GP.
Well, possibly, or it might just be that that's the flip side of paternalism, isn't it? Because normally you'd go and see a physician to get access to those sorts of things, whereas people can now get access to all of those things outside of seeing a physician. But then, what do they do with all that information?
Yeah, good. Okay, lots of good things there. I'm just looking at the back. Do you want to run that vote thing now? Because they've moved all the categories around. Let's do it anyway. Have you got your Slido things ready? We've got the Slido question for you that we'll get you to just do. This is more temperature testing than science, right? So you've got a choice to vote. Which issue of these? And I know you've regrouped them, and we haven't got time to regroup them back again. But into your so we'll make you. Someone's voted. That's democracy in action. Good. Which will have the greatest impact? We didn't put climate on here because it sort of fell under trauma, but it is sort of, yeah. I like the demand supply shock thing. That is good. Increased rationing. Yes. Okay. Never quite sure why these go down. Is it because they're being rescaled, or is it people are changing their mind, or is a Russian interference being? It's the Russians. It's the Russians. I'm sure it's the Russians. Yeah. But, good. Yes. Yeah. You can change your mind. Yeah. You can, and if you've got more than one phone, of course, you can vote more than once. So. If you've got a laptop and two phones, you get 3 votes. It's like Northern Ireland, but with technology. Okay, looks like we've got we've got a bit of a winner here. But I think, as Nick said, 1 and 2 really sort of quite closely related. Yeah, trauma's coming up on the inside. Jolly good. Okay. Some good thinking there, actually. Some of that group work did actually take our thinking on. Can we make sure that we collect, just so we do, I think there's a blog in there somewhere probably that we ought to try and collect things together. It's been a long day and it's not over. But I hope you've enjoyed it. I mean, I have. And I'll be honest, running an event like this is quite stressful, and you're always worried about whether the sessions are going to work and whether people are getting something from it. But I think we've hopefully met our self-imposed objectives. But there is more to come. If I can remind you that we've got Simon Stevens. So we've got about an hour. We want you back in here. Oh God, I haven't got my programme. What time? 6:45. Thank you. I've got it probably is written here. I'm just slightly brain dead at this particular moment. So back at 6:45. Can I just remind you also that there's a BMJ breakfast session tomorrow at 7:55, which is open to everybody. You will get, you'll need to have breakfast before the session, okay? So it's not quite a breakfast session, apparently. Quick administrative point, quite important. If you're not planning to have dinner, or you didn't register, or you originally said you weren't, but now you'd like to, could you see one of the events team to make sure that they know about that, because otherwise you won't get fed, or we'll waste food. And back at it does say here, I apologise. My briefing says back at 6:45 for Simon Stevens, which I think counts as pre-dinner entertainment. So. Thank you. Yeah. Welcome. Welcome back. Thank you for coming back. So it's been quite a packed day, but I hope you'll agree with me that that adding on this additional bit is going to be worthwhile. We have one session, then we're going to give you something to drink, then we're going to feed you. So hopefully, this is the pre-dinner, pre-drinks warm-up. It's my great pleasure to introduce Sir Simon Stevens, who's going to be in conversation with you collectively, but in particular with one of my many star members of staff, Mark Diane. Mark, over to you.
Thank you for giving me another opportunity to be Nick Timmins' dodgy out-of-hour locum cover. So I'm going to ask Simon a few quick questions on 4 main themes and then throw it open to the floor for most of the time. So start coming up with the questions. I should say there will be 1 question allowed on coronavirus, not much more than that. So Simon, starting off with NHS reform, one of the themes that we're keen to look at the Nuffield Trust at the moment is learning from history. This year is 5 or even 6 years since the 5-year forward view, which kind of marked the start of the direction the NHS is still on and was your first big document. Do you think the 5-year forward view met its aims?
Well, I spent the rest of today, sadly not here, which would have been brilliant, but with another group of brilliant people from West Yorkshire and from parts of the Northwest more generally, as well as some of the other integrated care systems around the country. And when you ask them that question, they are clear that, yes, they think they have begun to make a meaningful difference. Does that mean that it's uniform across the country? No. And part of the discussion we were having, although it was a sort of Chatham House conversation, was what do you do about those places that are not advancing fast enough or are stuck? But for sort of 4/5 of the country, I think you could say, yes, there has been a significant move towards the kind of population orientation, joined up services that everybody recognises a modern health system needs to be configured around.
But what it perhaps didn't achieve was the kind of reduction in demand that it anticipated, so the NHS would double its rate of efficiency improvements and be able to cope with only 8 billion extra funding up to now. So what do you learn from that? Was it too ambitious?
Well, we've had more funding than that over that period, as you know, Mark, and some of the things that, frankly, we would have wanted to see, some of the wider action on public health and prevention, some of the resilience in social care, and frankly, a 5-year budget for workforce growth and education and training. We weren't blessed with those, but hopefully now looking out over the next 5 years, we can be.
So I think that's finished my historical bit. Let's look forward to and think about the legislative proposals that NHS England brought forward last year. Do you think legislative change should be more radical than your proposals now we've got a majority government?
Well, when you say radical, what you mean is, should it have more of a top-down administrative reorganisation feel?
Radical in different ways.
See, I don't think that is radical. I think what we've actually learnt from the history of the various administrative reorganisations in the NHS is that actually is incredibly superficial. Actually, where the rubber really hits the road is around the interaction that teams of people have with patients, the way in which the statutory sector works with the voluntary organisations, the way in which we work horizontally across public services. And yesterday I spent part of the morning with the chief constables and the police and crime commissioners across England, and we were talking about the pressures on the police service, the changes they need to bring about. And of course, one of the biggest things they want our help with is access to mental health services for many of the same people who then show up in the criminal justice system because of the absence of mental health. So I think radicalism is tackling those kinds of things, not mucking around with the administrative superstructure.
So it's not a legislative radicalism, and so you wouldn't support putting ICSs, making them legal bodies, giving them statutory footing?
Well, there's a proposal to bring together the various entities that already exist.
Let them pool.
If the corollary of the question, though, is would you abolish foundation trusts, lock, stock and barrel, and create something instead called an ICS, I think that would be that would not go with the grain of what we heard from the NHS as people saying the problem set that needs resolving. And I understand when I think Matt was asked the same question this afternoon, he rightly said that the point of the legislation is actually to remove some of the obstacles that people perceive to joined up working locally rather than getting stuck on a sort of centralising top-down reorganisation.
So, last point on this, let's talk about a level of top-down reorganisation that's more top than you are. We've also seen proposals leaked to the Times that would involve increasing the government's power over NHS England, and in fact, specifically over you, as it turned out. There's a lot of talk of levers. Many of those levers seem to be mainly attached to you. What do you make of that?
Well, look, I mean, I think the reality is we do have a publicly accountable health service in this country. It's publicly funded. There are a variety of mechanisms through which that accountability is exercised. But part of the legislative proposals is that there would be a coming together of at least 3 separate statutory bodies in the form of NHS England, Monitor, and the Trust Development Authority. And those 3 have different bases of accountability. So we've got to resolve that question. And frankly, I'm pretty relaxed about it because I think as long as you've got an agreed strategic direction, which we have in the form of the long-term plan, then the rest is a second-order question.
So you're not that worried about it?
As I said, I'm not only not worried, I'm relaxed.
Excellent. Switching away from health, what do you hope for from social care reform, which we've been promised by the government? What do you think it needs to achieve?
At least 2 things. The first is that a significant proportion of any extra public funding going into social care has to buy an increase in the amount of social care that is available to people, not just a redistribution of who pays for the current volumes. So said another way, it might be desirable to make certain things that are currently means tested free, but just doing that does not actually buy you a single extra hour of home care or a single extra care home place. And as we look at the unmet need in social care, it's clearly very important that we get the second in addition to whatever the political process decides is the right answer on the first. So the first thing is the availability of sufficient social care in the round. The second thing I think we'd be looking for is that this not just be a debate around support for older people, particularly long-term care, but also recognises the very significant pressures in social care for people with learning disabilities and or autism, mental health services, which are around half of the budget for social care from local authorities. And so we've actually got to think about social care in the round, not just from the lens of my parents' generation.
It's interesting that your priority for social care, actually funding more social care, that could be said to be quite different from a priority that's about people not having to sell their homes to pay for care, which arguably is just giving them money to fund care they would have paid for themselves anyway.
Well, my point, Mark, is it absolutely could be both, and that's a choice for elected government to make, but it has to deal with the unmet need in social care as well as those other considerations as well, if we're going to, as Jeremy Hunt has rightly said, avoid some of the pressures on the NHS, as well as giving dignity in old age and responsive community services for other client groups.
And just lastly on social care, we've obviously had new migration proposals, which essentially mean that nobody could migrate to the UK to be an ordinary care worker. Does that worry you?
Well, we've got around 120,000 vacant posts in social care, and so we've got to join the dots. It is the case that if there is lower international employment in social care, there will need to be compensating funding for the extra pay pressures that social care providers will experience. These are all legitimate policy choices for a government to make, but you've just got to join the dots.
Extra funding that potentially wouldn't buy any more care, but really pay for more for the same.
Well, there are significant unit cost pressures in social care, and obviously the cost of being able to employ sufficient people is a main driver of that.
So let's talk for a bit about the Marmot review, the 10 years on Marmot review that came out earlier. It pointed to the fact that your tenure has been quite exceptional in some ways as a leader of the NHS, and that it's seen a slowdown or even a stop in a trend of improving life expectancy that went on for most of, or nearly all the NHS's lifetime up till now. How do you think that's affected the NHS while you've been in charge of it?
Well, nice try, Mark. Actually, Michael's timeline starts, I think, in 2010, 2011. And of course, when you decompose that, what you see is it's actually quite a kind of nuanced picture. Now, there are a whole series of things that Michael points to that will not have helped in terms of the wider determinants of health. But I also think it's worth looking at the work of the Longevity Sciences panel, who published this month as well. And they point out that actually it's a really complex picture comparatively when you look internationally, in that we have seen similar trends in some countries that didn't experience austerity. And the Longevity Sciences panel points particularly to Germany, which has obviously not had kind of macro austerity in the way that the UK has, and has had some of the similar trends. It also points to the fact that a number of the elements of the slowdown in the growth in life expectancy are actually attributable to things that happened to population cohorts during the 2000s, particularly obesity, some of the changes in cardiovascular disease risk status, and so forth. So I think, there is a puzzle here. There are some plausible hypotheses, but as both Michael points out and other researchers have said the same, really understanding what's happening around these life expectancy differences is still not completely nailed.
And so what are there actions that you would consider to try and turn that situation around, either from wider public services or actually from within the NHS?
Yeah, I mean, if you think about, and I know Chris Whitty this afternoon was talking about some of the sort of health risk factors and the sort of population health burdens, we can see what our future looks like on a number of current trends. I mean, we've got, in fact, figures out this week show that we've got just under 2 million people sort of pre-diabetic or at risk of type 2 diabetes. And we know there are certain things that the NHS can do. We've had about 250,000 people through the diabetes prevention programme. But frankly, our wider obesogenic environment, we are not making the changes needed in order to tackle that. So, even in the last few days, we've seen reports of increased availability of junk food outlets in many parts of the country, which is contrary to the stated goals in the Public Health England plan. We need, therefore, to tackle some of those if we are going to, looking out over the next decade, get off some of that escalator.
And do you think that's for public health in the sense of the kind of services that get funded through the public health grant, or is that for regulatory action?
It's a combination. It's going to be fiscal, it's going to be regulatory, it's going to be lifestyle modification support. And as I say, I mean, one of the programs I'm proudest of that NHS England has sponsored over the last several years has been the diabetes prevention program. Jonathan Valabji, Parthikar have done a fantastic job with that, reproducing and scaling an evidence-based program with RCTs in 5 countries, now getting better results for the reduction in type 2 risk than seen in those original trial studies. And we're scaling that from a face-to-face program to a digital program. Now, you could have argued that is something you could just have said is, it should be a matter for, public health rather than for the NHS. We said, look, we need to step up and play our part in some of that, but that's both and. That's not an alternative to some of the other measures that need to be taken.
Great. I'm going to finish with a couple of questions on general practice. I know we've got a lot of GPs and people interested in that in the room. So I'll start with a couple and then throw it open, and we can start there before all the coronavirus takes over. So first off, in our session earlier, a lot of people welcomed the pledge for 6,000 more GPs as well as the other types of staff. I think everybody agrees that that would be great. But obviously we had an earlier commitment in the DH's plan for the last 5 years for 5,000 more GPs. And in fact, numbers went down. So what's going to be different this time?
If you think about it, there are 3 moving parts essentially, so let's talk about each of them. The hardest to crack is the early retirement rate. The second hardest to crack is the sort of mid-career participation rate, and the easiest to crack is expanding the number of young doctors who choose general practice. Now, if we were having this conversation 4 years ago, you wouldn't have put them in that order necessarily. I mean, it has been a remarkable turnaround over the last couple of years that GP training numbers are the highest they have ever been, and we've seen that, and that's a tribute to HEE, to, I see Simon Gregory's here, to the RCGP, the GPC, all of whom got behind this campaign to explain that actually being a GP is one of the most diverse, important and future-proofed roles in an era when medical generalism is of increasing, not decreasing importance, and young doctors have responded to that. But the question is, for our mid-career GPs, how do we get sufficient flexibility? And for GPs in their 50s and 60s, how do we keep people engaged in the general practice workforce? Part of the answer to that is there light at the end of the tunnel? And so it's no accident that actually having another 26,000 non-GP primary care professionals as part of expanded practice teams, the resilience that primary care networks potentially create, the earmarked extra investment, those things are good in their own right, but they're also part of the sort of light at the end of the tunnel strategy. So we will have to get a combination of those three: retention, mid-career participation rates, and continued growth in the number of young doctors choosing general practice, which is a key part of the proposition, going, I think, from 3,500 to 4,000 or 4,000 plus GP training spots, plus an extended length in the vocational training scheme.
And then looking at the priorities for what you do with that hopeful expansion, final expansion in the workforce, one of the things that's got worse in general practice in recent years is continuity, the ability of people who want to see a preferred GP to actually see them. And there's quite good evidence that it is good for mortality, that it even helps to reduce hospital admissions. But would you accept the criticism that access has been a much higher priority than continuity over the last few years?
No, because I don't think that is actually the explanation for the decrease in continuity. The decrease in continuity is not because access has been prioritised or improved. Actually, the patient experience of being able to get a quick appointment to your practice has been steadily getting worse, and we've got to turn that around. The factor that most explains that continuity difference has been the composition of the workforce. And so, you know, if you've got a majority of in many practices, a majority of GPs in their 40s, 50s, choosing to work less than full time, together with the calls that the health service is placing on GPs in other parts of the service, you are not going to be in a situation where you had one doctor with a list available night and day throughout the year. And so that is the conundrum, that's the circle to be squared, essentially. How do you actually be a flexible employer, recognizing that people will want different options over the course of their career, want to be able to work part-time, and give some version of continuity? And there are a couple of ways into that. One, of course, is using segmenting your patient population for those for whom continuity actually matters, versus those who are actually presenting in general practice for a kind of one-off fix and off you go. And so in general, we've got to be more differentiated, I think, even if it's within the practice or the PCN. You know, the urgent care, primary care interaction is not necessarily the same as the long-term relationship and chronic disease management that you will have with some patients. I fully get there will be crossover before anybody says it, but by and large, you can be more differentiated. And the second piece is you can't just get continuity by virtue of the personal memory of the single individual who is your GP. You've got to find other ways of building that into the way the practice itself is organised.
Great. Right, I'm not going to follow up on that one. I'm going to throw it open to the floor. So I think we've got people with roving mics. Well, we've got at least one person with a roving mic. And she can move quickly. So, yeah, hands up. Let's, lady over here.
Thank you. Andrea Sutcliffe, the Chief Executive of the Nursing Midwifery Council. Nice to see you, Simon. And thank you so much for what you said about social care. I think that your leadership on that from NHS England's perspective is really great, particularly emphasising the importance of meeting unmet need and the broader groups that we need to support in social care in terms of learning disabilities and people with mental health problems as well as older people. But I just want to challenge you a little bit, as you might imagine. The issue for people using services, as I know from my own family's experience, is that the system is actually practically very difficult to navigate between health and social care and in and around that. And that the workforce issues are interdependent, and that's especially so for nurses. So a focus on 50,000 nurses for the NHS. You know, what does that mean for social care? And robbing Peter to pay Paul is not necessarily going to help. And we've got pressures and vacancies in social care as well. So I think Prana is doing an absolutely fantastic job with the people plan and the work and the focus on nurses and other aspects of that. But how can we join up the dots? How can we join up the dots when the NHS People Plan is an NHS People Plan, and some of the system issues are not really making as much of a practical difference at the sharp end as we might want for the people who are using services? Thank you.
Yeah, well, and thank you, Andrea, as well, because I think particularly when it comes to the nursing elements of this, the role that you are playing in helping the NMC be a sort of thoughtful and creative participant in the conversation about new routes into nursing and supporting the growth that we're going to need for the social care workforce as well as the NHS is absolutely essential. I mean, I guess at the heart of what you're saying is you can't just think about, you can't solely think about 50,000 nurses for the NHS. We've also got to think about the wider nursing workforce in social care and indeed go beyond nursing as well. And that is, I mean, we can't publish a credible people plan if it doesn't have budgeted investments in education and training that look across both sectors.
Okay, great. Let's have hands up again. Got the one at the back just there. Actually, let's have the woman next to Becky, and then we'll have Becky, I think.
Thank you. I'll probably ask a more controversial question here. But you've been sort of the chief exec for NHS England and NHS Improvement for a few years now. I kind of often wonder around policy when it comes to inclusion and around the decision makers. Now, you go into acute trusts, people that actually provide the care, and you look at trusts that are in specific areas like predominantly the demographics represent more of BME patients in those areas. I'll give examples of, let's say, St. George's Hospital, King's College, Barts Health. And if you look at the policymakers and the sort of the senior management teams, there's no representation of people, representation of the demographics of the people that they save. Now, you have things around diabetes, which we all know from research that it predominantly affects, people from BME backgrounds. Now, someone goes and tells my grandmother, for example, oh, you need to give up on carbohydrates. Someone who does not look like her, the first thing she will say is, who are you to tell me what I need to eat and what I shouldn't be eating? If I went and spoke to her, she will look at me and understand me at that level as well. Now, I think the NHS is missing a point here in terms of recruiting people in those areas and in senior management roles that will represent people that we save in the demographics in terms of management and reduction of waste around the services we provide. So diabetes, if we don't have people that represent a lot of the people that actually get affected by that, we'll keep fighting, we'll keep pumping in service, money into those services. It's not going to improve as much. You look at sickle cell, for example, only affects BME people. You look at the policymakers, none of them represents that. So, as a chief exec, and I know you're chief exec for NHS England and NHS Improvement, I don't know how much influence you have on acute trust. how would you ensure that we have
How much influence do you
enough
have?
people at that representation? Or how would you influence a policy around government, because obviously you are quite powerful, in terms of ensuring that there's that representation at the top? Because I kind of like struggle all the time with that. You know, you get at a certain level and then that's it. And then we are, you know, BME people, you get more of the disciplinary around, you know, you are more performance managed, you know, all those things. And, you know, you don't stay in jobs for a very long time. So, you know,
Brilliant.
That's why I said it's a bit controversial, but I think it's something that's been burning, and I think that's something we need to start tackling and looking at if we need to save money in the NHS.
Thanks. So we'll have Becky's question as well, and then we'll do a batch of two. I think that'd be good.
So Rebecca Rosen from the Nuffield Trust and a GP. So thanks for that, for your comments on continuity. I totally agree that the fragmentation of the workforce and part-time working has contributed, and that it needs to be targeted. Not everybody can have it, not everybody wants it. But I guess I would question your conclusions about how to address delivering continuity where it's needed. So the research that NHSE commissioned from Nuffield about continuity of care showed that it really needs to be designed into the way that you design and deliver your general practice services. And with the government very strong focus on rapid access, there is a significant risk that we highlighted that if you just focus on that, you will reduce your ability to deliver continuity and therefore lose the benefits for mortality, low referral rates, etc. So my challenge would be to maintain a focus on access to continuity where it is needed to reduce the risk that it is forgotten in the rush for rapid access that is the policy priority.
So do you want to do, should we do the question about the lack of minority ethnic representation?
Yeah. Sure. Well, yes, okay. So first of all, I think you made two very good points, not only about the importance for the NHS being able to, on a sort of fairness point of view as an employer, and being able to tap into the talents of all of the people, given we're the biggest employer of BME staff in the country, but your related point that actually this is essential if we're going to deliver accessible, high-quality services to the communities in which we're actually operating, and your sickle cell example was a great case in point there. So the question then is, okay, if that's the analysis, what are we doing about it, and are we going fast enough? Everybody here, I'm sure, knows about the Workforce Race Equality Standard. The most recent report of that, which is actually sort of lagged a year, was just published a fortnight ago. What that showed was that there has been no meaningful improvement in the experience of BME staff across the NHS, despite the fact that there has been an improvement in the reported objective HR measures, if I can put it that way. The core HR processes are working better in the sense of the chances of a white or a black candidate being shortlisted, the chance of a white versus a BME member of staff going through disciplinary, getting access to discretionary training. Those core HR processes are improving, but the experience of being a BME member of staff across the NHS has not. And part of that, of course, is where you then led us to, which is the sort of filtration of opportunity through the senior ranks in the NHS. That is true in management for boards. It's also true particularly actually in senior nursing ranks. And Ruth May is completely committed to driving change there, as is Jackie Dunkley-Bent in midwifery services. In terms of management, we've had a 30% increase in the number of BME senior managers in the NHS. We have got in London now a situation where every trust board has at least one, and arguably it should be far more than that, but at least one BME non-exec, which was not the case 3 years ago, pretty disgracefully. And what we are now doing is asking every employer, and this will be true for NHS England and NHS Improvement as well, to set an explicit, quantified goal for improving the proportion of our staff who are in the senior ranks in each organisation, and then measuring ourselves against that annually. So I think your point is well made. I think there is an energy behind this now, and I think we will have to be judged by the results over the coming years. On Becky's point, Well, I mean, I think I agree with you, Becky, really. All I would say is that I don't feel, and Nikki is here, Nikki Kanani, who's obviously leading the GP Access Review, and I know Nikki gets the point you just made, but I do think we've got to have both and. The fact is that when you ask patients, general practice is the foundational bedrock of the NHS, as we all know, 300 million patient visits a year. When you ask patients about their experience of general practice, there is a 13 percentage point difference in what people think about the practice overall versus what they think about being able to get an appointment. And if that gap remains there or carries on widening, then we will see people accessing other parts of the service with significant knock-on consequences. We've seen more than, I'm not attributing cause and effect here, but we've seen more than 1 million extra visits to A&E just in the course of the last year. Having accessible general practice is something we've got to get as a byproduct of the extra investment flowing into primary care.
Brilliant, thank you. Other hands up, we've got, let's have Andy Cowper, middle there. Is it about coronavirus? It's not. No. Oh, there you go. There's still one going begging.
Andy Cowper, Health Service Journal, Health Policy Insight. The Secretary of State set 2 goals in his speech today, and the first of those was to increase healthy life expectancy by 5 years by 2030. Is your estimation that that is practical, and if so, how will it be done?
Well, that is not a new commitment, I don't believe. I think that is been a stated objective of the last government as well. And in terms of how the waterfall chart that will get you there, a lot of the things that Chris Whitty was talking about are going to be the routes to those gains. There are some things that the NHS can do specifically. We are obviously leaning hard into cancer survival improvements linked to gains in early diagnosis. The cardiovascular disease standardised mortality rates, again, the long-term plan propositions around cardiovascular will give us a life expectancy gain. The question of multimorbidity and frailty, I think, is a critical one, which again is part of the dividend we will get from a resilient primary care infrastructure. So there are those kinds of elements that the NHS can bring to the equation, but clearly a lot of this goes back to the discussion that Mark and I were having around the wider determinants and the Marmot and other analyses. So healthy public policy is going to have to be a big part of this as well.
Okay, great. Let's have another Stephen Dorrell down the front. Raise your hand up.
Thank you. Simon, can I bring you back to Andrea Sutcliffe's question around workforce? I've been to Nuffield summits over some years and had a number of titles in the list of attendees. This year I'm here as the chair of the European movement, which must be a first for the European movement anyway. And the serious point I want to draw out from Andrea's question is that given the changes the government plans on migration policy, and given the sensitivity, in particular in some parts of the country, of the health and care workforce as a whole to migration policy, it seems to me, if I may say so, that the answer to Andrea's question needed to be a holistic view across the health and care sector, not just around training, but also actually almost micromanaging, certainly watching pressure points emerging over the next few months, because changes in migration policy could be a significant short-term impact or have a significant short-term impact on the sector seen as a whole.
Yeah, I mean, we're going to need to continue international recruitment, including for nurses, but other health professions as well, for some time to come. Because given the lead times in expanded undergraduate nursing, hopefully further medical school expansions, I mean, that is just a statement of the obvious. Now, the good news is that when you ask people what sort of international recruits do you think it would be good for the country to have, people are very aligned with the idea that ethically sourced international health professionals are a good for the health service and for the country. So I think that is a an argument that we are being heard on.
Great. Okay. Got time for another round. The man in the middle there at the table in front of Sarah Scobie.
Thank you. Jihad Malassi, Clinical Chair for Thanet and GP in the Ramsgate-Margate area. First of all, I wanted to thank you for the appointment of our accountable officer for the area. Thanet CCG will be defunct now and be part of a larger 8 CCG grouping, which I think is positive. I have 3 questions, if you wouldn't mind. One is about coastal inequalities and the regulatory and organizational environment that you spoke about in relation to how we change high streets, how we change people's eating habits, smoking, and so on and so forth. That's not an easy thing to tackle from a health perspective and requires a system perspective. So what pressure can be brought to bear, and what are your views on that? The second point is around reconfiguration, and you were quoted in 2014 regarding the value of DGHs, and I'm wondering if your position has altered or moved with regard to noises that have been made by local MPs and so on, Helen Whatley MP. And finally, regarding...
I think 2 questions might be... We're getting
go on, we want to know what the third one is. Come on, let's...
All right, really quick third question. Just whack it out there.
It's a vital question to me. I feel passionately about this. It's about primary care estate. Now, we've heard a lot about primary care estate and how that cuts through a lot of the stuff that we've been talking about today. Now, it's fine I'm also clinical director for the hospital reconfiguration work, and we're putting in a bid, et cetera, so I'm not prejudging any of that stuff. With regard to primary care, we are investing money in primary care estate, but we want something that's a bit whiz-bang, a bit Whitstable, a bit, and I know you've been there.
Absolutely.
And so we're talking about non-GMS space and how you can actually get third sector providers to play a role in that, but they're not hefty enough financially to take a role. So somebody has to make a decision about whether that money can be offered or whether security can be offered to organizations that don't have the scale or the ability to take on that kind of space. And I'm wondering what the view is on that and how that can be supported.
Right. Okay. Well, on your last point, I mean, in a sense, you have become you're a more scaled operation across East Kent now, I suppose. There are parts of the country that have got good models for what that looks like, and so I think, frankly, mutual learning is part of the answer to that. There's a whole set of issues around the way NHS Property Services works as just a sort of side discussion in this context. But I think that there are answers to be had there. On the high street, local authorities have got a sort of principal role here. There's a debate around the licensing powers that local authorities have, but 4 out of 10 local authorities have seen an increase in the number of junk food outlets, whereas in aggregate we were looking for a reduction. In some cases it's an increase of over 1/3 in the number of junk food outlets. So there's a real kind of issue there that has got to be tackled, and councils are probably the best placed to do that. But as far as your sort of middle question was concerned, no, I still believe that district general hospitals have got a very important role to play. I'm not one of these people who believes that the future of the NHS looks like sort of, just 20 kind of huge mega hospitals with people travelling miles for them. And I think, in fact, some of the trends we are seeing quite recently further reinforce that. So I said last June that it looked as if, given the rising pressures in hospital, some of the reductions that had been seen in the number of hospital beds, that trend, we shouldn't assume that trend would just sort of carry on indefinitely. And I think actually we are at an inflection point on that. Figures published today show that for the third quarter of the year, October to December, we've had the biggest increase year on year in hospital beds that we've had in a decade since the records began. And I think we're going to need more inpatient capacity. The fact that we've got over 7,000 extra nurses working in the NHS over the past year has helped with that. So look, I think we will need that. That doesn't mean, however, that when you look at particular services, there may not be advantages from divvying them up differently. And there's obviously been a judicial review contested in East Kent on stroke services, which the CCGs have won decisively in the courts, and there's a very strong patient reason for why you would want to make some of those changes.
Brilliant. We actually haven't had our coronavirus question yet, so does anybody want to go?
Well, Chris is got his hand up.
There we
so
go.
maybe,
I knew our nation's press
could be coronavirus table over there, actually, looking at some of the characters who are...
So we've heard a bit about plans for if we do get a pandemic, because we're not there yet. There's been some talk about how do we have the capacity to cope with this, particularly in critical care, how decisions will be made about prioritising resources if that happens. Given that the pandemic plans talk about the importance of openness and transparency in making these decisions, can you tell us a bit more about exactly how that will work if we do get a large number of cases in this country?
Thank you, Chris. Well, look, the first thing to say is an enormous thank you to our colleagues across the NHS who have been stepping up their work dealing with the inquiries, the testing that has been going on over the last several weeks. I also particularly want to thank colleagues from Arrow Park on the Wirral and in Milton Keynes for looking after those who came back and were quarantined. We are seeing big increases in the number of inquiries that 111 is getting and ramping up staffing there. And today, in fact, are rolling out new ways of testing based on home testing and drive-by testing, which we're probably going to need more of. So the NHS is clearly ramping up. The scenarios that we're dealing with are being looked at by, to answer your question specifically, Chris, the Scientific Advisory Group on Epidemics, SAGE, and a related group that does the EPI modelling. They will be providing the scientific advice to government, supported by our work and that of Public Health England. We've seen within the last 36 hours some of the sorts of measures that the Irish government have set out on sports fixtures. I think Chris Whitty this afternoon has talked about the possibility of schools closures, but those are all recommendations that will have to come from those expert bodies for government to consider, and they will need to be proportionate. But in the meantime, there are a set of very practical things that we all need to carry on doing around hand washing and around the way in which we dispose of catch it, kill it, bin it type processes. So there are things we need to do, there are things we need the experts to advise on, and there are things the NHS is doing to act in the here and now and to prepare.
Right, I think we've got time for exactly one last question, as long as it's a reasonably quick one. So any hands up? Sean, I'll let you go for it. Is it about coronavirus? Oh, really quick then, go on.
Hi, Simon. I just wanted to follow up on Chris's question there. And you eloquently talked about the other things that are being done and the advice you're going to get. But you're responsible for the provider sector and the hospitals right now, thinking how they will cope with a pandemic coronavirus. ITU consultants told us that they were very, very concerned about how they have a complete lack of capacity and would have to make some very difficult decisions using the Three Wise Men protocol. So I think... can I ask you to expand a bit further specifically on how NHS hospitals would have to cope if we had a serious pandemic outbreak?
Well, the sort of medical insight on this particular condition is continuing to develop. There's good information sharing worldwide. The protocols you're describing, Sean, I think relate back to 2009-10 and to influenza. So that will be a responsibility for the Public Health England and the other clinical experts to advise us and government. But in the meantime, as I say, the key thing that people are giving thought to is there a way of, which there likely is, reducing the intensity, the pressure on the NHS through some of the wider public measures. And that's where the focus of advice to government is likely to be over the coming days.
Right, I'm afraid I'm going to stick to that being our last question because we are a minute over time. I think all that remains is for me to thank you, Simon, for answering such a wide range of questions, and everyone to give a bit of applause to Simon for coming out here and joining us.
Thank you.